on their insured. So when they find something that is less than what they require, they are not satisfied. Or that may also explain what is found in the financial satisfaction. When they are told that they have to pay for some services, when they already have the mentality that their services are supposed to be free, they tend to be dissatisfied. But uninsured patients...
You have less than 1 minute to round up. Yeah.
Okay, sir. So for key predictors, like we discussed, we said that age, education, and marital status are strong predictors of satisfaction. Insured patients value communication and time with doctors, but accessibility is most important. For uninsured, accessibility is a key factor, while technical quality and financial aspects negatively impact satisfaction. So in conclusion, the study revealed significant difference in patient satisfaction across the subscales used. Insured patients reported greater satisfaction with time spent with doctors and interpersonal manner. Uninsured patients showed higher satisfaction with accessibility and technical quality and financial aspects. No significant difference were found between the communication and general satisfaction between both groups. And like we said, age, level of education, marital status are key predictors of satisfaction. And among insured patient, communication, time spent, and accessibility had strong impact on satisfaction, while among uninsured, accessibility had a strong association. Thank you very much. These are my references.
Thank you very much. You can have your seats. We'll take all the presentations before the questions will come after. Our second presenter. Do we have the online presenter ready? Okay. It's 44. Yes. Okay, we don't know on Zoom what day. Okay, that's fine. So the next presenter, I think, is the person with perceived effect. Yes. Okay, good. So the title is Perceived Effect of Occupational Safety Measures on Workers' Performance in Warri Refinery. I guess that is what it is. And Petrochemical Company, Delta State, Nigeria. Please, you can go ahead.
Slides.
Media, can we have the slide up?
044.
Let's have his presentation.
44. 44. 44.
I mean, sorry. No, 044.
Yes.
Good morning, sirs. Good morning, Mass. Standing on the existing protocol, I will be presenting on behalf of our team a study titled Perceived Effect of Occupational Safety Measures on Workers' Performance in Warri Refining and Petrochemical Company, Delta State, Nigeria. I am Dr. Adeyemi Akinmamuda. So using this outline, we'll be discussing our study. As a background, it's been established that management of safety and health is a key component of the oil and gas industry operations. And workers in this industry are particularly more vulnerable to experience some occupational accidents due to the nature of the industry and the difficult working conditions. As of now, it's a known fact that the oil and gas industry remains the mainstay of our Nigerian economy. Despite several national and international safety regulations, several cases of injuries and death related to workplace exposure have been recorded in Nigeria. So, some of the factors that contribute to this include equipment failure, supervisory failure, negligence, and violation of safety ethics. There have been several literature reports on various degrees of fatalities experienced by workers in oil and gas industry. There have also been reports on risk and perception of workers on their workplace environment. And also, we've also had established the reports on relationship between workers' perception of their workplace environment on their job satisfaction and productivity. However, what seems to be sparse in the literature that motivated this study of ours was that how workers themselves perceive the effect of these safety measures on their individual and organizational performance is actually very sparse. So therefore, our study assessed three major things: how the workers perceived the implementation of existing occupational health measures in their organization, and also how these measures were perceived to have affected their individual and organizational performance. And also, this study also identified factors associated with their perception. So the study setting was a Warri Refinery and Petrochemical Company in Delta State, Nigeria. It was a descriptive cross-sectional study design. The study conducted the survey among 283 participants across 19 different departments of the company, using proportionate sampling to size according to the department and also the cadres of staff. Then the participants were selected by a simple random sampling technique, and we used a structured anonymous questionnaire. Outcome variables include perception of the respondents on the effect of occupational safety measures on their performance and the level of the perception. So the data was analyzed using SPSS version 25. The factors associated with the perception were determined using appropriate statistical tests with p-value set at less than 0.05. Approval was collected from the WRPC Ethical Committee, and the verbal informed consent was obtained from each of the participants. The confidentiality was assured throughout this period of the survey. So this table one shows the socio-demographic characteristics of the respondents, and 64% of the respondents were male. More than 60% of them actually were aged above 43 years. Majority of them were married. Majority of the respondents actually had postgraduate educational qualifications, and the 57.2% of them had spent above 20 years in service, whereas the majority of the respondents were actually senior staff. So in terms of the perception of the respondents to how the safety measures were implemented at their company, so we each of the respondents had multiple choices to make among the list of questions asked. But what 78% of the respondents actually said they agreed that they had access to safety tips in appropriate measure within the company. Then also the 90.2% of the workers actually agreed that workers are forced to participate in workplace safety activities that preserve their well-being. It's hanging. Sorry. Okay, so thank you very much. So 92.8% of them agree that the occupational safety measures in the workplace have helped to enhance workers' performance, whereas the 56.8% of them agree that neglect of occupational safety will further lead to high rate of labor turnout. So this is a table illustrating the factors that were associated with the workers' perception of the effect of occupational measures on organizational performance. So in terms of the occupational safety measures in the workplace, how these measures affect or enhance the organizational performance, those who had spent more than 20 years at the workplace actually agreed that a proportion of those who had spent at least more than 20 years at the service was 78% compared to 55.4% of those who had spent at least less than 20 years and below. And the relationship is actually, the association is actually significant. Then also the senior staff had agreed more that operational safety measures at the workplace enhanced their organizational performance was more than the proportion of the junior workers who agreed that the safety measures enhanced their organizational performance, and the association too was also statistically significant. However, on the converse is true for the question on the neglect of occupational safety, whether or not it will lead to whether or not it will lead to high rate of labor turnout. It is those who have spent 20 years and below that had a high proportion of them actually agree that if there is a neglect of occupational safety, it will lead to a high rate of turnout, and that was 89.1% compared to 69.6% of those who had spent more than 20 years who agree that it can actually lead to a high rate of turnout, and the relationship was actually statistically significant. Similarly, for those who had the junior workers, 92% of them agreed that if there was a neglect of occupational safety, it will lead to a high rate of turnout, labor turnout, compared to 89.8% of the senior workers who agreed that the neglect could lead to further a high rate of labor turnout.
You have less than 2 minutes to wrap up.
Okay, thank you, sir. So we want to discuss our findings and our key findings from other objectives, other studies, and also we make our remarks. From our study, 92.8% of the respondents were aware of occupational safety measures. So, and this is also consistent with other similar studies. And this is, our remark is that this is an encouraging finding for the management of this organization. Also, our study also found that more senior and management staff perceive the occupational measures to enhance organizational performance. And this was also consistent with other findings in the literature. And this may be partly explained by the fact that the educational status of those who have spent at least 20 years, more than 20 years in service, and also those who are senior staff, was higher than those who were junior staff. Also, the closeness of these senior cadre staff to the management will also be partly responsible for this finding. It was also found that a higher proportion of the junior workers and those who had spent 20 years and below perceived that had a perception that if there was a neglect at their workplace, it can actually lead to high rates of turnout. And this is also similar, very consistent with findings in the literature. And this is a remark here was that the junior workers may be more conscious of the hazard they are being exposed to because they are daily getting exposed to this hazard at their workplace. So in conclusion, we want to conclude that the majority of the respondents were aware of occupational safety measures at the workplace and perceive that these have been well implemented at the organization. It was also found that a higher proportion of the senior staff and those who had
study design was utilized as well. The sample size determination, Cochrane formula, as shown above, was used, with 10% used to account for the non-respondents, and the total number of minimum sample size was 416 students. The sampling method used was the multi-stage sampling method, where simple random sampling by balloting was applied to choose the 5 female and 5 male halls. Then the systematic sampling method was then used, where simple random sampling was used to select the first room and the sampling interval to select the subsequent rooms. In each room, simple random sampling was also used. For data collection, data collection is as shown, ethical consideration via BOREC. For the results in table 1, it is shown that the majority were aged less than or equal to 20 years. Most respondents were female. Of the 300 level of study, majority of respondents were Christian and they were also single. From table 2, we can see that 244 respondents had good knowledge on food safety, while 41% had poor knowledge. From table 3, we can see that 295 of the respondents had good practices and 28.7% had poor practice. From table 4, logistic regression shows that there is a statistically significant relation between the knowledge of food safety and hygiene and marital status. For table 5, it shows the relationship between the level of study and the practice of food safety and hygiene. So from discussion, the population is young, predominantly female, also in their 3rd year. This also shows us that there are certain targeted interventions that we are to apply in solving this particular issue. For instance, the knowledge shows that although a good proportion had adequate knowledge, there is still a significant proportion of people who do not have adequate knowledge. So we're to bridge this gap. The practice shows us that we are also to bridge this gap by assessing certain aspects of this food safety and hygiene. Then in conclusion, the findings from this study show that undergraduates have a fair knowledge on food safety and hygiene with a higher level of practice of food safety and hygiene. It's then recommended that schools include educational programs on food safety, plan awareness campaigns on foodborne illnesses, implement strict hygiene standards to provide adequate food storage facilities for students in order to improve their practices and reduce foodborne illnesses and risks among students. These are my references. Thank you.
Thank you very much. Let's have the second presenter quickly, or the next presenter, not the second. 096. That's knowledge, attitude, and practice of modifiable behavioral, non-communicable disease risk factors among undergraduate students. Okay. Prevalence. Okay. Prevalence pattern of disorders. I think there's something in here. Okay, that's what is here. What we have here is not complete. The title is not complete. You can go ahead, please.
Okay. Good morning, all. My name is Josh, and I'll be presenting on behalf of the team the prevalence pattern of eating disorders and associated health risks among Babcock University students. Sorry, I'll be following this outline. And then the background, eating disorders have been in existence since time, but unfortunately they have emerged as a global health concern. So despite the increased prevalence and the serious consequences associated with it, it remains underdiagnosed and undertreated. So the prevalence of eating disorders has greatly increased, with females being twice as likely to have them as males, and these are due to various factors like biochemical, psychological, and other factors. So the eating disorders affect 2.7% of adolescents aged 13 to 18, with prevalence increasing with age. Girls as young as 6 to 10 begin worrying about their weight by the age of 14, and 60 to 70% attempt to lose weight. Okay, so the general objective, this study was done to assess the prevalence and pattern of eating disorders and risk factors for their development among Babcock students. It was to determine the prevalence, pattern, and the risk factors that predispose to the development of said eating factors among Babcock students. So a descriptive cross-sectional study was conducted among 242 students, and data was collected using a semi-structured questionnaire adapted from the eating attitude test and SCOF questionnaires, and there was a response rate of 100%. So the mean age of participants was 19.81 with standard deviation of 2.079, and the respondent pool was predominantly female, with females comprising of 58.3% and males 41.7%. So the findings indicate a significant association between the self-perceived eating habits and the risk of developing eating disorders, such as sociocultural factors, psychological factors, biological, and others, like I mentioned before. So the eating disorders participants have been diagnosed with anorexia nervosa, bulimia nervosa, while 58.3% showed negative responses to binge eating disorders. And then some of the respondents correctly identified to showing some of the behavioral eating patterns, such as fear of gaining weight, consuming large amounts of food in a short period of time, and constantly stressing about food and gaining weight. So in conclusion, the study highlights the high prevalence of eating disorders among Babcock University students and underscores the need for targeted interventions to promote healthy eating behaviors and mental well-being. Addressing eating disorders in this population is essential for improving overall health and well-being. And then these are references. Thank you very much.
Thank you. Please, in as much as we're trying to manage time, I think you should give us, some quality presentation. Don't be rushing them from there, so that we can follow and understand. That's why we're here. But just make use of your time very well. Thank you. Next presenter. IT, which one is ready? Please, which one is ready, please?
We're supposed to have 96 and 99.
knowledge and perception of fathers on the use of oral rehydration solution in the treatment of childhood diarrhea among university employees.
Good morning, everybody. My name is Osaya Dana. I am a medical student. Good morning, esteemed panelists and my distinguished audience. So my topic is, knowledge and perception of fathers on the use of oral rehydration solution in the treatment of childhood diarrhea among employees in a private tertiary institution. So this is my outline. So starting from the background, diarrhea has been noted to be a major cause of mortality in children under 5, and it, by UNICEF is said to account for 9% of mortalities. This is usually due to the risk of complication of dehydration, and as of which oral rehydration therapy was introduced by the WHO to address this problem of dehydration. And according to the Nigerian National Health Policy, they recognize men as the head of the family, and as of which they are involved in making health-related decisions in the family. So, statement problem. Many factors have contributed to the low rate of utilizing the ORS in the treating childhood diarrhea in the family, and as of which a major role is caregivers, as they are the ones that administer this solution. So, most studies outline the effect of mothers on their knowledge on diarrhea, but they never emphasize properly the role of fathers, and as of which paternal involvement is noted to involvement in childcare is noted to be suboptimal in different developing climes in Nigeria. So, justification. Only a few studies have been found to show adequate knowledge of utilization of the ORS in treating childhood diarrhea among fathers in developing countries. And previous studies conducted in northern and southern Nigeria, parts of Nigeria, show a wide range of knowledge on use of ORS in management of this childhood diarrhea among caregivers. If more men are knowledgeable about the use of ORS in childhood diarrhea, there will be reduced rates of mortality as well as morbidity and generalized benefits for the nation. So our objective is it aims to assess the knowledge, perception, and factors associated with knowledge and perception of, and factors associated with perception of male employees in a tertiary institution on the use of ORS in treatment of childhood diarrhea. So, methodology. So, this was a cross-sectional study done at Babcock University, a private tertiary institution, and it was carried out among 200 male employees, of which they were selected using purposive sampling method. Healthcare workers were excluded due to the fact that they could bias the study, and we also made sure to pick at least men that had at least a child below the age of 5. Then data collection was done using a pre-tested semi-structured interviewer administered questionnaire. And then data was cross-checked and entered into the SPSS software, version 24, and chi-square and composite variables were done to assess calculated for knowledge and perception as well, with level of significance set at 5%. Ethical approval was gotten from Babcock University Health Research and Ethics Committee, and written informed consents were given to participants. So, for the results, the study revealed that the mean age of respondents was 36.69 plus or minus 7.82, and most respondents had tertiary education as their highest level of education. 67.7% were married, while Christianity is the most practiced religion, and Yoruba ethnic group having most representation. There were a diverse range of professions found, but of which homekeepers were the highest percent, followed by accountants. The study indicates that 96.5% of respondents have heard about diarrhea in children, of which 80.8% report that their children have had experienced diarrhea. With regards to severity, 85.4% consider it a serious health issue. Studies also found that 89.4% have heard of ORS. Among those aware of ORS, only 45.5% first learned about it from healthcare providers, while 36.4% for family or friends. 61.3% also know how to prepare ORS. Then majority, that is 71.2%, have used ORS to treat their child's diarrhea, and among these, 55.6% occasionally have used it. Factors influencing the decision to use ARS include ease of use, which being the highest, while cost being 31.3%. Most respondents had good knowledge, 89.9%, while 10.1% were reported to have poor knowledge about use of ORS in treating childhood diarrhea. More than half, 52%, had a good perception of childhood diarrhea, while 48% had a poor perception. By various analyses showed that the level of education and occupation were significantly associated with knowledge, while occupation, marital status, and religion were significantly associated with perception. So, this study revealed higher proportions of participants were found to be Yoruba and Christians. This may be due to the fact that the university is located in a Yoruba state, and the institution carried out is a Christian-based institution. A majority of respondents had tertiary education. This would also be due to the fact that majority of them did work in a private institution that is a university. Then there was a statistically significant association between education and knowledge of ORS, which agrees with the report of a direct relationship between the two variables. Currently, married men have better perceptions, which may be due to the influence of their wives. So in conclusion, the study highlighted the level of knowledge and perception of fathers on the use of ORS in the treatment of childhood diarrhea among male employees of a private tertiary institution. The results showed that most respondents had a good knowledge and perception on the use of oral rehydration solution to treat childhood diarrhea, and these have direct associations with their level of education and marital status, respectively. There's a need for a tailored intervention to enhance male knowledge, such as improved health education programs. Thank you. This is my references.
Thank you. The last presenter for the day, IT. Zero 99.
Good morning, Chairman. Good morning, members of the I-Table. Good morning, audience. My name is Faponda Oluwabusola, and I'm presenting on the behalf of this team on the topic, knowledge, attitude, and practice of modifiable behavioral, non-communicable disease risk factors among undergraduate students in a private tertiary institution in Southwest Nigeria. So this is the outline. So, non-communicable diseases are chronic non-infectious diseases that progress slowly and cause 74% of global deaths, with 77% occurring in low and middle income countries. So risk factors are non-modifiable, which are risk factors that cannot be changed by intervention, or modifiable risk factors that can be changed by intervention. So non-modifiable risk factors are age, gender, and genetics, and types of modifiable risk factors are unhealthy diet, physical inactivity, tobacco smoking, and alcohol. So WHO emphasizes that most NCDs are preventable with lifestyle and environmental changes. So the statement of problem. So as I've said before, they are non-infectious and non-transmissible. Though they are more common in middle to late adulthood, the risk factors often develop in adolescence. Research shows that 70% of premature adult deaths stem from behaviors established in childhood and adolescence. So the Global Burden of Disease Study 2019 found that NCDs cause 38.8% of deaths among individuals aged 10 to 24 years. So the justification. So this study aimed to determine the number of undergraduates who are aware of these modifiable risk factors, and it also aimed to improve the prevention by informing the students about modifiable risk factors, enabling them to make healthier life choices, and thereby reducing the risk of non-communicable disease. Thereby, this will also reduce the health costs and the burden of NCDs on the health system. So the objectives were to assess the level of knowledge, to assess the level of attitude, to assess the level of practice, and to determine the factors associated with the knowledge, attitude, and practice of modifiable behavioral non-communicable disease risk factors among undergraduate students. So the methodology. So the study design employed in the research was cross-sectional study, and the respondents were undergraduate students of Babcock University, and the sample size was 410, and a multi-stage sampling technique was adopted in the study. The data collection was done using questionnaire, and the data processing and analysis were done using the IBM SPSS V24 software. Okay, so a scoring criteria was used as below. Knowledge was 12-point scale, attitude was 45-point scale, practice was 5-point scale. For the knowledge, above the mean showed that they had good knowledge about the non-modifiable risk factors, and below the mean showed they had poor knowledge of it. Then attitude, above it showed they had good attitude towards non-modifiable risk factors, while below mean they have poor attitude. Then practice showed, above mean showed they had good practice on the risk factors, and below showed the output practice. So ethical approval for this study was requested and obtained from the Babcock University Health Research and Ethics Committee, BUREC, and the participation was voluntary, confidentiality was maintained, and informed consent was obtained before participation. So these were the limitations of the study. There were potentially low response due to academic breaks between the collection of the responses, unwillingness to participate, possible inaccuracies in self-reported responses. So this is the summary of the result. So majority of the respondents aged between 15 and 20 years, and Christianity was the most practiced religion. Yoruba and Igbo ethnicity were of nearly equal representation with 47.6% and 47.8% respectively. Majority were Nigerians, and in regards to gender, majority were females, and most of the respondents were in 400 level, and psychology was the most common course. Then it also indicates that 57.5% of the respondents have never heard of non-communicable disease. While 50% correctly identified non-communicable disease as chronic illness not caused by infectious disease, while 52.2% recognized avoiding tobacco can help prevent NCDs. Furthermore, 62.4% agree that avoiding alcohol reduces NCD risk, yet 64.4% believe second-hand smoking is harmless. So regarding attitude towards non-communicable disease risk factors, 17.7% had positive attitude that regular exercise helps. So also, the study found that 88.7% of respondents currently use tobacco, and 81.6% have used it in the past, and only 37.6% engage in daily physical activity. Then alcohol consumption is notable, with 79.5% drinking regularly and 79.8% engaging in drinking. Health-seeking behavior is relatively good, with 85.2% undergoing regular medical checkups and 76.2% getting at least 6 hours of sleep daily. So the bivariate analysis showed that religion and level of study significantly influence the knowledge of modifiable behavioral risk factors for NCDs. Additionally, age and nationality significantly linked to participants' attitude towards modifiable behavioral non-communicable risk factors. Lastly, nationality and sex were significantly associated with participants' practice of modifiable behavioral non-communicable disease risk factors. So the discussion point. So this study aims to determine the number of people who are knowledgeable about the non-communicable risk factors, and also aims to improve the prevention by informing the students about the modifiable risk factors and enabling them to make healthier lifestyle choices. So student health promotion reduce healthcare costs can help minimize the burden of NCDs on healthcare systems and society by promoting prevention and early intervention. So in conclusion, the results showed that most respondents had poor knowledge, poor attitude, and good practice of the modifiable behavioral non-communicable risk factors. So these are the references. Thank you.
Round of applause for all the presenters. Thank you very much for your attention. So I'll call on the rapporteur to sum it up for us, summarize all the presentations. Thank you.
Good morning. Thank you, the presenters. The first presenter that we had, patient satisfaction with healthcare, a comparative study of insured and uninsured patients at the teaching hospital in South Nigeria, Dr. Harriet. The background was justifiably delivered. Everyone is entitled to health care as a citizen, either insured or non-insured. The problem statement, the insured patients have issues of non-availability of drugs, and the justification for the study was stated that there were gaps identified in service delivery, mostly among the NHIs and the insured patients. The study was to determine between insured and uninsured, some factors were highlighted. Time spent with the doctor, satisfaction was graded based on that. The time spent, the availability of drugs, and some other factors. Then it was a analytical cross-sectional studies. A semi-structured questionnaire interview administered was used for the study. Then the result. I'm so sorry. Then the result, yes, communication, time with doctor, interpersonal manner with which the healthcare providers attended to them, accessibility, and some other factors were considered, general satisfaction, communication, and overall, the male participant, okay, accessibility was found to have a positive effect on patient satisfaction, while the technical and the financial part has a negative effect. In conclusion, no significant difference was found, and only accessibility was strongly associated with the level of satisfaction. Thank you. Then the next presenter, perceived effect of occupational safety measures on workers' performance in Warri Refinery and Petrochemical Company, Delta State, Nigeria. Presenter Dr. Adeyemi. The background was delivered, and factors associated with their perception were also highlighted. The tool uses the structured questionnaire, and the findings were so numerous, but I'll just rush through. Access to safety measures. The study actually considered staff that have spent over 20 years in service and considered those that were under 20 years in service. And from the result, it was shown that the senior staff who have spent over 20 years in service had more awareness, and their perception was actually good, better than those that have spent less years in the service. Then we go to the next presenter. Sorry, I didn't know I would have much of this. Perception and satisfaction with childhood immunization services among mothers attending immunization clinics in Kwara State, North Central Nigeria. Dr. Adedayo. The background was delivered, a success story of immunization was told, and problem statement was highlighted. 3 million children dies of childhood immunization preventable diseases yearly. The justification for the study, EPI is still poor in Africa, despite the knowledge and the awareness that we have. The objective of the study is to determine client satisfaction. A cross-sectional study was conducted. The tool was semi-structured interview administered questionnaire. The result. Too many vaccines, after the factors were highlighted, it was found that some others believe that too many vaccines were not good for the children. Satisfaction level was 99.3 overall. Short waiting time too was a good one, 93%. Waiting area, 95%. Conducive waiting area, 94%. Attitude of workers, 98%, like that. High level of satisfaction was overall. Okay, ma'am. Okay, in summary, effective service delivery was found from the study, despite some misconceptions that still needs to be worked on. Then the predictors of adolescent reproductive health services experience among in-school and out-school adolescents in Owo, local government, Nigeria. Problem statement: 1 in 3 children are out of school presently. The objective of the study is to determine the factors associated with adolescent reproductive health services, awareness, experience. The findings: age, parental factors, social class, the predictors were highlighted. And in conclusion, need to improve awareness. Policy and advocacy is necessary in ensuring that these adolescents are well taken care of, combining school-based initiative and community-based services as well. Now, to determine This is another study to determine the prevalence of antibiotic misuse among patients attending primary health care facility in, something is missing there, of Plateau State, Nigeria. Okay, ma. Okay, ma. Now, the findings from the study.
Okay, let's just have the other titles.
Okay. Knowledge of food safety and hygiene among undergraduate students in private universities in southern Nigeria. Food hygiene and safety was highlighted. Justification for the study: education of youth will enhance safety and hygiene practices of food. And the study was to determine the knowledge and the awareness of the students in private institutions. The findings, there's a statistical relationship between knowledge and marital status. I was wondering, the students. Okay, and in conclusion, a fair knowledge of food safety and hygiene among undergraduates was recorded. More awareness and provision of storage facility is advocated for. Then prevalence and pattern of eating disorders and associated health risks among Babcock University students, delivered by Dr. George. Objective is to determine the prevalence and pattern and risk factors associated with eating disorders among the students. And the findings: there's a significant association between the perceived eating habit and the awareness of the students. They highlighted some points: fear of gaining weight, some eat abnormally because they don't want to gain weight. In conclusion, a high prevalence of eating disorder was found among students of Babcock University. So more advocacy and more awareness creation is advocated for. Knowledge and perception of patients in the use of ORS. Okay, knowledge and perception of fathers in the use of ORS in treatment of diarrhea among university employees in Nigeria. The background was delivered: diarrhea, major cause of childhood mortality in Nigeria. Men are heads of homes and they are expected to be part of the treatment. The problem statement was delivered: knowledge and perception. The objectives was to assess the knowledge and perception of fathers about use of ORS in treatment of childhood diarrhea. The two were the semi-structured questionnaire. Findings: majority are aware of ORS, but not using it. Then the factors affecting use is, among others, ease of use. It's so easy to use, low cost, availability.
Thank you. We need to take questions and answers for this session. Thank you.
Okay, thank you very much. So we'll open up this session for question and answers. Let me give my co-chair.
Thank you very much. I think we need to do this fast. If you have questions, comments, just indicate by raise of hand, so I can get numbers. Let's see. Okay. So you are number 1, 2. Please, can you raise up your hands properly? So you're 1, 2, 3, 4. You're 4, the first 4, 5, and 6. In that order, please. Can we have someone help us? So we'll start over there. So make your questions brief, straight to the point. And if your comment has already been raised by earlier commenters, so you don't need to say anything so that we can work with our time. Thank you.
Good morning. Just a very quick one to the fabulous presentation on patient satisfaction between the insured and uninsured. The uninsured had access. It was clear that they had access to the healthcare providers, but the insured had better time. So one would have loved to have seen on the last slide the thought processes of the authors, a recommendation moving forward. What did they think could marry these two findings? If the persons who were uninsured and paying from out of pocket had access, better access, while those who were insured had more time, how then do you marry those two findings and get a simple, straightforward recommendation on this? We're talking about patient satisfaction. Thank you.
Thank you. Next person, please.
Okay, good morning, everyone. Chundung Minor, Plateau State Branch. I'll first like to commend quite a number of the students that I saw presenting. I think it's a good start for them, and I would like to hope that they would going forward, they would also be introduced into manuscript writing so that they can move on from there. So just to a general comment for quite a number of the presentations. I know many of them were students, but I think the slides were a bit too crowded, and quite a number of you were going so fast, as the chairman pointed out. So we were not able to follow some of the presentations because the presentation was too fast for us, and even the PowerPoints were too crowded for us to pick out information that we were interested in. For the one on food safety, I would like to say that the justification, because the study was among students, so in your justification you were saying that many of them had not had food safety training, you know, and all that. And I was like, well, we also have not had food safety training at that level, maybe because now we are in medicine and in public health we may have been trained, but I think you should have, I'm not sure that was a good justification, considering that you're not dealing with people who are in the industry for food. Then, so because
Recording
of that, I thought that the components of knowledge should have been itemized for us so that we see that what you're looking at is commensurate with the population that you are studying. Then for the one on pattern of eating disorders, that one was really fast. I couldn't pick anything. I'll be grateful if you could tell us a little about your results. One, how many overall had eating disorders? And then what were the percentages for the different types that you were assessing? I think that will help some of us who couldn't catch anything that you said, because before we could put our head up, you had finished presenting. Then the one for fathers, your justification was also a bit weak. I thought you needed to lean more on the fact that, you know, they are like gatekeepers in homes. So maybe you need to look at that. I don't want to go into it. And then also I felt the population was biased because they are educated people, and then you're in a university environment, you know, where they have quick access to quite a number of medical facilities. A lot of health education goes on there and all that. So I was wondering if that would, you know, if you could, I felt it was biased right from the onset. And then what did you mean by good perception of diarrhea, except if it was because you were in a hurry and you said the wrong thing. And then for the NCDs, your justification too, you said you're going to inform students. I don't know, did you do an intervention? Because that was one of your justifications. And for those of you who had multi-stage sampling techniques, I think it would have been nice to have seen the stages so that we're sure that what you did can actually be captured as multi-stage. Thank you.
Yes, the third one, I think is behind you. Behind is a third person there.
Thank you so much. My question goes to the first presenter who did satisfaction for the insured and non-insured. We know that among the insured, there are different types of insurance. The NHIA is there, and for the study area, they also have their own state insurance. And then you have the private insurance with their different plans. Don't you think these ones will have different levels of satisfaction? So can that be captured as a limitation to this study? That's my question.
Okay, thank you. The next person, 4.
Thank you very much. Just an observation on the person that presented on the knowledge of fathers on the use of ORS and all that. Something was captured that you mentioned, they were fathers. 67% of them were married. And I think it might be something to look into. If 67% are fathers and have children, could be another thing to want to find out, you know, why in that place. Not particularly for your study, but, you know, something to look into. Thank you.
Thank you. The 5th person, please. Behind you, yeah.
Good morning. Thank you so much to our presenters. My question is also to the person that presented on father's knowledge of ORS. You found a statistically significant difference between married men and non-married men because of the influence of their wives. I thought you were supposed to spell out your inclusion criteria very clearly. Thank you.
Okay, the last person. Please, technical team, do we have virtual participants raising up their hands for question?
Thank
Sixth
you.
person, please.
Okay, good morning, everyone, and well done to the presenters. My response is actually a comment to all the presenters with the nature of presentation, how they presented their results. Most of them presented it in prose. I don't know if it was a prior instruction by the LOC to present that way. I think using tables and charts would have made it very easier for us to grasp, especially the last presenter that presented on all the statistically significant, I think she presented on a table. We could see the p-value and also how significant it will be very easy, legible to the eyes and sharp to grasp. So maybe next time going forward, you can use table charts to present your results better. You did the work, so you'll be able to explain and remove all those English and unnecessary words that were captured. They were more like copy and pasted from the original work to the slides. So next time we should apply presentation skills. Thank you very much.
So
Well
thank you
done,
very
everyone.
much. The ICT team, do we have virtual participants? None. Okay, fine. Okay. Yes. You sure? Okay, just to appreciate all the presenters, I think most of the issues have been raised. I think for future purposes, your slides, try and number them, okay? And I see a lot of mixed referencing styles. Vancouver, Harvard, and even sometimes the Harvard is not properly written. So I think it's something that we need to take seriously. Lastly, because of want of time, I noticed that in quite a number of the methodologies, you talked about ethical approval. It would be nice to just indicate the approval number, because some persons might just hide under the fact that they had ethical and they didn't really do that. Some of you didn't calculate your sample size, and I wonder why that is the case. And for those that calculated sample size, they didn't indicate the p-value, the prevalence that was used. And some persons, when they indicate the prevalence that was used, they just say level of knowledge. What does that mean? Is it in relation to good or poor knowledge? Lastly, in terms of analysis, it will be important to help us visualize, maybe in a slide, how knowledge, attitude, and practice, generally speaking, were computed. There was someone that talked about mean value being used. It's important that we know what this mean score was in relation to the final categorization for in relation to the study objectives. Thank you.
Thank you very much. Mine would be some general comments. I want to start with the title, because your title is actually the gateway. That is what attracts your readers to, read the abstract or even think of reading the main manuscript. But the way some of the titles are phrased are not exactly correct. For example, the person who presented on the prevalence of antibiotic misuse, your title should have just been the prevalence of antibiotic misuse. But to say to determine the prevalence is like giving an objective, a specific objective as a title, and that is not correct. Someone also talked about perception of effect, so those titles are actually not well phrased. You may want to revisit them again. Then for those who, the person who talked about adolescent reproductive health service experience, we're looking forward to hearing from you what were those experiences, what were the problems. The problems might be different from the experiences, and let's hear, they may have some good experiences or bad, but that didn't come up, so you just kept generalizing as experiences and so on. You need to also provide a working definition for in school and out of school. What were you working with? Is it those who have not gone to school at all, or at the moment if they were not in school? So you may have to provide that. Perception usually is a qualitative, is qualitatively measured. But if you want to do it quantitatively, then you should tell us the scale that you use in measuring it. That will guide your readers. It's very important. But quite a number of you did perception, and you made it look like you were just quantifying it in your measurement. Discussions should be discussion, not a repeat of your results. So most of those who presented were repeating their results in the discussion. And even in your results, you are not providing some explanations to your results. Let's have a direction to what you're presenting. That will be important. And conclusion again, most of the presenters were repeating the results again in the conclusion. Just tell us the major or the key takeaway that you want your readers to go home with. That's just some of my general comments, but for all the presenters, thank you very much. And for the audience, thank you for the attention that you gave. Thank you.
I want to thank you for your patience. We will be taking our first plenary for the day. We're taking our first plenary session for today. That's the plenary session on maternal, newborn, child nutrition, and health innovations in Nigeria. For this session, Professor Sunday Aderibigbe will be chairing this session. Yes, he will be chairing this session. When he comes, he will call up the presenters for this session. Thank you.
Good morning. Colleagues, good morning. We are going to the next plenary session now. So we are going to the next session. This session is sponsored by the African Center of Excellence for Population Health and Policy and the Medical Women's Association of Nigeria. The session is on research, advocacy, and policy for scaling up MNCNH innovations in Nigeria, the Aphpn and M1 experience. I'm going to be inviting the panelists. I hope they're around. Firstly, let me invite Dr. Taiwo Amole. She in the audience. Dr. Taiwo Amole, please come forward. Next, Professor Omosivier Maduka. Professor Omosivier Maduka. Okay, she's on the way. And then Dr. Ugochukwu Madubueze. Okay, so we'll be having 3 presentations in this session. So we're going to have 3 presentations. We have just 45 minutes or less for this session. So each of the presenters would have just about 10 minutes to present, and then we would have the remaining 15 minutes to discuss. I'm sure this is reproductive health, so there will be a lot of discussions. Usually reproductive health, brings up a lot of discussions. So the first presentation subtopic is translating research into policy for MNCHN innovations in Nigeria. The second one is on advocacy for maternal and child health, leveraging the strength of M1 for policy change. And lastly, policy implementation and system strengthening, ensuring research and advocacy lead to tangible health outcomes. So without wasting much of our time, I will call on the first presenter. Yes, Dr. Amole will do that. Then we'll take it off from there.
Good morning, sirs and mas. I want to especially greet my teachers and other colleagues, and I stand on the existing protocol. My name is Taiwo Amole. I'm from the African Center of Excellence for Population Health and Policy from Bayero University, Kano. So I'll just say a bit about the center. We got a World Bank grant in 2019, and it was to set up a platform for postgraduate training and for research. All right, so that's the outline of my presentation. And this is our vision to be a center of excellence in population health research and development in Africa. We have a couple of centers of excellence across the country. In Nigeria, we have about 17 of them. And in total, we have over 50. And our own center looks to produce skilled human resources for health with a focus to conducting impactful research. Actually, our main goal is to ensure that the research don't just end with our publication papers in our scientific journals, but that we move from there to policy implementation. And that was why the center came to be. Our work so far, which we'll be presenting this morning, has been with a consortium, and M1 is one of them. We're here together. And we're focusing on maternal and child health with nutrition and innovations that we have worked on so far. The figures regarding maternal and child health in Nigeria, I'm sure we are all very aware. We have significant challenge in Nigeria. And we all know that research is the key to identifying the solutions and shaping policies for whatever interventions that we need. So together with our group, we've worked on that, and we're going to present some of them today. Sadly, Nigeria accounts for over 1/4 of the global maternal death, and this was from the trend that was published in 2023, looking at year 2000 to 2020. And from our NDHS, the maternal mortality ratio that we all know, it's about 512 per 100,000 live births. In Kano, where I'm from, our MMR has been over 1,000 for decades. And the causes are the things that we know. They have not changed. I normally tell people that even when I was in medical school, late 1990s, I mean, the causes have not changed. The things that we know, hypertensive disorders of pregnancies, hemorrhage, sepsis, anemia, obstructed labor. So the causes remain the same. Okay. All right, so these are just showing the trend that maternal mortality and child morbidity and mortality statistics in the last 3 decades in the country have not changed much. This is a trend of home delivery, and those that are delivered in the health facility. If we look at that line graph, you see that not much has changed. It's like almost like a plateau, you know. You are not seeing a crash. So it means that whatever we are doing, we need to do something differently. And this is also for ANC in antenatal coverage. That looks like it went up a bit, but still not significant changes observed. And if we look at child health, on the 5 mortality, we had some significant decline. But look at neonatal mortality. It's been really static for the last 3-4 decades. Not much has changed. Infant mortality has also not changed much. And in the region where I'm from, which is the north, the indices are poorer. So these are a set of new innovations that we worked on, and we saw that they could actually change the landscape for maternal and child health. I will talk about some of them this morning, not all of them. So we have Group ANC, multiple multivitamin supplements, the Aphpn trial, which my center was part of it, the labor care guide as well, which is a review of the the pathograph that we use to monitor labor. That has been adopted across the country, even though implementation is not all across. And then we have what we call azithromycin for puerperal sepsis. It's also a work that we are doing at our center, community distribution of misoprostol and azithromycin to manage sepsis. And then the emotive intervention. So the first innovation that I will talk about this morning is the emotive intervention, which was focused on postpartum hemorrhage. We know that postpartum hemorrhage is the major cause of maternal mortality. So what was the problem with postpartum hemorrhage? For decades, it still contributed to maternal mortality. The problem was the diagnosis was either missed or it was delayed. The treatment also was missed or delayed. And same with when we have refractory PPH, it was either missed or delayed. When we were doing the trial, when we had the emotive trial, we usually have a session where we put like a blood-like liquid in kidney dishes, and we ask the healthcare workers, the nurses and the doctors to estimate the blood loss. And the problem was visual estimation. Sometimes they will say 300 mils when it's actually 800 or even over a liter. So that was a major problem, and that was how the emotive intervention came in. The usual care is that since 2012, the WHO actually had guidelines for managing postpartum hemorrhage. That's to have oxytocin, like oxytocin, tranexamic acid, IV fluids and all. But it was given sequentially. When a woman is bleeding, first of all, they massage, then they go on. After some time, is she responding? Then they give oxytocin. Is she responding? Then they give on. But the innovation behind the emotive trial was to give it all as a bundle. So we used the bundle approach. We give all at once. And that was what that second diagram is depicting. And that was the acronym, the emotive. The E was early diagnosis, M was massage, uterine massage, O for oxytocin, and T for tranexamic acid, IV fluids, and the E was examination of the perineum and escalation if there was a need. So when that was given as all together as the bundle, all 5 interventions, we had a reduction in PPH by 60%, and that was huge. And based on that, we were able to develop implementation strategies for health facilities. This is just showing as well what happened, the usual care, that's current practice, and then when we use the emotive bundle, you could see a crash in the number of PPH. We had about 60% reduction. So based on the findings of the trial, the World Health Organization changed the guideline or reviewed the guideline for management of PPH. And that was done in 2023, in December 2023, based on the evidence from this trial. And right now, this is being rolled out in states in Nigeria. One of my other colleagues will give us more information about that. We are working in 16 states to see that healthcare workers are trained on applying the emotive bundle to manage PPH. So that's one innovation that we think or we know will crash maternal mortality. The other innovation that I want to talk about is what we call...
You have 3 minutes more.
Okay. The Kano State Surveillance for Evidence and Policy Platform. We know that many times maternal mortality data is actually obtained from like retrospective data or facility surveys. But right now we set up a platform that collects information from a sample of people. It's called a sample registration system. So we actually get pregnant women in all the selected sites and follow them up to know what the pregnancy outcome is. So we know if a maternal mortality occurs, if a stillbirth occurs. So that will feed later into a civil registration and vital statistics system when, we do that. So that is presently being done in Lagos and Kano. Another one that we did was the Ivan trial. What the Ivan trial did was to compare injectable iron to oral iron. And the outcome for the mother and the baby are actually very significant when they were given injectable iron. The side effects were also minimal. So that has been published, and very soon the policy regarding management of anemia in pregnancy and postpartum period will also be reviewed. These are other interventions. We also did a study on simplified treatment for eclampsia. When a patient has eclampsia, they have multiple doses of magnesium sulfate. We actually worked on giving only 2 doses to see whether it could control for the convulsion and manage the eclampsia. And the result also is, the pilot has been completed and the main study is about to start. The results also are tremendous. And what this will mean is that at the grassroots level, people would actually be able to manage hypertensive disorders of pregnancies. Another one there is the azithromycin, combination of azithromycin and misoprostol being given at the community level as well. That's also another innovation. And then maternal immunization readiness. There is also an ongoing project on maternal immunization readiness. Some diseases, respiratory syncytial virus and the group B streptococcus actually account for a lot of disease amongst neonates. So these vaccines are to be introduced. But we know that right now, not only in Nigeria, but across the world, there can be a lot of problems about hesitancy and other things. Other important things, even cost. So right now, we are looking at the readiness, looking at what is the situation in Nigeria. How much would it cost? What policy do we need to tweak? For example, right now, pregnant women, the platform that they access care is very different from where the routine immunizations occur.
Time is up.
All right. So for immunization, we're also looking at that. One very important thing that I would like to talk about in all this is stakeholder engagement is very, very important for sustainability, for you to be able to translate to policy. You must engage stakeholders and it must be an early engagement. Of course, we have some challenges. Many of these projects were funded by, partners. And so when they end, we have to think about sustainability. And it affects scaling up as well. Then cultural and systemic barriers that limit the intake of new interventions. These are some of the challenges that we have encountered. So in conclusion, high quality research is fundamental to drive policies for maternal and child health in Nigeria and beyond. We've been able to show some of the things that we've done to achieve sustainable change. To be able to do this, we need collaborations with different people, including researchers and academicians in the hall. And we hope that by bridging this gap between research and policy, we can drive decision-making, enhance healthcare system, and improve maternal and child health outcomes.
Thank you very much.
Thank you very much.
Thank you. So we'll go straight to the second presentation. Advocacy for maternal and child health, leveraging at the strength of M1 for policy change. That will be taken by Dr. Madbezi.
All right, good morning, everybody. So today I'll be representing medical women and sharing the medical women experience. My name is Dr. Ogochukwu Madbezi. I'm the Assistant National Coordinator of Medical Women Association. The third one. Advocacy, accelerating, yeah. Okay, thank you very much. So just as a form of background, we all know that maternal mortality remains a significant challenge in Nigeria, and we have about 28.5% affecting Nigeria at this time. And barriers such as weak policy environment and lack of product availability hinders the implementation of life-saving interventions. So this project is actually aimed at establishing a cross-country network of experts and champions to promote the adoption of evidence-based MNCNH interventions. Those are the same interventions that my colleague has highlighted. So typically we are looking at the emotive strategy, whereby E is early detection and trigger criteria, M is massage of uterus, O is oxytocin drugs, T triazinamic acid, IV fluid, E examination and escalation, among other innovations which she has actually presented. So this is a consortium of partners. We have the ASCAP, African Center for Excellence in Population Health and Policy, Pathfinder, and CCSI, which is Center for Communication and Social Impact. So we took our method is that this project is being implemented in 16 states across Nigeria, including Akwa Ibom, Bauchi, Yobe, across all geopolitical zones, and we are taking the study design as an implementation research with a mixed method. Our study populations are pregnant women, policymakers, healthcare workers, and our interventions are basically advocacy, capacity building, supply chain management, health system strengthening, and this project is going to run from September 2024 through August 2028. So basically, M1 is trying to strengthen advocacy, strengthen stakeholders' buy-in, and increase awareness among our population of interest. So the interventions are strengthening policy environment, building technical capacity for advocacy, promoting the availability of innovative maternal health interventions for PPH. The picture there was one of the stakeholder meetings in Yobe State. And why are we doing the advocacy? We're trying to bring our partners together alongside the Ministry of Health of every state to understand what the BMGF Foundation project is all about, trying to establish a platform for easy communication, try to gain their buy-in into implementation of this work. And our stakeholders' engagement cuts across the national, the subnational, healthcare providers, policymakers, and community champions in 16 states. Our stakeholders include and not limited to Honorable Commissioners of Health, Executive Secretaries of Primary Health Care, ES of Hospital Board Management, special advisors to governors' wives, the governor himself, as many as we can reach. And this was a picture of stakeholders engagement meeting in Lagos. And so we tried to select about 20 champions in every state and then developed a criteria, a scoring system whereby we prioritize these champions, and at the end of the day, we'll select 10 from every state. So these champions will be our foot soldiers in the community to help drive advocacy. So what we did in the first week of February was to train our members on champions mapping alongside our partners and deployment of champions mapping tools by state EMA members, including interviews and discussions. By week 2, collation and analysis of the scores and shortlisting of our champions. And by the 3rd week, we'll send letters of nominations to those champions, and by the 4th week, we had a very high-powered inauguration of those champions in the different states, whereby we had Commissioner of Health, PAM secretaries, and other top government officials in attendance. And going forward, we commence planning for the advocacy and communication training. From this picture, this was the inauguration of champions in Kaduna State. So you can see our invitation card and a picture of the champions. Our elder, Professor Clara Ejembi, is one of our champions in Kaduna State. And of course, M1 is in the business of creating awareness. We try to create awareness on health, public health important days that speaks to maternal mortality and PPH. And so we celebrated universal health coverage, World Iron Deficiency Anemia Day, Zero Tolerance to FGM, International Women's Day, and we try to coin all the team towards maternal mortality and PPH. So we did a lot of sensitizations on radios, televisions, in the community, in hospitals, and a lot of road walks just to create awareness on maternal mortality and PPH. And these are some of our flyers. Of course, we did online sensitization as well on our Instagram page, on our YouTube page, and Facebook and WhatsApp pages. And of course, we disseminated even our protocol at the West Africa Conference of Physicians, where it was critiqued and we made corrections. And also we tried to disseminate at other platforms, Sogon, even here we're disseminating information. And of course, our protocol was also published on PubMed in the West Africa College of Physicians Journal. And we also did the policy desk review, looking at state policies, at national policies, and international policies, where we brought out current situation analysis, identify gaps in policy implementations, identify innovative approaches to prevent MMR and PPH, and also provide recommendation. So at the end of the day, we expect to have a brief which we would be able to present to the stakeholders and have a robust discussion on policy changes. Our output includes we expect to establish a national network of MNCH experts. We expect to drive high-level political advocacy and strengthen the policy environment for implementation of MNCNH innovations. And our outcomes, as expected, are increase the number of healthcare workers trained in PPH interventions, upscale nationwide adoption of new PPH interventions, and of course, reduce the prevalence of maternal mortality in Nigeria. And as a conclusion, our keynote is that this project provides a strategic approach to scaling evidence-based MNCNH innovations, and its successful implementation will contribute to achieving Sustainable Development Goal 3 and significantly reduce maternal mortality. Thank you very much.
Thank you very much. You gave us 1 minute to spare. Thank you. So we go straight to the third presentation by Professor Maduka Mosivier, Policy Implementation and System Strengthening, Ensuring Research and Advocacy Leads to Tangible Health Outcomes.
Good morning, my teachers and colleagues. My role in this team will be to bring together what the first and second presenters have discussed and show you how evidence-based research should inform policy, can inform policy, and a roadmap for doing so, and especially bring a call to action to Aphpn to do exactly what ISPAP and M1 and other stakeholders have been doing. Fantastic, thank you. So my name is Omosivie Maduka. I'm a member of this association, proudly so, but I am also the program manager for this consortium's activities with regards to what ISPAP and M1 and other consortium partners are doing. We know that research is fundamental to evidence-based policy making. We teach the fact that we shouldn't allow policymakers just make policies blindly, but that we should provide evidence-based support for policy making such that policies are based on evidence from high-quality research. We know these things. And we also know that research should fuel policy, but oftentimes we are trained, and more importantly, we practice research, advocacy, and policy influencing as very different we have a silo approach towards the practice of these things. And it's important that we should remember that research is a driver for policy. So how do we translate our fantastic research that sits in wonderful journals? How do we translate it into a language policymakers can understand? And how do we bring this to the notice of policymakers and get their attention for change in interventions? And how do we ensure that we scale up and we evaluate such that our policies keep getting refined based on research outcomes? The key lessons that we've learned from the presentations that we have heard about the emotive trial, about the CASEP, and about every other thing that ISPAP is doing and M1 is supporting is that high quality research is very important. There would be no policy information, there will be no information for policymakers to use if it's not coming from research. And if it is bad research, then it will equate to bad policy. So high quality research is important. We need, as Aphpn, to come together, build the capacity of our members to produce high quality research. Our seniors need to mentor the younger ones, and then we also need to, as an association, as individuals, we're doing fantastic jobs, but as an association, we need to continue to pursue high quality, high impact research. But irrespective of how awesome research is, it is not sufficient to cause change in policy. So without advocacy I see is a bridge between research findings and policy changes. It is advocacy. Without advocacy, without stakeholder engagement, without understanding, first of all, who the stakeholders are, without finding a way to communicate research findings in a way that is devoid of jargon, in a way that is simple, understandable, and in a way that is compelling, where they see the value add for them as policymakers to adopt and to sustain, we will not really make so much progress. Real-time data systems actually help to improve policy responsiveness, but some people have to be responsible for translational research that provides innovative policy solutions. And we must continue to support policymakers to evaluate. So this is the Aphpn advantage. This association is built on the premise that there's membership from the academia. We have extremely skilled researchers. We have people with diverse field experience. We have a diverse membership that cuts from the university system to the medical officers of health, to the ministries of health, to commissioners, to deputy governors and governors. We have access across all cadre of healthcare delivery. We are not relegated to one specific sphere. And this is the advantage of Aphpn. And the fact that we have advocacy and communication experts who are very well versed in how to communicate for policy translation or policy implementation. So, what must Aphpn do? One, we've said it: sponsor, facilitate, build capacity. This is not as individuals, this is as an association. So I'm talking about an association agenda, just like we have been doing in the past, to do even more, facilitate high quality nationwide research. Because Aphpn is active in 33 states in the country, we can do research across these 33 states at the same time and come up with results that are impactful, that will ensure that our voices are heard and that our research findings come to the notice of policymakers. We also need to engage in research uptake activities, which is anything you do to bring your research findings to the notice of people who need to use it, whether it be policy, whether it be change agents, champions, or even the end users themselves, the people who stand to benefit from the research findings. How do you bring this information to their notice to the point where they can take it, they can adopt it, they can use it? How do we advocate for policy changes and implementations? So not just about getting the findings, putting it in a policy brief and posting it somewhere. How do we engage? How do we engage policymakers? How do we ensure that our voices are heard? How do we get into the corridors of power, quote and unquote, where decisions are being made? How do we reevaluate existing policies in line with current researches? And most importantly, they need to build bridges, alliances, and partnerships with other professional bodies, with other organizations to do so. So, by way of a summary, we need to strengthen our own research and data systems as an association. We need to collaborate. We need to invest in capacity building for evidence-based decision making. We need to seek for funding to do so, because without funding, without funding, all our activities won't be done. And then we need to foster a culture that is data-driven. In conclusion, evidence that is generated through research is a foundation for effective policy. We need to ensure that policies are grounded in research. The examples that have been given today about the emotive, about CASEP, about Myrna, illustrates the success of that. And then this is a call to action. A call to action to our association, that as individuals we're doing fantastic work, as universities, as teaching hospitals we're doing good, but as an association we have the opportunity to leverage from every single state in the country, including the FCT. We have an opportunity to bring research together that actually informs policy. We can have access to the government, to the Minister of Health, commissioners at state level, governors at state level, and actually advocate very actively for there to be certain things that will change for the health and improvement of maternal and child health, and not just maternal and child health, every health intervention that we are passionate about. Thank you very much.
Thank you very much, Professor Maduka Mosibi. It's time for us to take some discussions. So I want, if we have questions from the audience, anybody? Okay, Professor Zwaka, number 1. Okay, Professor Ejembi, number 2. Any other person? Okay, number 3. Yes, please, can you get a microphone? Yes. Thank you.
I want to commend the presenters for those innovative ideas and thoughts. And I want to also congratulate you on the work you're doing. But we all know that when it comes to maternal mortality, when we dwell on medical causes of maternal mortality, we miss, I can see almost 90% of where the problem is. It's a very good initiative. No doubt about what you're doing. I want to commend you, but it's very, very important to have an holistic approach, you know, to what you're doing. And it will change the paradigm of this country if you changed the approach of not only looking at the medical causes that can give you visibility, profile around the world. People will hail you, you know, for doing PPH interventions and what have you. But our major problem in this part of the world, you know, is the non-medical causes. And I think it will be very important to look at systemic issues that are major drivers of maternal mortality in our parts of the world. Secondly, I think many a times when we talk about causes, we put it in a box. Let me use the common terminology that has been introduced. We put it in a box. What I mean is that we think that those causes that have been published and itemized and shared many, many times, and that they are in publications, they are the same causes when you try to do a sub-national analysis of the causes. I don't think so. They might not be the major drivers of what we're seeing. Especially if you look at the northern parts of the country and the southern part of the country, there might be different major medical causes that are driving this intervention. So when we have an intervention and put it in a box and take it to every nook and corner, we think that if we introduce them, it will reduce. We might be missing the mark, but I would like to encourage you that you have a very good initiative that can help us, crash these big numbers that we have. If we can look at what are the major drivers at subnational levels, at regional levels, what are they? Can we have interventions differently in South, East compared to Northeast? Can there be different interventions? And looking at the causes that are responsible that can help us drive down this information. I think it will be very useful. My other comment is to also encourage you in this your consortium to look at whatever you are doing. I think you need a very strong health systems unit. It can help you, even with what we've done in PPH, it can help you look at what are the critical components that can help us, you know, even using the major causes, the medical causes, what are the systemic issues that we can introduce. My last comment is that many times as researchers, we sit at our ivory tower and develop very good research and with policy component and try to sell it. I think we are missing the mark. Participating research is critical to success of policy intervention. If at ab initio, even in developing your research agenda, those people are not on the table with you, and you've helped them to identify their problems and use that as a basis for your research, selling it will be a Herculean task. Thank you.
Thank you very much, sir. Please, other contributors, because of our time, can we just summarize our
Thank you very much.
contributions?
I want to congratulate the presenters for an excellent work, but I want to align with what Professor Zwaka has said. If we are really focused on reducing maternal mortality, right now, where are the women delivering? Where are they dying? They are not, it's not happening in the hospital, it's at community level. Our NDHS data is telling us that So we need to move beyond interventions in the hospital to where the problems are actually happening. That's one. Number two, we need to look at what are these determinants of maternal mortality. And when you look at it, the remediable sociocultural factors are the major drivers of maternal mortality. And we cannot solve them with medical interventions alone. We need to introduce, interventions at community level that empowers our communities to self-reflect, self-diagnose, and develop community action plans to change behavior and actions that drive maternal mortality in this country. So we need to perhaps begin to invest in simple things that can help, and community NPDSR is the way to go. And if you look at community NPDSR, especially the social autopsy component, if done correctly and properly, it empowers our communities. They self-reflect, self-diagnose, and develop community action plans, that change behavior and actions. So as much as facility interventions are important, I think if we really want to crash this thing, we also need to begin to look beyond that. And secondly, even, these interventions that we are talking about, where you are, like Professor Zwaka has said, the articulation or identification of the research question and interventions right from the beginning, we need to begin with the end in view and bring the consumers of the research products to the table so that we plan the research together, so all the policy target them, involve them from the beginning. They are more likely to accept it and use it. And finally, even if you have the product and they've accepted it, scaling up has always been a problem. So we have this intervention. Who is going to fund it, the scaling up? We've done quite a number of things in maternal mortality. They use it to change policy even at national level. But getting it to scale has always been a problem, because we are always donor dependent. Nobody is willing to put money on the table to get this thing done and done correctly. So I think we need to look at things a bit more carefully.
Thank you very much, ma'am. The last person, number 3. Yes, please, 1 minute.
Good morning, everyone. I want to say special thanks to the presenters and congratulate them. Mine is a question. From the first presentation, I saw she had used NDHS data for maternal mortality of 2018. And I know that the NDHS report for 2023/2024 is online. So, and I looked at it. Why is that not referenced? Going through that report, I saw that maternal mortality was not reported. So this audience is a highly seasoned one, and I would like to know if there's any information on why maternal mortality was omitted in the NDHS report of 2023-2024. Thank you.
Okay, thank you very much. We will not be able to take more than that. I will give the first presenter the microphone so she would respond to some of the issues raised.
Thank you very much. We appreciate the questions and some of the I want to say that I didn't have enough time to talk about the CASEP project. That's the platform that we said is tracking pregnancy and their outcome. That platform actually was able to collect data and look at the causes of maternal mortality. And I can tell you it's not been published, but they have not changed much. So when we set up that platform, we retrospectively collected data for a year in all the sites. Kano State has 44 LGAs, and we have sample sites across all the 44 LGAs. The enumeration areas serve as our sampling unit. So we collected data from all the women in the selected enumeration areas. Enumeration areas were also proportionately selected to the population of each LGA. So we have a powered sample size to determine maternal mortality. The causes have not changed. The only thing which is there in literature, I mean, maternal PPH comes high up, number one, but we've known that northern Nigeria, hypertensive disorders of pregnancies actually come as number one. So that has not changed in the very current data that we have, which we are going to publish soon, that on maternal mortality. Also, having an holistic approach to it, that CASEP, we went down to the grassroots. So in Kano, so the project is being done in Kano and in Lagos State. But in Kano, the Kano State Emirate Council, you agree with me, they do a lot. In fact, they're already involved in health. They have committees on health. So we work with them. So women in the community are part of our research, traditional rulers, religious leaders. And part of the work, apart from counting the maternal mortality, is that we do verbal autopsy and social autopsy. So we collect data quantitatively and qualitatively. And other parts of that project actually assess, the non-medical causes of maternal mortality. So all these data is also being collected on this, and our interventions are going to be tailored towards all this. The rough analysis that we've done, we saw that emergency causes accounted for about more than half, 50-something% of the maternal mortality. We saw LGAs that had very high maternal mortality, and we are investigating the reasons. So not only just facility data or counting the medical causes of death, the non-medical causes of death, non-medical causes of maternal mortality are also being captured. So the participatory part of it, the Emirate Council, at the grassroots, we have people that are part of this project that are contributing to the data that we have. Community MPDSR, this is one of the things that the CASEP project is also doing. Even at the federal level right now, there is a MAMI project that is looking to crash maternal mortality. So we are keen into all these existing programs. So CASEP, or whatever we are doing, is not a vertical thing. We are looking at keen into the existing programs like the MPDSR, which the community MPDSR is part of it. The project, when we started, was mainly focused on auditing. The response part of it, the MPDSR team is going to supply for us. As regards scaling up, that's why the consortium even came together, because the first thing we had was actually that emotive trial. But when the consortium came together, it's about scaling up. And in scaling up, we are not looking at projects that are funded by partners alone. So right now, like she presented for advocacy, we are including the state ministries of health. For example, in the states where we are, we made sure that they included consumables for emotive into their annual operation plan, so that they can budget for it. And we're happy to say that some states have actually budgeted for it. So those are sustainability plans that are there to ensure that scaling up, we don't have a problem. When funding ends for the project, each state, and we hope that this gets across to 36 states of Nigeria, each state is able to fund for these activities. I think I've been able to address the major, you want to say something? The NDHS, the reason why that was used was because the NDHS, yes, is out, but the MMR is something that is not yet, but we hear news like it's not very different. So if you have it, I'll be happy to have it, but the MMR is not something that has been published. That's why we still stayed with the 2018 NDHS. So we are aware that this is a very high-powered, audience that need current data. Thank you for saying that.
Okay, thank you very much. Just last words. I want to raise some posers. Number one, our policy makers. How many of the policies do they make using evidence? How many of the policies are evidence-based policies? Number two, our researches, okay, are they geared towards policy change? Many of us, we just do research for promotion, publish or perish. Okay? How many of us really do researches geared towards having a policy change? And then, how many medical doctors are skilled in advocacy and communication? How many of us? Okay, so these are posers that we need to think about. I remember yesterday, we need to throw away the box. We need to throw away the box. Let's look at, let's think of innovative ways of doing things, okay? And then our interventions, just like Professor Jembi said, our interventions, are they geared towards the woman at the community level? Or we are doing institution-based interventions, okay? These are posers we need to think about. And I want us to give our panelists a round of applause for that wonderful presentation. I'm sure they have stimulated our appetite. They have made us to think about these things. And I feel going from here, we need to do researches that our policymakers can actually use, and they are part of it, the conception of such, researches. Thank you very much, panelists. God bless you. Thank you.
Yeah, I want to appreciate the chair and the panelists for the wonderful session. I want to crave your indulgence. We'll take one more session before we go for tea. Please. We want to bring up, please, you will go for tea, but let's take one more session, please. We want to take the fourth plenary session. We want to bring up the Global Health Research Group. And for this session, Professor T.N. Akonde will be the chair of this session. Please, let's make him welcome as he comes, Professor Akonde. Thank you very much. Thank you.
Well, while the photograph is going on, I think I should invite the panelists. First, let me invite Dr. Akindele Adebi, who is the principal investigator for the Dark Seed project. And then Dr. Simpa Daniel, who is the CEO of Healthstack. And lastly, but not the least, Dr. Oyeladun Okoromade, who is the Director of Policy and Planning of NCDC. This session is about digital tools in infectious disease surveillance. And I have the three experts who will be giving us some insight into the Dark Seed project and also some policy briefs, and then some issues about community-based surveillance using digital tools. Let me say that we have this session funded and the project funded by the Wright Foundation of Seoul in Seoul, Korea. And then they are also online with us. We have also the collaborators online from the International Vaccine Institute of South Korea. And this is the way to go. Well, before I say that, please, the attendance sheet will be passed around. Please, we request that you fill the attendance sheet as this part make their presentations. I will invite the panelists one after the other to make their presentation, and the presentation from them will be from between 5 to 12 minutes. And then we will have a panel discussion for a short while, and then we'll entertain questions and answers. And so first, I'd like to invite forward Dr. Daniel, who will be speaking on the overview of digital innovations in health.
Good morning, sirs. Good morning, Mars. Thank you for joining this panel session. Okay, so I'll be talking about an overview of digital health innovation on the global scale, just to provide context for the work that we've done. Essentially, it's the use of technology to provide, to improve health outcomes, talking about artificial intelligence, telemedicine, wearables, and data analytics as a whole. Why it matters? Because we need to increase accessibility to healthcare, we need to improve efficiency, improve outcomes, and reduce costs as well. What are the key drivers? Technology advancements, things are moving like I mean, within the AI space itself, it's like 1 week is a year, in terms of how much, work is being done, blockchain and the rest. Demand for personalized medicine, so more and more now, we're going towards precision medicine and individualized stuff. Big data, predictive analytics, that's widely growing as well. Global health challenges are also increasing, as you'll see, and actually form the basis for what we did. Aging population, and then, of course, consumer expectation is also changing. People have seen what technology is doing in fintech and the rest of it, and why not healthcare? So I just highlight a few things. Telemedicine and remote control. So this is virtual consultations happening across board, and being able to monitor patients even while they're not within the healthcare facilities. Hopefully it expands access to rural areas and then reduces, the overcrowding that you have within hospitals. AI in healthcare diagnostics. So now AI able to interpret X-rays, CT scans, even provide summarize clinical notes. We have what you call ambient listening now, where you don't have to write your notes any longer. The system would basically, give you your notes at the end of contact. Chatbot and virtual assistants, predictive analysis for disease prevention, and then natural language processing. And then key also is AI agents, where we kind of just moved from the point where you see computers or technology as just providing information back and forth, but now they're not able to take actions, right? They understand and can take actions because of the widespread of large language models. Wearable technologies, sensors tracking real time, IoT-enabled hospital management system, so you don't have nurses going to take vital signs from patient to patient. You just have that device, and that just streams all the data, biodata that they need, biometric data that they need. Across board. I just kind of highlighted the Aura Ring. It's a sleep monitoring tool, and you just simply wear a wedding band, and that's all that you need to do. And all that provides data from your sleep patterns and all that going forward. A virtual part is a patch on your chest. It measures your vital signs. Big data, what's the key issue? So data as a whole, right, from in the current trend, right, so there's a rapid increase, right, in terms of the volume of data that we're collecting, the velocity of that data, and the variety of that data that is happening. Ideally, that would happen, the base of that lies within the electronic health records system, and then you can then begin to use all this for multiple things. So predictive analysis for outbreak, genomic sequencing data, and then obviously that drives personalized medicine as well. The use of blockchain essentially provides security and transparency, decentralizes control. You have smart contracts, so basically you set up the system that if A and B happens, do C. And that happens independently of human intervention, and hopefully can speed up a lot of things and provide transparency. Secure medical record storage, so everything that is done is entered on the chain. So the blockchain essentially provides you a decentralized but immutable copy of data, so you cannot change whatever has been entered into that system across board. You can track what's been done on it. Of course, that then applies with supply chain logistics, right? So it provides transparency up to the end user's point. What are the key challenges? Ethics, what's right, what's not right, biases, there are a lot of stuff that goes into that system that you might not necessarily be aware when you start to build out the system until you put it out in the field. Data security and privacy risk, talked about that as well. The high cost of implementation. So I kind of make this joke now that the cost of hardware is actually more costly. It's more costly than actually the cost of doing software currently within the space. Digital divide, accessibility issue. We talk about high resource areas and poor resource areas, right? As you go forward, you're going to be talking about data-rich areas and data-poor areas just because we don't have that infrastructure, and that then basically provides a basis for that digital divide and accessibility issues from the data point of view before you now go to, people actually having access to the technology to use as well. What are the future directions? AI-driven precision medicine. So think about medicine that's customized to each individual, and that is driven largely by computers and not necessarily humans. Blockchain decentralized healthcare records, augmented reality or virtual reality in medicine. So you see a lot of transformation happening where training is not being done in real physical spaces, but in a virtual environment and augmented within that environment as well. Robotics in surgery and care delivery. I have one of my classmates who's based in Leicester, basically does robotic neck surgery, and actually it's actually more precise than what you would do without the assistance of the robot. Quantum computing prospects in terms of drug delivery. A lot of companies now, at least 2-3 companies have come up with what you call the early stage of the quantum chips. And you can imagine that the computing that you can do for like 10 years, you can do in one day. You know, that just basically changes how things are. And so hopefully more drugs will come in. Again, people are also going the path where you're using secondary data now to drive your drug discovery processes as well. The AI agent-driven healthcare system. I mean, for me, I think this is the most exciting bit down the line where, you know, on this side of the world, we talk about the fact that we have resource constraint, right? Human resource for healthcare constraint. But think about it that you didn't have a hospital that runs on like less than 10% of the current staff that they run with, and how that would happen, and the fact that, you know, really, truly, you can have your healthcare in your pocket. Thank you very much.
Thank you very much, Dr. Daniel. Let's put our hands together for him, please. He's a typical example of a medical doctor without stethoscope. All his life has been IT. And so next, I'd like to invite Dr. Oyeladun Okoromade for our presentation.
Okay, good morning, my teachers, my mentors, and colleagues in the house. My name is Oyeladun Okoromade. I'm a director from Nigeria Center for Disease Control, and I'll be taking us through key challenges in infectious disease surveillance in sub-Saharan Africa. I've been given just 5 minutes, and I'll rush through some of the presentations, then would expatiate more during group discussion. This is the outline that I'll be following. And as a brief introduction, public health surveillance, as we all know, is an ongoing systematic identification, collection, analysis, and interpretation of disease occurrence, and public health event data to take timely and robust action. So it involves timely dissemination of health-related data for the purpose of monitoring and improving the health of population. It involves tracking, monitoring of various health indicators, risk factors, and also to determine trend within the community or a larger population. And the end goal is to inform public health action, ensuring that policies, decisions are made based on data available. This is just to give us a snapshot. This circle shows the emphasis on the surveillance that is continuous. It's not a one-off event, and it involves reporting, interpreting, responding, communicating, evaluating, and the circle continues. And to give a brief overview of the core reasons for surveillance in terms of linking surveillance to action. The main reason is to initiate outbreak investigation, to monitor the trend of diseases and initiate an outbreak investigation when it's occurring, and to also know the type of measures and the control to be instituted either for vaccination, prophylaxis, elimination of source, interruption of transmission at any stage, and also to develop targeted programs and development of policies and programs and regulations at every level. We have different surveillance systems available in sub-Saharan Africa, which I've highlighted examples here, would expatiate more during the discussion. We have indicator-based surveillance, which rely on certain predefined indicators or certain set thresholds to monitor and assess the occurrence of specific events. We have event-based surveillance or community-based surveillance. This is an approach that focuses on early alerts or signals or any rumor occurring within the community so that we can detect specific events within a community. We have a facility-based. Facility-based is looking at events occurring within a particular facility. We have laboratory-based surveillance, sentinel, disease-specific surveillance, case-based surveillance. We have collaborative surveillance and the use of different digital tools. And it's important to know that all these different surveillance systems all occur within the IDSR framework. I'll be spending a bit more time here looking at the key challenges in infectious disease surveillance, and I've highlighted it in 4 thematic areas, looking at the structural and systemic challenges. This looks at the health system, infrastructure available for the surveillance system and the health system. We look at the poor diagnostic facilities in terms of our laboratory facilities, capacity existing at the national or at the subnational level. There are various fragmented surveillance systems where we have different disease-specific vertical programs occurring. There is a weak data management as well as a lot of incomplete reporting or delay reporting from different community or different subnational level. We also have workforce and capacity constraints. These look at the shortage of skilled personnel, limited epidemiologists or data analysts, shortage. We have a very short training experience in terms of the digital tools, or surveillance officers are not well up to speed in terms of data, software, and innovatives occurring. And there are a lot of retention challenges where there is a high turnover of our workforce team despite the training, inadequate continuous training, and the poor career incentives. Then talking about financial and resource constraint, we look at a lot of underfunding surveillance programs at all levels, be it at national, be it at the state or the LGA level. We heavily rely on donors to support our surveillance activities. We have a lot of sample transportation challenges and storage issues at the local level, and a lot of logistic and supply chain barriers as regards our surveillance. And most importantly, political will, policy and social structural challenges. This looks at the weak governance, weak policy framework available, a lot of political instability. We have conflict area where surveillance activities are impaired, disrupting a lot of surveillance activities. And there is a gap in our international health regulation compliance as a country. We'll share more on this during the group, during the question and answer section. So I've highlighted some of the recommendations here. There is need to ensure continuous learning and adaptation. Capacity building of surveillance officers across all levels needs to be a continuous process. And also we need to continue to leverage our surveillance system on digital health as well as the AI. Need to enhance One Health approaches, make it a multi-sectoral approach instead of having a several vertical surveillance system for veterinarians, different surveillance system for the human health. They should be able to speak to each other for a One Health approach. And also ensuring community engagement strategy, public health, private partnership. Thank you.
Thank you very much. Let's put our hands together for a while, please. And swiftly, I will invite Dr. Adebi, who will be speaking on applicability of digital tools for infectious disease surveillance, lessons from the DAXI study.
Good morning, elders, colleagues. So I'm Aki Adebi. I'm the principal investigator for the DAXI project. If we look at the joint external evaluation that was done in Nigeria in 2017 and 2020, Initially it showed that we are not ready for if any threat, a public health threat comes. But we improve dramatically. We move on to 46, but we're still not there. And part of what was identified as the major gaps include issues with surveillance, especially issues at the subnational level, that even though the national level is doing well because IHR had also helped the national level to improve the capacities, especially to be able to detect, to be able to prevent, detect, and respond to public health threats when they come. Community surveillance also was a sore point that is still quite suboptimal. However, it was thought that digital tools, and platforms such as SOMAS, such as DHIS2, holds a lot of promise. As Dr. Simpa has talked about, that's the future of, infectious disease surveillance and even of health. But during the COVID-19 pandemic, a few vulnerabilities, were detected in SOMAS. Part of those vulnerabilities, refer to thresholds, refer to offline and online synchronization and so on and so forth. But these difficulties that were noted are not peculiar to SOMAS alone. It has been noted across low, medium income countries that when you have a high-end technology being introduced in a low, medium income country, contextual factors may actually militate against its efficient and effective use. So it's not peculiar to SOMAS alone. Now, what is the key challenge? The key challenge here is that usability assumptions sometimes may not hold true. What we assume will hold in standard settings may not hold true eventually in real settings. And this might actually be due to some poor capacity at the level of the organizational level, may also be due to organizational readiness that usually we do not readily assess when tools are being introduced. It's usually a top-down approach. Even when we say we run a pilot, issues that are related to organizational capacity and readiness are not readily taken on board. So there is little attention that is paid to contextual issues, and this would make otherwise very good technologies to appear to be failing. So in view of that, we came together with the Oyo State Ministry of Health, State Primary Health Care Department, and a few other partners, and we were funded by Right Foundation. We had a community advisory board that also influenced, most of what we did, and were also key to interpreting our results, which was very, very important for us. So we came together to look at the study. Somebody is still going to present later in the day an abstract, so I'm not going to go into the methods, but we looked at the current use of digital platform for integrated disease surveillance in Oyo State. The challenges are linked with the deployment, and then we assess the usability and organizational requirement. We use the human-centered design to be able to interrogate this. Now, in a few sentences, I will just go on to highlight the lessons that we learned. We found out that in Nigeria, during a desk review, we identified at least 12, digital tools and platforms that are used for infectious disease surveillance. And many of them were not speaking to each other. And in fact, many units and departments were not aware of the existence of the other units using such tools like that. Now, the lesson is that when we're introducing things like this, multiple partnerships, communication, collaboration, and coordination using the One Health approach is always very, very important. The second lesson was that when we use the system usability scale to assess the ability of users to be able to navigate and to navigate around the system, and also to be able to use it without difficulty. It was learned that the learnability, which is in the ease of navigation, and the use was poorest for SOMAS, was a bit better for DHIS2. And it was better and because of this difficulty, many of the users often migrate to, open data kits, WhatsApp, Excel-based applications because of their difficulty with navigating around the SOMAS. So the lesson here is that user experience and feedback must be used to guide design. And we must have an opportunity to get these user feedbacks even after we have deployed, a design, so that we can redesign as necessary. The lesson 3, we found out that contrary to assumptions that SOMAS would improve the timeliness and completeness of reporting, we found that only in 61.3% and 58.1% of local government areas, respectively, had improvement in timeliness and completeness after the introduction of SOMAS. So the lesson here is that assumption of digital tool effectiveness cannot be held in vacuum. We have to consider other factors, and so monitoring and feedback is always very, very important. Lesson 4 is that there were technical challenges which included offline and online synchronization, threshold or data overload, poor supportive supervision, and the organizational challenges were the lack of a data transformation strategy. None were aware of that, and many said that what they do is that they adopt whatever external bodies bring in. And so they do not own the infectious disease surveillance space and rely on external forces. So the lesson from there is that online user support or troubleshooting tools, as well as supportive supervision and constant training, are needed for digital tools to be very, very effective. The last lesson, lesson 5, is that digital tools are adaptable for community surveillance, but with limitations. And these limitations will include internet subscription, access to electricity, and unclear engagement rules. So the community expressed this, that the rules of engagement are quite unclear. So the lesson is that for us to be able to use digital tools, devolve it to the community level, we need to have clear-cut rules of engagement. We need to have training and retraining, and we need also to build community trust. So I'd like to conclude that structured transformation strategy is the way to go, because this would contain all the lessons that we have put together. It will guide the national, state, and local adoption of digital tools for disease surveillance and response, including the development of appropriate tools for community informants. Thank you very much.
Thank you very much. Let's put our hands together for him. All of them are stayed within the time allotted. Now we'll go on to the panel discussion, which will last a few minutes before we now allow others to make comments and ask questions. I will start with Dr. Okoromade by asking, what are the digital tools available to us in Nigeria currently for infectious diseases surveillance? How effective are they? And then how can we improve on them?
Thank you, sir, for that question. For us as a national, Nigeria has adopted digital tools for surveillance of public health events. And across all levels in the country, both at national, subnational, and the health facility, the point of entry, as well as the laboratory, we have deployed, there's been a lot of tools deployment across these different levels. Dr. Adebi presented well over 12. I would say that we have over 20 different tools being deployed at different levels. But the main thing is that they don't really speak to each other. But I will touch briefly on the main 5. We have what we call SOMAS. This is the main tool deployed by Nigeria for public health surveillance of infectious disease. Is for immediate reporting of case-based diseases. For SOMAS is an open source and it supports real-time disease detection. SOMAS is for outbreak response management, for contact tracing, as well as for, it's also been it has been deployed at the point of entry as well. For SOMAS, in terms of efficiency, I would say SOMAS supports real-time notification of events. So any occurrence of any outbreak or public health event at any level, every level of decision-making gets being notified, and action is taken appropriately. Also, we use it to manage contact tracing so that it's very easy to link a case with contact, and also for contact follow-up. For case management, when there is an update on each case, it's easier for clinicians as well as the state epidemiologists and the surveillance officer to get notified of any update on what is happening concerning a case. And this also has improved the case management during outbreak response, and also it's a good mechanism for feedback across each level. And I would also talk about DHIS tool. DHIS tool is also a major digital tool that has been deployed for surveillance, but DHIS tool does not support a real-time notification of public health events. DHIS tool aggregates a monthly reporting of cases for IDSR 003. For some of us are familiar with IDSR 001, 002, and 003. Also, we have what we call MSAS. MSAS is a mobile SMS platform, which is used for also aggregate weekly reporting. And also the advantage of the mobile MSAS platform is that it's very easy to use at the community level where the data network is very limited. And also it aggregates cases at that level. For us, we also have what we call event-based surveillance. This is used for early alert and signal. It is an AI-driven system that is used to that is actually used to mine information across social platforms to escalate rumors or signals or events that can cause a lot of calamities within the community. So in terms of the key challenges, as I've presented, the major challenges that we have concerning these tools is funding. In terms of funding for devices, update of devices at subnational level. So subnational level, we need the state, the LGA to be able to hone and fund their surveillance system. There's been a lot of over-reliance on donors as well as the national. Even at the national level, a lot of reliance on donors. So the government needs to ensure that there is enough funding for surveillance within the health security system at every level, in terms of funding available for data, funding available for procurement of devices, and also there is also a capacity challenge. There is a poor digital literacy across every level. There is need to ensure that we keep a continuous capacity building exercise across all the state at the LGA level. And most importantly, there is need for the country to have what we call a digital surveillance governance policy. This will help at every level, or every organization or platform that want to develop or introduce a new digital system, to be able to have a set of standards and protocol to key into to protect data privacy as well as the data ethics in the country.
Thank you very much. I think you just did the summary. Left to, if we allow you to take another 30 minutes. So let me go to Dr. Simpa with this question. Mobile health and telemedicine is the in thing now, and we know that it can be quite helpful in the control of infectious diseases. How much of this have we deployed in Nigeria? And what are the achievements so far?
Interestingly, I think the way to look at it is between the public and private sector. On the private sector side, which is largely driven by entrepreneurship and that's happening, but I don't think it's at the rural level. I mean, so technology diffusion, right, kind of follows money, right, and it's explainable, right? It's just the cost of acquisition. Just we talked about devices. So just like when mobile phones first came in, right, you had very high network people, network people use that, and then it took a while before, Globe came and then it came all the way there. It's the same way that's happening. So we're at that level now where it's really being driven by the middle class use, right, and not yet at that very rural, point. Now, when it comes to the public sector, there are very few subnational programs that exist where telemedicine is being used to drive stuff at the rural. I think Lagos State did a pilot. And then you had some also around FCT, as well, and then some also in Kaduna. The thing also is that most of these pilots are driven by donor funding. And so once that funding ends, projects end.
Thank you very much. Let me go to Dr. Adebi. With the Nigerian health workers, what's their capacity to take on these digital tools for infectious disease surveillance? What is the gap like? Is it so wide? And how can we fill the gap?
Yeah, so we came up, when we did this study, the immediate feedback was that there are a few of the workers who are not trainable according to the feedback that in terms of digital tools of what we got back. But when we took this to the advisory committee level to interpret some of the results that we got, we realized the fact that it was not that they were not trainable, it was the deniability of those tools that had a problem. That is the ease of the ordinary user to navigate without difficulties. So whatever tool, digital tool that we have, it's not that our workers cannot use it, but because we do not factor in the user experience. So whatever it is, we find market women using WhatsApp that had no education at all. So if they can use that, because initially, what we found in literature is that there are some, the capacity of workers to use these things are very poor and what have you. But our quantitative study, which we had not even analyzed when we talked with the Committee Advisory Board, where it's only the qualitative study that they were interpreting for us, made us understand that it is the deniability that is a problem. And this was reinforced by the findings from our quantitative study, that is actually deniability that is a major issue.
Okay, thank you very much. Let me get back to you, Dr. Kurumade. With the deployment of digital tools in the public health landscape in infectious diseases in Nigeria, how well have we performed with types of disease surveillance?
Okay, thank you, sir. I would start by saying for Nigeria as a country, there's been a tremendous improvement in surveillance system with the rollout of the digital surveillance tools in the country. First of all is the country joint external evaluation score. As at the time we did the first JEE, where we had a score of 39, there was no digital platform for the surveillance system. And for those of us that are familiar with the JEE score, we had a score of 1 in the reporting system in Nigeria. But by the time we had the second JEE, we recorded an increase from 1 to 4, meaning that this digital tool has been rolled out across all the country and all the LGA. And that was quite significant and was part of what increased our score from 39 to 54. Secondly, a lot of improvement that has occurred. It has increased our real-time case detection, as well as case reporting and outbreak response management across the country. There's been an increase in how we manage our laboratory and the case management information sharing system across the platform. And most importantly, there's been, we have instituted the border health screening at the point of entry, which has made it a lot easier to track passengers that are coming into the country, and also to track and monitor potential imported of cases in the country. To give an example, I would touch base on SOMAS and COVID. I know my time is up, but SOMAS and COVID-19. With the rollout of SOMAS, we were able to easily detect the hotspots, LGA hotspots in the country, and that also helped us to reprioritize our intervention and to institute what we call the active surveillance case search across the hotspots in the country. And with the use of surveillance, it's part of our success story. We're able to do and aggregate and put out our daily COVID-19 daily reports on all the social media in the country for 2 years. Without that, this wouldn't have been possible. There would have been a lot of delay in reporting, but with SOMAS, that gave us an edge to have a real-time reporting system. Thank you.
Thank you very much. If I allow you, you will not allow us to go on tea break. Let me go to Dr. Simpad. There's a lot now about AI, globally and even coming locally now. To what extent have we been able to use this when it comes to applying for disease surveillance in Nigeria, or what's the potential?
I mean, there's a lot of potential, right, for the use of AI, right, within that disease surveillance space in predicting, you know, what next hotspot would be, in what new disease actually is coming out, and doing that. But you must also remember that surveillance is a state project, right? Which is very different from, you know, say, consumer-facing thing. So it's within those institutions, so like NCDC, that you will see that application, you know, growing. And I believe that there's a lot of initiative that's going on internally to drive that. A few academic institutions, of course, you know, participating and you know, driving it from that point. But I think aside from what we've done within this, there's very little private enterprise looking at that space and saying, okay, what can we do as a product to change that?
Okay, thank you very much. Our time is fast spent. Let me ask Dr. Adebi. We've talked about the community part of it. How do we use these digital tools to improve awareness that will strengthen disease surveillance, infectious disease surveillance?
When SOMAS was designed, I think it was designed to be, you know, an all-comers thing that there could be add-ons. People use a lot of simple tools at the community level. I think what can be done at this level is to look at add-ons that can be interoperable with SOMAS, so that the onboarding of information from the community level will be seamless and will be easy. Instead of developing newer, you know, tools and introducing newer digital technologies, people use voice notes, for example. And I was surprised to find out that even those who are not literate at all, you know, send voice notes, you know, everywhere. So simple things that can be adopted at the community level can be add-ons to SOMAS. We already have SOMAS. So we can have those add-ons, and it makes our job easier to get information from the community level.
Let me add to this to say, with our local languages, how can we use these digital tools to improve awareness?
I think Dr. Simpa and I had been discussing about this a lot, and we've been talking about what models are applicable that we can, adapt for local languages that probably may be able to translate some of what we find, or use icons, which community level people can be able to understand. But I think the space for research is huge in that area. And we are really exploring that. We have a few products that we are testing, and we think that with time, we should be able to come up with something that will be useful in Nigeria.
Oh, thank you. I think I will just take the last question. It's not the last that I have here, but in view of our time, yes, before we go to the audience, ask Dr. Simpa about innovations. What digital tool innovations will move Nigeria up, scale up Nigeria up with disease surveillance?
So the tool has been chosen, it's SOMAS. So it's the add-on to SOMAS now that I think that's where the innovation should come in. Just like we pointed out, can we plug in from the community level, to SOMAS? Can we make things easy? How do we improve that learnability and usability, at that level? How do you also ensure, because one of the things that we also discovered again in another study is, like, for instance, private facilities don't participate that much within our disease surveillance system, especially except designated, and which are very, very few. And if you look at all the outbreaks that we've had in this country, they've actually started out from private facilities. So I think those are the things. So if you're thinking of, like, for instance, connecting an EMR, to be able to speak and report directly into SOMAS and stuff like that, and providing notification, yeah.
Okay, you are itching to add in 30 seconds.
Okay. Thank you. So for us at National, I quite agree. We are advocating a lot of add-ons. But for us, what we're actually looking at is interoperability. So there are other digital tools. How do we ensure that we are able to link this seamlessly with SOMAS, which is the main tool? We've started this process with the DHIS, we've started with the NADIS, which is for Ministry of Agric, we've started with Ministry of Environment, but the advocacy is to ensure that every other platform also come on board and be able to link and share data information seamlessly across different platforms.
Thank you very much. Now I go to the participants. If you have a burning question, comment, and then you will be the determinant of how soon we will go for tea break. Yes, one. Then I think I can see only one. Only one. Oh, there are so many. I can't see well. Can you help? Three. Help me with the numbering, and then, four. Okay, can someone take the mic to the four? So we'll stop at four.
I'm Dr. Innocent Allen Ogena from Edo State. My question is to Dr. Adebi. In your presentation, you told us that you observed that there are too many platforms all going, and they do not even communicate among themselves. What plan or what policy change do you think we should adopt to either harmonize them or ensure that we will have at least a few adopted platforms? Because we recall that in times past, when we had so many donors at national level, there was now this issue of basket funding. How do we regulate the so many platforms that are coming on board? That's the first question. Then the second one has to do with Professor, the session chair talked about whether the capacity of the healthcare workers. And in your response to it, you talked about learnability. But there's something we have observed at the community level. There are some of these health workers that appear to be either untrainable or they don't seem to understand anything. And this also brings us to the fact that in terms of medical practice and in terms of healthcare delivery,
the medical doctor should be incorporated into the training of healthcare workers. Because in the history of medical officers of health, there were always medical doctors in any institutions where you had the training of community health extension workers or the environmental health officers. So if we ignore the training process of these healthcare workers, it definitely will fall back to us because of their inability to perform their jobs.
Thank you. The next person, let's address the questions before they respond.
Oh, thank you very much. My name is John Oladejo from CDC. You know, as a matter of fact,
Are you contributing? I'm sure you are contributing, not question.
Yes.
Yeah. Okay.
I just wanted to talk about these digital tools we are talking about. As a matter of fact, the Honorable Minister set up a committee, not quite long, to look into all these digital forms. You know, I was part of the meeting where a company called Trek Secure actually came to introduce themselves on this, and they have been in about 20 countries, so that all these digital tools we are talking about, they will be able to speak to one another, so there will be a sort of operationality. So this is very important, and I believe Aphpn should be part of it, because you know, without digital tools, without this AI, I don't think we can move to any level. Thank you.
Thank you. Next, number 3.
Yeah, thank you. I'm Michael Adedoyin from Ogun State. I have 2 concerns, and the first one is on the accuracy of the data we gather and the use of biometric systems. I'm wondering, you know, we see cases, especially in infectious diseases, we see cases of patients, you know, Nigerians being very mobile, you know, they are diagnosed in one place, they have been captured, you know, and then they move to another place, they repeat the same test and all that, and they are captured again in those places. In fact, some of them, we've seen cases where they use different names entirely. You know, so I'm wondering how, if there are steps being taken to start deploying biometric systems in capturing data in the country. And the second question, or should I say comment, is on the aspect of parallel vertical data, disease surveillance systems in the country. You know, it's not only between veterinary and human disease surveillance now, but even we have the epidemiology aspect, you know, having a national program running on that. We have disease controls the programs also having their own parallel data collection, and I'm looking at us bringing those 2 sides together so that we can actually have a more comprehensive surveillance in the country.
Thank you.
Thank you.
Number 4. I think it's, oh, okay, that's, oh, it's getting more than 4 now. Yeah.
I think this is morning. So good morning,
30
Mr.
seconds.
Chairman and the presenters. I want to say thank you. 2 quick questions. One, my name is Dr. Shewenson, OHHC Ife. I'd like to ask about accessing the SOMAS platform. Do we need any particular permission? Do I just go online and register? And if we are to access the data, what password or who do we seek permission from? As a lecturer in the department working, do we really have roles in this surveillance? I think it's like a government ministry thing, while ours is just to conduct research, and can we have access to the data captured on it? And then a very quick one. So for a young person coming up, what would you advise? Go study AI technology first and learn something on medicine to do this, or you first have to study medicine and then learn something on AI to do this, considering the world opportunities ahead and the future.
All right, thank you. And the last one in front, my my HOD so that I can get back home.
Okay, thank you so much. You know, I sincerely appreciate all the speakers. My question will go to Dr. Mrs. Okoromadu. You made mention that there are a lot of digital tools that are being used. So I don't see the reason why we have to use so many digital tools when there is one that is functioning very well, because that is just, you know, misuse of resources. Let us try as much as possible to stick to one. And when it comes to surveillance in this country, your agency is doing very great, and the foot soldiers at the lower level, especially the DSNOs, disease surveillance and notification officer, they are also doing very, very great. But what is the guideline, you know, from the NCDC concerning their selection at the HG level? Because one of the challenges you made mention of regarding surveillance is human resources. Because you discover that you train a set of, you know, DSNOs now. When you go back in the next 3 or 6 months, there is maybe political interference, and those ones will be dropped, and another one will be selected. And I think, you know, your agency should try as much as possible to have a guideline in their selection.
Okay.
So that at least, you know, we can have, you know, consistent DSNO. It's not that 3 months DSNO or 6 months DSNO, and at the end of the day, they just go and be bringing those people that are not trainable.
All right, thank you very much. We'll take one question online, and then we'll get the response. Yes, are we ready? It's not loud.
The level of the teaching hospitals and academia. Thank you so much, every other participant.
Can you repeat the question briefly in 30 seconds, please?
No, I said most of the tools elucidated by the center from the NCDC, sorry that I missed the name, how do we adapt them at the teaching hospitals? That's where we are teaching our students, both the MPH, resident doctors. How do we adapt some of these tools? How do we use them?
Okay.
And then the other ones, or do we leave them at the level of only NCDC? Thank you.
Thank you very much. So we'll get responses very briefly, please.
I'm Dr. Ahoma Mbanozuru from Newi.
Okay. I want to thank the audience for those beautiful questions, very insightful. In terms of interoperability, yes, we are aware that the ministry is doing something. The NCDC has been talking about this even at One Health steering committee level. But what is important beyond these ad hoc approaches is to have an omnibus digital transformation strategy for infectious disease surveillance, which Dr. Iladun also referred to as data governance. That will solve all the problems. Without that, new people come on board, they fraternize with external donors, and we begin the problem all over again. So I think that is the right approach. On capacity, we need to have a paradigm shift. Professor Oshibogun, a renowned teacher of teachers, have taught us, and Professor Akonde also have taught us about the right mix and the right fit in health management. The private sector would employ people and fit them to work. The public sector would fit work to people. And that
will result in a wrong mix. It will result in a wrong fit. There is nobody that is untrainable. It's just that we have to fit them to their level of knowledge, what they can do, their competence, the right peg in the right hole. That, I think, and we have seen that knowledgeability is very, very important. There is nobody that cannot use digital tools. It is just that which one is learnable for them at their level. And that's what we need to be thinking about. I think those are all the questions that I have. I'll hand over to...
Okay, let me just take off from where he said. So the key thing here is this, right, is that we fit the technology to the people, not fit the people to the technology, right? It's easier for us to change technology than it is to change people. So just quickly want to do that. Accuracy of data, again, it goes just back to that design process, right? And that's part of the findings that we're talking about here, right? How do you ensure that the system produces accurate data and not leave it just at the whims and caprices of whoever is entering that data, you know, at the end of the day? Biometrics for data, I think that's a very long stretch. It's not impossible, but again, it's just about building tools. Remember, all these things come with hardware, they come with cost of acquisition, and you know, you need to then be mindful about that. Career path. So as you go forward, right, AI is not optional, right? So it's not you do one and then go on to the other. No, you just do both of them as you're going. So you combine both the AI, whether you're doing medicine, do AI alongside with it, whether you're doing public, just wherever you are now, start and engage and begin that learning process. Because like I said, 1 week in AI is like 1 year in lifespan. What has happened, like, I mean, just yesterday, just a quick example, right? I was just reviewing some videos. Like, I could not watch anything that was 6 months ago. It was like, oh no, this will not be speaking English any longer, you know. And that's how evolving that field is. Thank you.
Thank you. Well, I'll try to be brief. There was a question talking about duplication of entries when you have a case in a particular state and then now travel to another state. So if you're familiar with SOMAS and you're a user on SOMAS, once a case is created with a particular name and details, it automatically rejects another one. And that is why if a case has been recorded in a particular case, and the individual now travels to another state, what we usually advise is for the state Aphpn to transfer that case to another case instead of creating another Aphpn number, because the SOMAS would automatically spot that error and reject. For different platforms available, there are different disease, vertical disease programs. We have different programs for TB, we have different programs for HIV and malaria, and they have systems for collection of their data. Most times, the common one for these programs are DHIS2, and that is why we're advocating interoperability. Through interoperability. There was a question about assessing SOMA's platform. There are users that are created at different levels. Even for us at national, we don't create users for states. We only create users for our national officers. At the state level, it's the state epidemiologist that is in charge of their SOMAs at the state level. And at the LGA level, we have the LGA DSNOs and the assistants. So you should be able to link, as a teaching hospital, you should be able to link to the particular LGA as well as the state to have access to the SOMAs. And you either be a surveillance focal person for your facility, or you have something to do with surveillance in terms of reporting to the platform. So I will advise that you connect with your LGA DSNO so that they'll be able to put you through on how to have access to the platform if you are one of the surveillance officers within your facility. There was a question about different tools. In terms of selection of DSNOs, we all know that Nigeria is a federated system. We have the constitution, the national does not have the executive power over what the state does in terms of recruitment. Yes, there is IDSR policy that stipulates the criteria and the requirement for the recruitment of the state EPID and the DSNOs, but yet at that, we don't have that holistic control over how the state goes about with their recruitment. So in terms of that, there is a stipulated guidelines through the IGSR policy, which is also due for review anyway. But when it comes to how the DSNOs are being selected or recruited at the state level, that power lies at the state government authority. And the question around teaching hospital, I didn't quite get that well, but I'll still refer that to this LGA closest to that teaching hospital. The NCDC, yes, NCDC is deployed summers, but the states as well as the LGA, they are in charge of their own summers and they are in charge of their own data. So if there is any training that is required for the teaching hospitals or officers, or that is required for people at that level, please kindly link up with the LGA DSNOs. We will definitely get the feedback. But that is how the IDSR framework works. We start with the LGA DSNOs, the state epidemiologists, the information flows to the national. Thank you.
Yeah, thank you very, very much. Let's put our hands together for these panelists. And that I want to apologize that we will not be able to take more questions, particularly for those wanting to ask questions online. And what? Appeal. Okay. If he's coming from BOT, we cannot.
So thank you very much. I think I've listened to some question about how the universities can access these summers. We need to build bridges. All of us here, we have, from the universities, we have departments of community medicine, we teach epidemiology. And surveillance is a key thing that is a component of what we teach. We cannot be doing theory, and we don't know the practice. So how do we build the bridges? You have all these tools that you are using. How are we going to work with you? You at least expose the trainers so that they can be able to train their residents and their students. And then how can they also be able to access the data and engage with it? I think that's what we want to know from you. Thank you.
Thank you very much for this advice. Very good. We'll talk. Take the advice first.
It's actually in the pipeline. So part of the digital transformation strategy that I talked about, the plan is to roll out summers at all the health facilities, both at the public and the private, starting with the tertiary health facilities. We've identified of course, community medicine will be our entry point. But it's actually in the pipeline, and we will soon come. And also it's good to also collaborate with Aphpn in this project. Thank you.
And finally, I'd like to thank everyone, all the participants who are here in person and those online. And we want to thank you for your patience. And we end it here. Thank you very much.
Thank you, Mr. Chair. Thank you, everyone. We'll be going for tea. We'll be back 30 minutes time. 30 minutes, 30 minutes, 30 minutes.
And there was equally a very large outbreak of Lassa fever, as well as COVID-19 in 2020. We will say that it was NCDC that led this outbreak. And we equally develop and maintain a network of public health laboratories, conducts, collates, and synthesize and disseminate public health research to inform policy. So I'm very happy when some group of researchers were actually working on digital tools. This will actually inform policy, and this will be very, very useful to us at both at national and subnational level. When we are talking about One Health, you have to look at the changing landscape of emerging and re-emerging diseases. So if you look at the map of the whole world, you will see that we have newly emerging and re-emerging diseases, as well as some other diseases that are actually being renewed. And this is very important for us to note. So this is an umbrella of what One Health concept is all about. So you can talk about non-communicable diseases. You can see the interface I'm talking about here. That is between the animal health, human health, and environmental health. So there is a particular spot where they all met, and you have to look at what are the major thematic areas we need to look at. You know, veterinary medicine is very, very important when you're talking about One Health. Then zoonosis, multisectorial diseases, antimicrobial diseases, infectious diseases. So these are what constitutes what One Health concept is all about. So let's quickly look at the term. This is, I've already, in my sectorial and transdisciplinary approach. So when you are working locally, regionally, nationally, and at global level. So it covers the whole level from the local to the global. So what are the goals of this One Health? I've already mentioned it in my opening remarks that we are talking about optimal health outcome, very, very key. And then you recognize the interconnectedness between people, animal, and the environment. It's very, very key. And the people, plants, yes. So these are the major goals of One Health. So these are the facts we really need to look at. The first thing is we have 60% of pathogens that cause human disease, and they are originating from domestic animal or wildlife. And you know that most of us, we always keep all these domestic animals in the house, and we even love it. We don't want anything to, we hold it as if it's our baby. So anything can happen between human and animal when you play often with it, especially the children. Then 75% of the emerging health pathogens are of animal origin. So we need to note that fact. And 80% of these are of bioterrorism, concern they originate in animals. So you can see that more than 70% additional animal protein will be needed to feed the whole world by 2050. And more than 20% of the global animal production losses are linked to animal diseases. So you see that we need to protect the health of animal as we are protecting the health of human. So the animal, the human, and the environment, they have to be in a very big state of protection. So these are other facts we really need to look at too. Human actions have severely altered 75% of the terrestrial and 66% of marine environments. The to survive. So you can see, I'm giving us this fact so that we're able to understand how human, animal, and environment, they interact, and why we really need to talk about One Health concept. So, One Health approach. We are talking about global health in NCDC. So in that case, so we need to know about the coordination, the communications, and the collaboration. So how do you improve these three important thematic areas? Because that is the only way we can have human, animal, and environmental interface. So we need to address this, and the only way to address this is to use One Health approach. In global perspective, we have the tripartite, the GHSA, the IHR, JE. Some of it were discussed this morning during some of the presentation we had today. And in this, we need to talk about healthy ecosystem, healthy animal, and healthy human, before you can say you are talking about One Health. So in Nigeria, I really want to talk about the overview of One Health in Nigeria. I've already defined what One Health is all about, and we have already talked about some of the areas that can contribute to One Health, like working on National Action Plan in area, and talking about the animal health itself and the environmental protection. So before 2006, we have what we call sectorial independence with little collaboration. In that perspective, there wasn't anything like a Ministry of Livestock. We have only Ministry of Agric, and then Ministry of Environment, but we are not really collaborating at all. But in 2006, when we now have highly pathogenic avian influenza, that is H5N1, so there's a paradigm shift from independence to interdependence. Some of our teachers in the house were part of this team when we first had the first avian influenza in Nigeria, where we had to have series of different teams, ranging from coordination to laboratory to logistics and so on and so forth. So then we have what we call Interministerial Committee on H5N1 to control the pandemic. And then we have Joint Control Development of Pandemic Preparedness Plan and Resource Mobilization. So these are the activities that were actually conducted immediately. There was a outbreak of H5N1. That was the time when we now have what we call interdependence. So between 2006 and 2014, you have Lassa Fever Rapid Response Committee in 2009 and 2016, Interministerial Committee on Lead Poisoning in 2010, and Interministerial Committee on Ebola Prevention. Most of us were part of it, the health, the agric, and the environment. Then multisectorial actions to disease-specific activities, like Ebola, rabies, brucellosis, and so on and so forth. Then there was actually joint training of FERTIP, and some of our colleagues here are graduates of FERTIP, where we developed short courses on zoonosis and infectious diseases, where we were training health workers on 3 months short courses. Then after 3 months, they will go for projects, and that project will now be presented. So these are the things we were actually working on in Federal Ministry of Health before we now established NCDC in 2011. So 2014 forward, so there was Ebola. Everybody knew what happened that time. That was the time when we have Global Health Security Agenda, which was launched in 2014. There was new approaches to emerging and emerging diseases. So there is a growing recognition that disease events, either natural, accidental, or international, and these are threats to public health. So we equally focus on a multi-sectorial approach using international standard. We look at the guidelines, frameworks, and so on and so forth. So Nigeria was a signatory to GHSA, and some of us were part of the team that actually that went to the first conference that was held in Mali in 2018. So in Nigeria, what are the visions and the missions of One Health? The vision is to be a nation of healthy people and healthy animals living in a balanced ecosystem. And the mission is to build a strategic, dynamic, and functional platform that advances human, animal, and environmental health through multidisciplinary and intersectoral collaboration. So it's not only the physicians that will be involved. We have other areas like vet medicine and so on and so forth that was part of this One Health approach. So, when you're talking about One Health, there's a governance structures on this, and we have the steering committee, the technical committee, and the coordinating units. At the national level, the Honorable Minister is the chairman of this steering committee, and for the technical committee, the Director General NCDC is the chairman of this National One Health Technical Committee. As we were actually coming together with Ministry of Livestock as well as the Ministry of Environment, the head of the Livestock Division is the co-chair, with the DGNCDC, and the Director of Water Pollution and the Environment is a co-chair too. So we have three of them working together to ensure that they are able to, deal with this One Health approach. So under this National One Health Coordinating Unit, which is domiciled in NCDC, we have the desk officer for human health, which is NCDC, animal health in Ministry of Livestock, and then environmental health in Ministry of Health. So all these we all operate together, and then we have monthly meeting where very important issues are discussed. When there is no outbreak, we look at each of the pillars and what are the gaps and what are the areas we really need to work on. So as today, so where are we in One Health in Nigeria? So the first thing is that we have One Health strategy plan, which was actually developed for 2019 and supposed to have expired in 2023. So, because of one issue or the other, we just started to review it so that we can have 2025 to 2029. So we have International Health Regulation, IHR, and then we have performance of veterinary services, which is PVS, bridging workshop, we have done that. Then One Health Public Health Emergency Operations Center in national and state level. Before COVID-19, we have only 5 Public Health Emergency Operations Center all over the country. But as we speak now, each state has at least one. There's some states that have 2. They have one for Public Health Emergency Operations Center, and then the polio laboratory, the polio operation center. Then we have operation center. We are planning to have operation centers in at least one senatorial district, because we believe that all these infectious diseases are emanating from the local government, from the community. So if you are talking about having it at the state level, we need to have at least in each, and then you know that 3 local governments make up of one senatorial district. So one of the biggest LGA will host that particular public health emergency operation center. But this one will cost a lot of money. So We only have it now in our plan, but we have not really started the operation. But I'm assuring you today that all the states has at least one public health emergency operation, so that anytime there is any outbreak anywhere, this is where all the stakeholders will meet, and then they will have their work done. Then we have one health zoonotic disease prioritization. Then there's equally operationalization of the joint risk assessment, and then JE. I think JE was actually discussed in the morning extensively. We've had one in 2019. We had another one in 20. We have another one in 2023 after 2017. So we're actually progressing from 39%. I think by now we're in 58%. You know, in the morning, you know, one of the slides was showing that we did it in 2020, which was 46. We had another one in 2023. I think Dr. Oyeladu was the team lead at that particular time. So this is the public health emergency operation centers which I was talking about. The 36 states and FCT were well equipped, and we have had series of incident management activities like COVID-19, cholera, VHFs, and so on and so forth. So the map showing on the left side of this place is showing that for any it's showing that it's only Jigawa states that we stay, lacking behind because they have not been able to give us a building where we will be able to equip their public health emergency operation center. But all other states, they have it, and then we, work hand in hand with them, we interact with them, and anytime there's any outbreak, we do what we call risk assessment, and from there, we are able to activate the EOC, and our colleagues from headquarters, they will go to the states to assist them in ensuring that everything works smoothly. So this is one of the sections for EOC. As I've already explained to us, we have successfully managed 61 public health incidents requiring IMS activation at national level. You can see that we have done meningitis 3 times, monkeypox, Lassa fever, yellow fever, cholera, measles, anthrax, then COVID-19 and diphtheria. So in our EOC, these are the way we manage our information. The ICC is Incident Coordination Center. So we look at SOMAS. I think SOMAS was discussed fully in the morning. And then we will look at Tatafo, Sitaware. We look at the 2 TWG dashboard, because each of those diseases, there is always a technical working group that will be looking at the data and be able to advise the DG at a particular point in time when there is any sudden increase in the number of cases that is being reported. So this is the way we are able to get our information every day. And then every 3 o'clock in the afternoon, we always have what we call public health intelligence meeting, where we will look at all the reports from each of the states, and we'll be able to say, okay, in the particular state, then there is a sudden increase in the number of cases in meningitis. So this one will now undergo what we call signal management, and then from there we'll be able to say, okay, this particular signal shows that we need to take a particular action at a particular point in time, and a report will be sent to the DG, and then EOC will now be activated. So this is the way we are able to manage all the information received from states, not only states, even from outside the country. Because sometimes you may see that there may be outbreak of disease in your neighboring country, and if you don't have that information, there may be a problem at the end of the day. So before any emergency, there must be a risk assessment that we inform either we need to support that state or not. So sometimes they will send a message to us that, oh, there's outbreak of so in my state, then we now take it up. Or sometimes we get it through public health intelligence reports, which have earlier mentioned to us. Then we always have what we call regular training. When there is no outbreak, we do regular training and dissemination exercise, among all the frontiers. We always do this so that anytime there's any outbreak, each health worker knows exactly, or each colleague knows exactly what to do at a particular point in time. Then we develop outbreak preparedness and response plan for all the priority diseases, which I've earlier shown to us. Then another important thing is demonstration of the fact that we know the positionings of response commodity. But we are actually moving from active response now to readiness, because we realize that you spend more money on response when there's any outbreak than prevention. So we are actually advocating for prevention. So if we can really look at prevention very well and be able to prevent most of these diseases, we have more money in the pocket, and then we have less to spend on response. So the pictures you are looking at, these are the pictures of colleagues that are actually on the field. Then some of them are working on the data, some of them are in the warehouse, and some of them are in the ICC. ICC is Incident Coordination Center, which is the same as Public Health Emergency Operations Center in NCDC. So during any emergency, so what do we do? So you can see that we coordinate all the response activity using an incident management system called IMS. Then we conduct tactical planning and execution, very important, and develop and implement an incident action plan for events and emergency. Incident action plan is supposed to be for the first 28 days. This is the action plan that will be presented to DG to let the DG know that, look, if you can do this in the next 28 days, we will be able to avert a lot of casualties or a lot of death. And that is very, very important. Before NCDC was actually established, there wasn't anything like incident action plan. People just go to the field, and by the time you are getting to the field, most of the people will have died, and you will not be able to do much. But now, there's a plan, and there's action that you needed to take at a particular point in time. So you mobilize the skilled workforce for the deployment of a rapid response team. This rapid response team, they have been trained on how, to respond to any outbreak, how to manage outbreak, how to ensure that the outbreak are contained within the first 28 days. Then we equally manage information sharing and communication with stakeholders. You will see some of our colleagues, they have to go to the community, they have to talk to the traditional rulers, the elders in the communities, to inform them of the major key messages that they needed to take note, and then be able to disseminate it to their ward. Then we monitor and evaluate response, and that is when we are talking about what do we do after the outbreak. You will recall that there was an outbreak of meningitis in 2017 in Zamfara State, and there was no communication between NCDC and Zamfara State for a very long time. So we had a very large outbreak to the extent that we have about 1,700, dying. But the day we were actually informed, within a very short period of time, we were able to contain it within 3 weeks. Yeah. So that is what we do during the outbreak. I have very short period of time. So after we must have contained the outbreak, so what would we do? We execute all recovery operations, and then we conduct what we call after action review. So immediately after the public health event, we had a joint review of all the stakeholders involved and be able to know what we did well, the area where we are lacking, and then what we needed to do if there should be any of such outbreak. The improvement in plan matrix, that is our action plan, we have to look at it again and be able to see areas where we are lacking. Then conduct exercises to test preparedness and response plan, and restock and maintain strategies to stockpile for commodities, because we have to reposition all our commodities in all the states, using LMIS. So this is a multi-sectorial composition of the PHOC. We have the incident manager, then we have the surveillance pillar, case management, laboratory, IPC, risk communication. So these are the pillars that constitute the One Health approach. So these are the gains from PHOC. I have only 5 minutes. So to improve coordination at national level, reduction in mortality, and efficient use of limited available resources, improve capacity development, and then collaborative researches. Yes. So this is a One Health approach using anthrax case study. You know that in January 2025, the Ministry of Livestock notified us that there was an outbreak of anthrax in Zamfara State. So a PHOC had to be constituted immediately, and incident manager from Ministry of Livestock was actually appointed, and there was a co-incident manager from NCDC. The reason why is because this is more of the animal in nature, that is zoonotic in nature, and it's from Ministry of Livestock. So the Ministry of Health and other ministries, they all come together to ensure that we have a well-articulated and activated PHOC. So putting this anthrax in focus, you can see that we established a national anthrax technical working group. We activated it, and then we were actually, talking to all the communities that are affected. So when you talk about PHOC, these are the gaps of One Health implementation in Nigeria. So we look at the weak disease surveillance information sharing between human and animal and environment. So optimal environmental health sector involvement, poor institutionalization of OH platform and subnational ties of government. It's only at the national level that is very, very strong. And we need to have it at subnational level so that we'll be able to get the actual results we are looking for. There's inadequate funding, and intelligence organization cultures differences equally affected it. So when you're talking about National OH Steering Committee, it's not always operational, especially at the subnational level. And these are the gaps we are actually observing, or we have observed, and we are really working on this. So what are the next steps for us? Our next step to ensure that all these gaps we have observed are being taken into consideration is training and retraining or to improve capacity of staff. We don't have enough staff to be able to take care of this. And then observation and upgrade of ICT infrastructures is very important. Then we need to expand the firm professionals, not just only to the health workers, but to other colleagues in Ministry of Livestock as well as Environment. And equally, continuous training and simulation exercise are required to maintain response across all public health emergency operation center, because this is where this is where our strength lies when you are talking about how to have concept in the way we have planned it. Another thing is continuous operationalization of OH at the subnational level for optimal results. So because one health concept is very, very key when you are talking about states and the local governments. Because without all this, at the national level, we are just, we are just playing. If we don't make sure that the states and the local governments really buy the ideas of this One Health concept. And then we need to strengthen the engagement with all our stakeholders. We cannot do it alone. We have to involve all other development agencies like WHO, UNICEF, and so on and so forth. So they will be the one that will help us to ensure that we expand it and then we move it to the next level. Then strengthening interoperable data. We discussed this in the morning. It's very, very key. The Federal Ministry of Health is already already set up a committee on this, and I believe within a very short period of time, it will start yielding. With these few points, I think One Health concept and the practice in Nigeria has been sort of improving, but we still need to do more in terms of workforce development, in terms of funding, and then in terms of engagement of stakeholders. Thank you, and God bless.
I want to thank him for that wonderful presentation. I don't know if we have comments. Yes, I will take two here. Please let me check if there are people online. If there's somebody online, let me know. But we'll take two here first. Dr. Aphpn.
Thank you very much, sir, for your presentation. One Health. Your emphasis during the presentation was just on human beings and animals. But you just mentioned the environment very little. Please, NCDC should not forget about the environment. This time we are talking about climate change. And you see what is happening in Nigeria, our overdependence on fossil fuel. The air pollution, even in domestic houses, in the forests, all those things going on, leading to emission of carbon dioxide and other greenhouse gases. The environment is being tormented by human beings, and we are not doing anything to handle it. So many non-communicable diseases are emerging because of climate change. Please, NCDC should not forget about the environment, how to keep the air clean. Thank you very much.
Thank you very much. Thanks for the presentation.
Sorry, before you come up, participants online, if you have any comments, just indicate by raising your hand so that we can bring you up. Thank you.
Okay. Thanks for the presentation. I was just wondering if you can throw more light on the implementation of One Health at the community level, because you talked about the national implementation, community level. Usually, how do we incorporate veterinary practice or animal health into the healthcare team at the community level? Thank you.
Okay, I should go ahead. Okay. Okay. Thank you very much, Prof. I think it's a comment and it's an advice. As a matter of fact, I actually mentioned that when we first started, environment was not part of it. But we knew quite well that environment should be part of this. You know, there was a program called Ready Cinema in our office that just ended in June last year. That was the time when we now started bringing, it was World Bank project. That was the time when we now started bringing environment, Ministry of Environment into what we're doing. In fact, they only utilized 1/4 of their own budgets because they were not really forthcoming with any plan that will really help us to really improve in on One Health. So it was only human and animal that actually clear all their budget. Environment was still very much lacking. And most of the time when you call them for a meeting, they hardly come. And when they will come, they will send somebody that will not be able to take any decision on whatever we are doing. And that was very bad. But what we now decided to do now, because we are going to have another project called Hope, and they are going to be part of it. We are going to really conduct a lot of advocacy to them, especially to their honorable ministers and their peers. We need a very high-ranking officer to come to that. You can't just send the level 7 officer to a place where we have level 17 peers seated. So if you want to do anything, they will not be able to take any action. And it was as if this One Health concept is a new thing to them. I think another thing we need to do is to really train them, to really send them out, to train them, to ensure that they are well trained, to know exactly what they are expected to do. So thank you very much for this, sir. Then for the implementation at the local level, you will see some of my next step, which we are planning to do, that we really want to take it to the community level. We were only at the national and the states, but the community, they have not really taken it. And before we get to the community, there's an interface, that is local government. So we are actually bringing in the DSNO at the local government level, the health coordinators at the local government level, to really understand what health concept is all about. And then we are reviewing our National Action Plan for 2025 to 2029. So all this will be part of what we are going to incorporate into that document. I hope I'm able to confuse or convince you. I don't know. With these little words of mine, I think I've been able to convince you, not confuse you, or what Health is all about. Thank you very much.
Thank you very much for that wonderful presentation. We move to our next plenary session, and that will be on the reproductive health session. So to chair this session, I want to invite Professor Adesegun Fatusi, the former Vice Chancellor of UNIMED Ondo. Please let's make him welcome.
Good afternoon, dear colleagues. Members of our BOT, our national president, and every member in the executive. This session is going to focus particularly on adolescent health, and I would like to invite the presenters that will be part of this session. First, I would like to invite Professor Adeshola Olumide, who is the President-elect of the Society for Adolescent and Young People's Health in Nigeria, Aphpn. Please welcome Professor Olumide with me. Secondly, I would like to invite Professor Esther Mvuladu, who is the Secretary General for the Society for Adolescent and Young People's Health in Nigeria. Last but not the least, please welcome with me Professor Omosife Maduka, who is the chair of the local organizing committee for the 2025 Nigerian Conference on Adolescent and Young People's Health and Development. Where's Omosife? I'm sure she'll be joining. As you could see, as you could hear me, everybody seems to come from one body, even though this was said to be adolescent reproductive health. This is going to be a session on adolescent health, and this is sponsored by the Society for Adolescent and Young People's Health in Nigeria, Aphpn. Aphpn is a national platform for advancing adolescent health in Nigeria. And every 2 years, it holds this conference, starting from one that happened in 2019 in Ibadan, followed by one in Abuja, followed by the one in Lagos, and now we're going to Port Harcourt, come August this year. Let me quickly acknowledge in the room a number of people as we start this session, as I await the arrival of Omosife. Let me recognize and thank Professor Kufodeyemi, who was the chair of the local organizing committee for the last conference in Lagos, a wonderful conference. And let me also recognize the engine room for that conference, Professor Olade Wright, who I also know is in this room. One of the things you notice, this session is about looking at adolescent health and how to conceptualize the role, not just the role of public health physicians, but how do we advance that field. One of the things you will see as you review the history of adolescent health development in Nigeria is that public health physicians have been at the forefront of developing the concept around that agenda in Nigeria, leading the work and all of that. But there is a newer dimension, particularly as many other professionals are coming in. We have a lot of pediatricians coming in now. For example, we have people in mental health talking about adolescent health. And one of the agenda we are looking therefore at in Aphpn is to move the agenda forward, not just the issue about adolescent health, but also begin to step more and more into the realm of about adolescent medicine. What would this be? How do we need to advance this? How do we begin to step into the next dimension of that dialogue? And today, when somebody is appointed, for example, as a pediatrician, like a true life example, in the Federal Medical Centers, like 2 weeks ago, called me and said, oh, I want to start adolescent health clinic. I talked to 2 people. They said, go and call Fatusi. We'll tell you what to do. I'm like, Fatusi. And the question is the fact that what do we have? In other words, there are gaps. There are people looking for solutions. How do we step into that gap? How do we meet those gaps? Those are part of the things that we're going to be talking about today. But this session is not really about us just talking. It's also an opportunity to listen, to share ideas, and to harvest input into the concept and ideas we are developing towards ensuring that Nigeria moves to the realm of adolescent medicine in a purposeful way, and with public health physicians playing a foremost role. So again, welcome with me our 3 presenters this morning, Professor Adeshola Olumide, Professor S.M. Buladu, and Professor Maduka Omosife. We'll start this morning very quickly. Is it morning? Why am I thinking morning? All right. Let me start this morning. Professor Buladu, that's the morning again. It is when you wake up that it's morning now. And Emmanuel, where I belong to, we only say morning, we don't know afternoon. I'm sure people from Nitri will agree with me. So good afternoon. Now it's afternoon, Abi. All right. So Professor Buladu will start us off today, just talking a little bit about what Aphpn is, so that we understand the broad dimension of what is bringing us to this realm. And very quickly after that, Professor Maduka will tell us what is the agenda for our program in August, and Professor Olumide will then step on to cap that off with beginning to identify core elements around our thoughts about adolescent medicine in Nigeria and how to begin to conceptualize and advance it. I will finish it hopefully with listening to you with about 15 minutes to get some good input. So, Professor Esther Ebuladu, Deputy Provost, College of Health Sciences, University of Jos, and Secretary General of Society for Adolescent and Young People in Nigeria. Please welcome her with me.
Good afternoon, everyone. My greetings especially to the BOT seated here and all my senior colleagues. So I'll be taking us through a bit about safing. I'm sure a lot of us have been hearing safing, but just for the benefit of doubt, we don't want to assume that we all know what safing stands for and so on. So here we deal with young people. So you see, this is one of the events, and that is what safing actually drives importantly. So safing actually stands for Society for Adolescent and Young People in Nigeria. It is, this society was actually established in 2016, and it came on board really because of the need for adolescent health. It saw a gap in addressing the issues around adolescent health, and in order to actually carry even the young people along, we included adolescent and young people, and that's also in line with both WHO definition for adolescent health, what the national policy looks at in terms of adolescent and young people, and then considering also the definition of youth. So to carry everyone around adolescent and young people, we included that in what we look at. So safing is actually a platform that is not only one discipline. So it, although we drive we advance health and development, and because of the health dimension and the development dimension, there is a multidisciplinary organization. So we have public health physicians there, we have clinicians there, we have people who work in the space of adolescent and young people, both government and non-governmental organizations. We all collaborate and work together. When there's a need, we extend our hands to them, and we also make ourselves available. But then safing drives the initiative, and we also drive the program for adolescent and young people. What safing does is not a standalone. We don't run it just on our own, but we actually align with the national policy so that we're not running a parallel program or activity. So we align it with what the national policy on adolescent and young people is all about. I will show you shortly, but you'll see that, you know, when we talk about adolescent health, what comes to mind for most people is that we're talking about sexual and reproductive health, but that is not it. We're way beyond sexual and reproductive health, because adolescent health issues cut across every area. So we will soon show you that, but you'll see that we also look at nutrition, communicable diseases, and non-communicable diseases, mental health, oral health, and so on. So safing actually promotes positive youth development, like I mentioned, and then we also look at prevention of illnesses, and we're concerned about the quality of health care of adolescent and young people. And to let you know that we stand in the forefront in providing the platform and a safe space for adolescents. When we carry out our programs, we ensure that adolescents and young people are able to express themselves. So we give them that platform to express themselves. It's a safe space for them when they come to our activities. They acquire knowledge, and there's a lot of knowledge sharing in our own activities. So there's knowledge sharing, and we build capacity. not only capacity of the young people, I mean adolescent and young people, but even for those who work in the space of adolescent and young people, we actually build their capacity. We allow adolescents and young people to showcase their talent and their creativity, because we give them the opportunity to display what they have, and we also stimulate them to think, as it was said here, not just out of the box, but even throwing the box away. We allow them to do so, and they're able to build skills because we give them the opportunity to build more skills. So I had mentioned earlier that we look beyond sexual and reproductive health, and in line with the policy, the thematic areas for adolescent health, this is our own area, or these are our area of focus in adolescent health. So we have, yes, let me start with what we all know, which is sexual and reproductive health, but we also look at eye and oral health, nutrition, mental health, disabilities, because there are also adolescents and young people with disabilities that are left out, but we carry them along in our program, so they are also our area of focus. Non-communicable diseases, violence and injuries, and then substance use and abuse, and looking deeply into their mental health. These are the things, the areas that we actually focus on in Aphpn. These are not all the activities, but a bit of what we do. We do most of the work that we do. I would like to mention here that you may see us seated here. Probably we should have brought in an adolescent here, because in most of our programs we carry adolescents and young people along. All our activities are driven by adolescents themselves. We only give them support. So, but in promoting health and promoting the well-being and quality of life of adolescents, we actually advocate for them. So we're more of the advocates for adolescents and young people. And as part of our activities in building the capacity of adolescents and young people, we organize webinars. In training, we provide webinars on different topics, and just recently we just carried out one in preparation for the conference that is coming up. We carried out a webinar on abstract writing, and we're going to have another one on the 14th again on how to write abstract for programs. We are able to set facilities, set up facilities for people who want to do so, to provide services for adolescents and young people. And in addition to that, there are people who work in the space of adolescent, but probably are not, do not have the capacity to do so, or do not have enough knowledge or even skills, or their competencies are probably not optimal to provide services for adolescents. We actually provide the platform to train them. So we build their capacity and also develop professionals who are interested in working in the space of adolescents. One of our core strengths, again, is conducting research. We conduct research in all the thematic areas that I've listed earlier on these thematic areas, this focus area that you see, we conduct research in all that. And we do our research also not alone, but we also do that with some international organizations who also partner with us. One of the research that was just published, I think, is the youth index, and we are looking to doing more of that. So that is what we do. Another thing we do is also implementing projects. We implement projects in collaboration with organizations that seek our assistance. We're able to do so, and then we also can do on our own when we see the need to do so. Importantly, one of the platforms that we provide for adolescents to gather together, adolescents and young people to gather together in mass and then carry out so many activities, is our conference, which is very popular with us. And like Prof mentioned earlier on, our conferences are usually organized after 2 years. And that's because we allow ourselves time to plan properly for the next conference. the last conference was in Lagos. I don't know, there are people who were there. ECHO 2023. That was an amazing, yes, I can see some hands up there. Yes, for those who attended, you can attest to it, that it was an amazing conference. And we build on what we have done. We improve on what we have done. And we can assure you that for the next conference, it will be better than what you witnessed in ECHO 2023. Yes, a round of applause for that. So, and it is not, we're not just making empty promises, but we can assure you when you come, you will attest to that. We had the first conference in 2019 in Ibadan. And then the second conference was in 2021 in Abuja. And the conference in 2021 happened to be a combination of both second national conference and the first African conference on adolescent health. So we are not just domiciled in Nigeria, but we are also known outside Nigeria, African countries and others who join us in our own activities. The third conference was in 2023 in Lagos, and then our upcoming conference, which promises to be more exciting, more productive, more engaging, is the one that is coming in Port Harcourt, Garden City in 2025, this August 13th to 16th. But I won't say much about it because Professor Maduka will come up and tell us a bit about that. Some have been asking about our membership. We're open. We're open to people joining us, especially those who are interested in working in the space of adolescent health, young people, youths, and so on. We're open for you to join us. So we have basically two categories of membership. We have individual membership and we have institutional membership. For the individual membership, we have full members, we have associate members. Associate members are actually students who are also working or interested in doing things around adolescent health, and then youth, of course. We also have fellows and we have full members. For all of this, you pay dues. So we have dues that you pay for you to be our member. If you want to know more, we'll let you know how you can join and become a member. For institutions who want to join, we have the subscription for that. Institutions, we want to 10 persons, 11 to 50, and even larger than that. And as you can see, it's not just for that, even government and then NGOs, academicians are also welcome. Universities can actually subscribe to be our members. If you want to know more, because we have just limited time, and honestly, we can't tell you everything about SAFIN, but if you want to know more, you can actually visit our website and join us, or you can register also for the conference. But just to end this, I want to say SAFIN remains committed to championing adolescent and young people's health and development. We can dare to say we are the leading organization when it comes to driving the agenda of adolescent and young people in Nigeria. Thank you very much.
Thank you very much, President Vulaju. Let's go straight to Professor Maduka. Just as Maduka walks onto the stage, let me highlight 2 or 3 points from what she has said. By the way, we have our program officer, Mrs. Kende Alalade. She's standing right there. If you have any question about SAFIN, you can always ask her. One of the opportunities that SAFIN provides, particularly for public health physicians who are working the space of adolescent health, is mentorship. There is no policy in this country on adolescent health that I would not have noticed was led by a member of SAFIN. There is no national research on adolescent health where you won't find SAFIN members playing a lead role in that. So it's a place where particularly younger colleagues and find mentorship and support for building their capacity in adolescent health. Let's welcome Dr. Professor Maduka, who is also the Director of the Center for Health and Development, University of Port Harcourt, in addition to being the Chairman of our local organizing committee for 2025 conference. Professor Maduka.
Thank you very much, Oga. Thank you, sir. Good afternoon to my teachers, elders, and colleagues. Some of you may be wondering who know me as a core die-hard epidemiologist. What is Maduka doing with adolescent and young persons' health in Nigeria? And there are two things that is making me stand here. One is the enigma called Professor Adesegun Fatusi. Let's put our hands together for him. When Professor Fatusi says you are doing something, forget. You've already finished doing it. You just tell him, just date, time, when, where is it happening? It's a done deal. And that was my response when he approached me and said he needs me to lead this charge. The second thing is that there is nothing you are doing that if you do not think about the health of young persons and adolescents, there's nothing you are doing that will be successful for the future. You may be successful today, but if you don't think about young persons, adolescents and young persons, we have failed the future. So for me, it's really important and critical. My responsibility is to give you a very warm welcome to Port Harcourt 2025, where we will have the fourth conference, national conference on adolescent and young persons' health in Nigeria, Aphpn 2025, holding in the Garden City between the 13th and the 16th of August at the Obiwali International Conference Center. If you know Port Harcourt and you've been there recently, you will know that that's the best place for us to have conferences. And you will also know that Port Harcourt is famous for executing the best conferences in Nigeria. It is true. It's true. I think 2024 would have erased any doubt from your mind. Those of you who came for ASCAP, those of you who came for WACP, and all the other conferences that have happened recently in the Garden City. So we want to welcome you. The theme for our 2025 conference is the evolving adolescent and youth in a digital age. How do we build resilient young people in a changing world? Please note that this theme came about many months of discussion and deliberation, and all the other sub-themes that are offshoots of it address digital citizenship and ethical engagement, address youth empowerment and entrepreneurship and civil engagement, address adolescents and the JACPA phenomenon, address young people, climate change and a sustainable environment, and then how do we leverage technology for young people's health and social development. Finally, we want to find out how to bridge digital gaps among adolescents and young persons in Nigeria. A couple of things are different about Aphpn compared to other conferences. Aphpn conferences, number one, have a youth pre-conference that is almost 100% run, managed by young persons. And that's such a fantastic opportunity for young persons to actually come on board, run this thing like they would want it run, and you find out the dynamics are different. You have art, you have music, and you have all manner of things that make young people happy and excited, but you also have content. You have content, you have presentations by young people for young people, and it's actually quite exciting. Another thing that makes this conference very interesting is that it pulls together experts from all walks of life, multidisciplinary, like Dr. Mboladu said, who are passionate about the health of young persons. So we go even outside of professional organizations. We go outside of academia. We talk to media. We talk to advocates. We talk to people at the grassroots. We talk to SUG, student union groups, and other organizations that are very interested in young persons' health. And of course, we engage 100% the young persons. I'm particularly honored to be the chairman of the local organizing committee. And there was a picture that Dr. Mboladu showed, the first picture on her slide. That's a picture of us in a recent event that I'm going to talk to us about. So the roadmap for us up to this point has been such that we are the fourth in the series of conferences, like Professor Mboladu said. We always start our conference planning with thinking about a unique logo, something different. Can we have that back up, please? A unique logo, something different. And the unique thing about it is that it's designed by young persons. So we had a logo competition. If you look at the logo at the top right-hand corner, we had a logo competition in 2024, and we got young people. We advertised in national dailies, got young people on social media platforms, got young people to design the Aphpn logo for the 2025 conference. And this is what they came up with after we had merged a couple of their logos together. And we had an event, we call it a logo launch, and that's basically what kickstarts our planning for the conference, which held in September 2024 in Port Harcourt. And it was a jam-packed event, was exciting, and we were able to honor the winner of the logo, the winners of the logo competition at that event. We've been having abstract presentation, capacity building sessions. We had one Wednesday, 5th, and then another one on the 14th. So please, Professor Fatusi will be speaking to us on the 14th of March about how to write a program as abstract. You don't want to miss it. It's Zoom, it's free. Please join. So what do we require from you? Professor Mboladu has talked about membership, so we want to remind you, please go to Aphpn.org, www.aphpn.org. Go there now and become a member of Aphpn. Number two, please put a slash. When you do www.aphpn.org, put a slash and put conference. It'll take you straight to our conference website. Please register for the conference. There is a discounted registration fee for members. So do your membership first, then come and pay for conference. You'll get our conference registration discount. Please register for the conference. Start to pack your bags now. We are ready to host you in a fantastic way. Please also, we're calling for partnerships. We need sponsors and we need exhibitors. Please interact with me or any member of the Aphpn team. Alalade is there. She will be able to talk to you about how you can partner. We have partnership packages, and it's something that is going to be quite worth your while to connect with us. Please connect young persons. Put it on your Instagram, Facebook, LinkedIn handle. Connect us with young persons. And if people cannot come, get them to come in person. But if young persons cannot come in person, we will have satellite hubs all across the country where they can feed into what's going on live as the sessions and as the conference is going. And then finally, call for action, submit abstracts for the conference. With that said, I want to let you know that myself and my co-chair is Indy Freke. Indy Freke is a person living with disabilities, and that is in line with our mantra to always include that demography in our planning and execution for Aphpn conferences. It's going to be a fantastic time, and trust me, I've never disappointed in a conference hosting by the grace of God, and my team will not this time around. It will be better than ECHO 2023. Thank you very much.
Thank you very much, Omosibe. I think now let's go to the core dimension. One of the things we've done to move the dial forward for adolescents in Nigeria is a conference. For those who might remember or recall who work in the adolescent field, the 2021 conference was the place where the Nigerian latest national policy document on adolescents was launched. So partners look forward to our platform, to conference, to launch new policies, to launch new agenda, because it's the only national platform that we have for adolescents. With that said, like I told you, the next agenda for Aphpn is moving the new dimension around adolescent training, for adolescent medicine training forward. What would that be like? What will it take? Join me as I welcome the president-elect of our society and the director of the Research, Innovation and Management Office in the University College Hospital, University of Ibadan, forward, Professor Olumide, Adishola Olumide, who is also the Vice President for Sub-Saharan Africa for the International Association of Adolescent Health. Thank you, Professor Limle.
Thank you very much, sir. Good afternoon, my teachers. Good afternoon, professors. Good afternoon, ladies and gentlemen. It's a pleasure to be here with us this afternoon to share a few thoughts that we have about advancing adolescent health in Nigeria. And so, oops, that has been chopped off. So the title of my very brief presentation is Advancing Adolescent Health in Nigeria, Conceptualizing Adolescent Medicine Training in Nigeria. And I'm sure that by the time I'm done with these few thoughts, we'll all start thinking about going forward, what do we need to do to have a proper training program that our doctors can tap into so that they are better able to deliver health services to our adolescents. All right, let me just move on because of time. Okay, so in case we are not very sure, adolescents are people 10 to 19 years of age. This is the definition that WHO has given to us and which our Federal Ministry of Health also aligns with. We all do know it's a transition period, and it's a period people are undergoing various changes: physical changes, mental changes, cognitive changes, and psychosocial changes. One thing we like to emphasize about the adolescent age group and the adolescent period is the fact that they are neither children and they are not adults. They are adolescents, and they should be treated as a definite group. So why then do we invest in adolescents? Why is it important that we have a society for adolescent health? Why is it important that we start looking at adolescents differently and thinking about how to shape the types of health services that we give to them? Various reasons. First of all, demographic reasons. I mean, adolescents comprise about 20% of the population or more in Nigeria, globally about 16% of the population. And if we look at the, now I don't know which is the, I hope I don't turn it off. Yeah, all right. If you look at the line graph, the blue line graph shows sub-Saharan Africa, just showing us that in a few years' time, by 2050, the total numbers of adolescents in sub-Saharan Africa is going to be higher than every other country. Currently, the highest numbers of adolescents are in Asia, but by 2050, we're going to have the highest numbers of adolescents in sub-Saharan Africa, and we cannot afford to ignore this demographic. Another reason is for human rights reasons. And so governments have said they are going to do things for adolescents. We have the Convention on the Rights of the Child. We have various conventions, also various protocols also in Nigeria, various things that have been signed by our Nigerian government. And so we like to say that like other categories, other groups, like mothers, like children, like geriatrics, adolescents also deserve to be heard. They have a right to life, they have a right to education, they have a right to health, and they have a right to all the good things that life can offer. So the next one is the fact that we have global and national commitments that have been made. So we have here the SDGs, and then recently we have the West and Central Africa commitments. And then also in our country, Nigeria, we have our national policy on the health and development of adolescents and young people's health in Nigeria. And through these various documents, governments have pledged to do some things for adolescents. For these reasons, we like to say that we want to hold our governments by the hand and say they must deliver on the promises that they have made. Also for economic reasons, whether we like it or not, adolescents also have a right to their own fair share of resources. In addition, it's important that governments put money to improve structures and improve systems for adolescents. For instance, putting money into education, putting money into immunizations for adolescents, ensuring that adolescents are trained so that they can be better entrepreneurs. That's also another reason why we invest in them. And for adolescents themselves, they also do contribute to the GDP. A lot of adolescents these days are involved in work. They do all manner of work. They are online working. And so because they also contribute, it's imperative that we ensure that their health is secured. And then the final one, which is kind of like our own purview, is the public health reason. Now, many people try to say that, which is true to some extent, that adolescents are relatively healthy. That is true. However, they still do contribute significantly to morbidity and to mortality. And the distinct thing about the adolescent phase is that this is the time when various health risk behaviors are instituted. And not only do these health risk behaviors affect the adolescents as adolescents, it affects them as adults. Indeed, data shows us that about 2/3 of the health problems that come up during the adult years have their origins in risk behaviors that were started during the adolescent years. cares. We have things like smoking, unsafe sexual practices, sedentary behavior, the various types of diets that adolescents start to take on during this period. They all show up as morbidity and mortality causes during the adult years. And so for these reasons, it's very important that we have health services that particularly address adolescents. If you then look at the slide we have here, do adolescents require specialized medical care? We have care for neonates, we have care for pediatrics age groups, we have care for adults, we have care for the elderly. But then there's that growing gap in between where we don't know what to do with them. Imagine a 10-year-old lying in a cot in a pediatric ward, or imagine a 13-year-old being in the same room with crying 2-year-olds. That is not appropriate. And so it's not surprising why many adolescents do not come to clinic. Many of them do not seek healthcare services because they know that what they are going to meet there is not what is palatable to them. While adults don't mind sitting in a waiting room for 1 hour to access services for themselves or for their children, adolescents cannot stick it. While adults can sit down in a place that doesn't have air conditioning or where the seats are falling apart, adolescents will walk away. And so because we are not deliberately focusing on them, we are losing this group and they are falling through the cracks, and basically they are getting used to the fact that they don't need to access health services. And for this reason, we must start to focus on care that really addresses their needs. Other reasons, like I've mentioned, they are often attended to as children by pediatrics or adults in internal medicine. Sometimes the only health issues they assume to have are SRH related. Many times people think it's all about sex for adolescents, but they have other things that are going on in their lives. Professor Mvuladu showed the different areas that we focus on in our Society for Adolescents and Young People, just showing that the adolescent is way beyond just sex and sexuality alone. And we also know that many doctors currently attending to adolescents are not adequately trained for this role. Adolescents are not going to say yes or no. Adolescents are just going to sit at you. They're probably not going to give you what is wrong with them. If you ask, they have come in with an STI, and they are the most likely age group who are going to spin you around in circles about what their problem is, and then they'll go away and you wonder, so what did this person come to clinic for? The person has come either to talk or to sound you out or to find out, is the information I'm giving to you going to be confidential, before they then come back maybe weeks later on with their real problems. And so we need to be prepared to handle this distinct and unique age group. Now, this paper puts it in a very succinct way, talking about the fact that a very striking finding is the paucity of adolescent medicine specialists in areas where the population of youth make up the largest proportion of the general population, such as Africa and Asia. And so generally, there is a paucity of adolescent medicine specialists globally. Everybody knows that. However, in countries like Nigeria, in regions like Sub-Saharan Africa, where we know that our adolescent population is getting larger and larger by the day, this paucity is felt in a more alarming manner, and we do need to do something about it. So what are some exemplars? We don't have something now doesn't mean that nothing is being done. And so we have subspecialty training in the US. This is a 2 to 3 year adolescent medicine fellowship typically in the US. In Canada, it's a 2-year subspecialty training, which is integrated into pediatrics. Then we also have some other courses. We have the leadership training, the LEA program, the leadership education and adolescent health program in the US. That is also run for non-doctors. So nurses can also run this program. Doctors can run this program. Clinical psychiatrists, clinical psychologists also run this program. And then you have the very famous short course, the European training in effective adolescent care and health. And at the time when I was going to move into adolescent health, I spoke with Professor Fatusi, and we both attended this course. Now you can imagine people from Nigeria going to attend a course that is strictly designed for European citizens and for European clientele. We had to do a lot to try to adapt it to our environment. And indeed, a number of our doctors who want to delve into adolescent health have been attending this program. But what can you really learn in 2 weeks? So other things that have been done, the World Health Organization has the core competencies in adolescent health and development for primary care providers. This is currently being revised because they want to ensure that the competencies that are being acquired are relatively uniform globally. In Africa, we also have a short course in adolescent and youth health in South Africa. In Nigeria, we have our Federal Ministry of Health clinical protocol, and last year it was revised. Now, that protocol presents some amount of information for clinical training, for clinical expertise, but like was written in that manual, it is not enough for anybody to go through that manual and then think that they're going to be pouncing on adolescents and taking care of them. Then we have the Adolescent Health in Sub-Saharan Africa training as well. That used to be run in OAU, but it hasn't run in a couple of years. We're trying to kickstart it. And then our colleagues in psychiatry have actually gone ahead, and we have subspecialty training in child and adolescent psychiatry. But psychiatric problems are just one of the many problems that adolescents have. And so these efforts are inadequate to meet our teeming population of adolescents in Nigeria. So what are some of the thoughts that I have, or the thoughts that we have put together? One is the fact that, do we actually have a healthcare workforce? Do we have enough people who are interested in providing services to adolescents? I would say yes, and Professor Fatusi has actually confirmed that by saying that a couple of days ago, somebody was still asking him, how do I set up an adolescent health clinic? Now, thinking also about the duration of time, how many years do we want it to be? 1 year, 2 years, 1.5 years, 18 months. What are the kinds of things we want? Now, we know that there are different audiences. We have the audiences that might want to do more like a subspecialty training, and we do have audiences who are already entrenched and working with adolescents, maybe in school health or in companies or in university healthcare facilities. They might require a shorter type of training. Then thinking about the competencies, these really have to be underpinned by our realities in Nigeria. And then what conditions do we want to prioritize? What are the conditions? Some of the ones, I think I took a look at the one in Canada, and a large chunk of what they do focuses on eating disorders. Now, that might not be our own reality in Nigeria. So whatever it is we put together has to showcase what our realities are. All right, so our closing thoughts. One is, do we require subspecialty training in adolescent medicine in Nigeria? I think I would say yes, and I think everybody in the room would also agree with me and say yes, hopefully. And then, do we have the manpower that can be trained? Definitely yes as well. Do we have the clientele that require these services? I would say yes, because we do have 16% to as high as 23%, 20% of our population who comprise adolescents. Thank you very much for listening. And I'll hand over to Professor Fatusi for the discussion.
Thank you very much, Professor Lumide. Please, can you move on to that slide where you have questions? Okay. We have good enough. We have another almost 20 minutes or 25 minutes to, by my watch, it seems to me that we have spent like 45, 20, how many minutes, sir? Fantastic. We have 15 minutes more. Let me again thank Professor Lumide, Professor Maduka, and Professor Evula. Please join me to just applaud them one more time. Permit me to go back to that slide and raise a few questions. There are things that are quite clear. I know that when I started residency, not when I started, not even when I finished, when I came back to the university after I had gone my first missionary journey to go and work in UN and come back, I remember when I first mentioned that my field of practice would be adolescent health, people told me, what nonsense are you talking about? And they even asked me, they said, I thought you want to practice public health. This is not part of public health. I'm sure that today we all know better. And therefore, if this sent to you as being futuristic, the same way adolescent health sounded like being futuristic a few years ago, virtually every resident doctor knows something about adolescent health. Virtually every one of our training, every one of our revision course, we have at least one lecture on that, and there are questions on that. And so for us, this is the next agenda. And so the questions we want to pose are, we want to leave this as matter for discussion. Number one, for example, what is the healthcare workforce? In our mind, we are looking at the subspecialty training that will people 4 areas. Public health. The advantages for those of us in public health and community medicine is that we are in a field that combine active clinical practice with active preventive practices and loaded also with the issue around, thank you, also things that have to do with policy, advocacy, and promotion. So at the center of what should happen in adolescent medicine. The second area we're looking at is the field of pediatrics. Not all pediatricians will be adolescent health specialists, but some will want to be. The third area we are looking at is family medicine, because there are a lot of things they're doing already in family medicine. They are like our immediate first cousin. And the final area is mental health. We feel that those of us in public health, with those in mental health, with those in family medicine, and with those in, what's the other field I talk about now? Pediatrics, can come together for those who are interested. In fact, we started a clinic in Ife years ago, before I did my second missionary joint to God knows where. You know, where we were doing a joint clinic like every week. And I think that because of a few issues, it didn't survive much after those of us who are leading it left to other places. But we found that that can be a model. Would that work? Does that make sense? Should there be a different approach to it? So that's one of the first questions we'd like to pose to you and get to have your reaction. The second issue we'd like to do is, what should we do? Of course, there'll be options, but short courses are always there. Like she said, we used to run a short course for Sub-Saharan Africa in Ife when I was in Ife, when I was on ground in Ife. And people are coming from different countries, Uganda, Tanzania, to come to that course. That can continue, but when we talk about the specialization, what would be our ideal? A 1-year course? A 2-year course? Where will we run this? Because this cannot be a theoretical thing. Are there centers that are more primed and are more ready to embrace this? When we had our first conference dating back to 2019, I remember somebody came from Kaduna State University, I think his name is Adebi, who just finished his pediatrics training, and who told us, I want to start a docent clinic. What do I do? That was 2019. Somebody asked me 2 weeks ago. In other words, that's a question that has been widening. So, are there centers that are more primed to do this? And finally, what are the conditions that we need to specify for people to practice? And of course, we need to begin to talk to our colleges. Luckily, National Postgraduate Medical College and West African are already doing some specialty training. And many of the leaders are in this room. What do we need to do to step this forward? So I open the stage for discussion. Questions, clarifications, discussions. We have 12 minutes to go. All right, I can see one hand there. I can see, where is, somebody has to help me. Where is Kendi? Kendi, please come and help me. By the way, let me announce, we need, for each state, we have some banner that we would like to give to you. Please to help us take back to your state. And like it was announced, when we do our conference, we don't just meet somewhere. We also have satellite stations everywhere, in Maiduguri, in different places. So if your center is interested in holding a satellite center, we will fund it. You will get young people to come together in that hall, follow the conferences free of charge. That's part of the thing we do in SAFIN. How many can we take? I can see one hand there, number one.
Sorry, sir. We still have online participants.
All right.
If you are online,
Okay.
you are online and you want to make comments, please indicate.
All right.
So that we can.
So we'll take 6 in this room, and we'll take 3 to 4 online. Kende, I have one hand there. Number 2, number 3.
So we may
number
not be able
4.
to take up to 6, please, sir.
Sir?
We may not be able to take up to 6, sir.
No, we'll do 6, but 1 minute. We have 12 minutes. So, half a minute, half a minute each. Number 1, number 2, number 3, number 4 somewhere there. All right. I think luckily there are only 4 that I can see. All right. Kende, if you find 2 more, please give them the opportunity. All right, Ma.
Yes, thank you very much, Professor Fatusi, and thank you for all the presenters that have made this very wonderful presentation. My name is Dr. Zainab Gwaru Muhammad Idris. I happen to be a staunch member of Aphpn, as well as the National President-elect of Medical Women Association of Nigeria. You will not recall, Professor Fatusi, you were in Kaduna for one Global Fund survey, and you were in my office where we had a deep discussion around issues of funding for various interventions that we had at that time, including for malaria. For me, adolescent health is really a critical issue. And when I saw what you're doing, I've also sat on a panel for SAFIN, by the way, in one of the conferences that you held in Lagos, the very last one you had in Lagos. And one of the discussions we had is that we don't have enough reach. We have not really saturated the space, and we need as much of our healthcare workforce to be attuned. I'm happy you presented it here today in part of what you have said should be the next steps. I wonder how we can really get everybody involved and engage on adolescent issues. For instance, one of the programs that I recently coordinated has to do with adolescent health. Kaduna happened to be the only state that adolescent health and nutrition as a key intervention area. And we had a lot of insight. We were able to make some inroads, and we, perhaps maybe after this, I can share some of the key outcomes of that intervention. But what am I saying here? We have not really done enough to reach the nooks and crannies of this country. Yes, you may be in some zones within the country, but I'm not sure the northern part has been well penetrated. And we need perhaps to partner to see how we can move this forward, because SAFIN is a platform that can actually achieve that agenda. But then what is the government also doing? How far has the government, both at the federal, state, and local government, been involved on adolescent issues? These are questions that we need to also respond to. Thank you.
Thank you very much, Ma. Because we won't have much time, maybe I'll say two things as we go to the next person. Thank you, and I'm glad you are here. And M1 is a great partner for us to work with. Two things I'll quickly say. Number one good news. After Port Harcourt, the next conference is JOS. We determine our conference ahead, so we are coming more to the north. And Kaduna should be lining up somewhere. But more than that, is that we'll engage with you in a discussion outside this place. We agree with you that we need to do a lot more. There won't be enough time to do all the discussion. But one of the things we hope will happen at the conference, when we had this the platform in 2023 that you were on, part of the issue was this, to say, how do we begin to prepare the ground? But one of the sessions we are going to have in Port Harcourt is going to be a session for the states and state leaders to talk about what they're doing and to look how we can begin to strengthen partnership and support for them and with them towards promoting adolescent health. But it's going to be a big discussion, and we look forward to discussing that with you. I'm glad. Let's go to number 2.
Number 2.
Okay, go to number 3. Maybe number 2 has changed his mind. Maybe his question has been answered.
Thank you very much. My name is Dr. Irma Pepple from the Rivers State University. I want to say that one way of making sure that adolescents get the health that they need is not just engaging only in the doctors, but to the people that basically we see in every primary healthcare center, which is close to the community, which are the community health workers and the nurses in public health. And even when you don't find a doctor, you find the community health workers. So it would be good to take adolescent health in a way, is it to train them, develop protocol, make them aware, or get a day where the adolescents can go to the primary health care, because around every primary health care center are the adolescents. And when you go and meet adolescents, you find out that they're very receptive. I spend a lot of time on religious basis talking to adolescents, and you find out that they're very receptive, they ask questions, and they have a knowledge gap. And just like you said, this digital age, you find them that are feeding that gap with all sorts of sources on the internet. And where those who are not on the internet, all sorts of sources on the street, like the vendors in Port Harcourt are on every bus selling things. They are the ones that feed a lot of the adolescents with what they know. And before you sit down with them and you correct them, because the average adolescent is very far from the doctor. Yeah. From the time maybe he's 2, he doesn't go to the hospital again except he has a particular, maybe till, if it's a female, till she's pregnant. So that is how it is. So thank you.
Fantastic. Thank you very much, man. We totally agree with you. By the way, a few years ago, we developed 2 national documents. One of them is integrating adolescent health and integrating adolescent and youth-friendly services into primary care, essentially because of that. The second one was about promoting adolescent and youth services at the primary care level. There are 2 national documents, but again, Nigeria is so good at developing documents. It's about implementing, and I'm glad you are raising that point. It's something very important to look at. Thank you, ma.
Thank you very much, Prof. and the presenters. My name is Dr. Aphpn, Calabar Aphpn. When I did my posting in Jos, there was a place I visited for these 3 children called Gideon Beki. That means House of Hope. in Calabar, there was a Christ Embassy that also tried to rehabilitate these street children. And then we know them as Colombo boys and girls. They are very, very notorious. I don't know whether Aphpn is also focusing on these street children who are becoming a very big menace now. They come to your car and beg you for money. If you don't give them, they scratch your car or even break their windscreen. So I don't know Aphpn is also doing about this group of adolescents. Thank you.
Thank you, sir. My simple answer is that we care for all group of adolescents. You know, in Aphpn, we believe that young people are like diamond. In its original form, unpolished form, it's not attractive. But if you work on it, it can shine brightly, it can shine beautifully. So we believe that every young person, no matter who they are and what they are going through, can be assisted, supported to become like diamonds. So, but like somebody said, what is government doing? We'll continue to do our part, but hopefully, I hope that you are not just raise the point, you also join Aphpn, and you can begin to work on this together. Thank you, sir.
Good afternoon, sir. Good afternoon, everybody. My name is Udeme Emma. I work with Pathfinder International. So, the person that asked the previous question talked about the internet and what adolescents get fed on from the internet. And one thing that really messes up with their mental health is what they get from the internet. So coming up in August, I would maybe make a suggestion for Aphpn to really include internet safety for young people and how they can navigate through the internet without being cyberbullied, because some of them have been reported to be bullied to commit suicide or something. So to include how adolescents can safely navigate the internet, to not get bullied, and also to not become bullies on the internet. Thank you.
Thank you very much, sir. And I know that Pathfinder is one of our good partners. When you stood over, I thought you were going to announce how much you're going to give to the conference. You have been one of our constant partners, and I think we'll talk more to you and see what we can do. But you are correct. In fact, like you said, one of our team is about digital citizenship. How do you be a good citizen in the digital world? You are doing your part. You are not harming people. People are not harming you and all of that. So I look forward to the paper you present, an abstract around some of those. I think we have all the people in the room already who wanted to make comments. Are there people? Oh, one more.
Thank you, sir. I am Akin Lulumshari from Union, Professor of Public Health. I just want to make two comments. Number one, regarding the specialties, I think they're all appropriate. Community medicine, public health, family medicine, psychiatry, as well as pediatrics. And if you look at all of them, they are all in the West African College of Physicians. And I think the only other that is left is the pathology, is the morbid anatomy, and the rest of them medicine. That's not there. So I just want to suggest that we can put out a paper to the West African College of Physicians, perhaps starting with that, as well as even the national, the NC, MP, and National Postgraduate College too, targeting these residents for training, just as we used to go for management training and other things. This is very important for those four specialties. And then coming to the adolescents themselves, I think we should also design a particular training program for them that could be done during the long holiday. Most parents may not want it during the school time, perhaps a week or two. Just focusing, we'll promote it through schools, of course. But I think during the holidays, sometimes in August, sometimes in September, we can do such a program and make it attractive to parents, to the youth themselves, and I think it will go a long way to broaden the horizon. Thank you.
Thank you for those two very excellent points. Maybe to respond to the second one, maybe let me stretch it a bit. I think one of the things we would like to see done is actually to see many people are interested, who we can build their capacity, and then they can multiply these ideas in the various places. That's the fastest way we can cover Nigeria. But certainly we'll do something like this. That sounds exciting. I think that we may have only like 4 minutes left. Anybody online?
The person online, put on your video quickly so that we can get you.
If not, I'll just give one minute to my co-panelists to make a comment if they do. While the person online is coming on, are we ready for him or her? Otherwise, let me ask Professor Lumide any last comment or your last word.
All right, my last word is, I think the time is now. If we want our doctors to be trained, yes, it's important to train various health cadres. The Ministry of Health actually has the clinical protocol that addresses this. But beyond this, it's important that our doctors can be trained wherever it is they are, whether they are surgeons, whether they are neurosurgeons. I think I even see beyond physicians alone. I think that everybody, whoever has opportunity to attend to an adolescent, should know what to do, should know what to ask, so that that adolescent has a good experience and is not driven away permanently away from the healthcare system. Thank you.
Sorry, sir, the person online is there. The person online is there. If you are ready
That's
online,
additional.
please.
I hope that's not Dr. Additional who is online. All right, please, let's go on. We can't hear you yet, ma. Give us a minute. No, not yet. Not yet. Just give us half a minute. And thank you, Pa. This half a minute is on your bill, not our bill, because you are the one that didn't let us hear you. Oh, yeah. Have you set? All right, let's go to Professor Buladu while we are getting that sorted out.
Thank you very much for all your meaningful contributions. If we want to secure the future of our country, and we want to ensure that we have a healthy adult population, the time is now for us to focus on adolescents. So you are all partners in it, irrespective of your specialty. Let's join hands together. Thank you.
I think everybody knows what I'm going to say. Please let's continue this conversation in Port Harcourt in August 2025. Thank you very much.
I'm waiting for the online person. Let me also say, maybe just to highlight that for us, this is the beginning of a conversation, and all your suggestions, we are going to put them into consideration. We indeed come up with papers, and
Mike, can go ahead online.
All right,
go
ahead, ma. Good to have you online. Ma, I am not blessed with lip reading ability, so I think you have to just find a way of making sure we hear you.
Hello.
Yes, ma. Welcome. Finally.
Okay. I said good afternoon to everybody.
Good afternoon, ma.
Professor Fatsi. I said my name is Dr. Uzo Amaka Carol Chima. I retired from Ministry of Defense as Director of Public Health. And I just want to thank you, because I've been one person that has been so passionate about adolescent health since my training, in Action Health Incorporated in Lagos. And while I was in Ministry of Defense, I made several efforts to get the adolescent, clinic established in Ministry of, in the military barracks. But for some reason, maybe I was not able to convince the authorities that be. So, and since after retirement in 2020, I have been on some, journey of some Israelite journey, like borrowing Professor Fatusi's words of some sort. But I think this is an area that is very, very welcome at this point, because there's a great need for adolescent health in our society, especially in the military communities. That's one very high risk place. So I'm very much interested. I was not able to attend the 2019 conference in Ibadan. I planned to, but unfortunately, I have been on some missionary journeys of some sort since after then. but will be in Nigeria very soon. And I'm still interested. I'm already registering as a member, and I hope that we'll be able to take this forward and get trained and get more people to be trained, and then also reach out to the military barracks. Like I said, it's a very high-risk community. So thank you very much for your presentations, and thank you. By the
Thank
grace
you very
of
much,
God,
Ma. Can you please
contact.
put down your contacts? Just write your contact for us, name, in the chat box with your phone number and email. I can be sure that Maduka will contact you within the next 30 minutes. That's how proactive we are. Ladies and gentlemen, I want to thank you profoundly for this session.
Where do you?
In the chat box.
Okay.
So I can quickly record it, and they will follow you up. Ladies and gentlemen, thank you very much for this session, and we look forward to continue the discussion even outside this hall. We are always ready, and thank you.
Thank you very much, Professor Fatusin and members of the panel. Thank you for that wonderful presentation. Let's take the photographs here. While that is going on, we'll move straight to the next plenary session. That's plenary section 6. I want to invite the chair for this occasion, a consultant pathologist, the Chief Medical Director of Babcock University Teaching Hospital, person of Professor Barnabas M. Mandong, to chair this session. Professor Mandong, please. I would also say that the Babcock team should just come along at the same time, those who are presenting with him. This session will be handled by Babcock University. Babcock University. You're welcome.
Good afternoon, ladies and gentlemen. I've been introduced as a pathologist, and I have a team of 3 people. Before they sit down, I want to thank one of my friends sitting down here, Professor Ibrahim Ayuba Zoka, my childhood friend. He encouraged me to take some degrees in public health, even after I had become a professor of pathology. And so I started in Jos with MPH, ended up with a PhD in epidemiology. And it has given me an opportunity to understand what health is all about from the community to the laboratory. I had admired being a public health physician for a long time. Even when I was commissioner for health in my state, we insisted that every medical officer in the general hospital must have a master's degree in public health. If they do not do that, if we do not do that, most of them end up as farmers in the rural areas. And I feel very comfortable that I have some of these degrees along with us. So we're coming into public health through the window, but I'm comfortable and I'm sure the windows has accepted me. We are going to talk about One Health. One of our colleagues was talking about One Health. The medical school in Babcock University started 2011, and we have graduated 8 sets of medical students. When I arrived at medical school, I was the foundation dean of the medical school, became the provost. Now they asked me to take over the teaching hospital. We met a faculty of public health, offering degree of public health at first level, BSc. And so the BSc public health started before the medical school. So it became very difficult for us to integrate that public health into the medical school. We got all the resistance. But we thank God now that we have able colleagues who have come to the Department of Community Medicine to help us develop that place. We're also going to, apart from One Health, we are going to talk about Babcock University Medical Journal, the Category A journal now. We started it 2011. It's being midwife by Professor Abiodun, the head of Department of Community Medicine. It has reached that level. We also want to thank Adibi. He's coming from UCH. He has been assisting us in the Department of Community Medicine. He's one of our anchor researchers. He has done very well for us. Ayodeji is part of us. All this group of young men, I will call them young men, but they're adults, they have helped us to develop community medicine in Babcock University to the level that we are very proud of. So today, Adibi is going to start with us to talk about One Health. What has happened is that will One Health replace the primary health care? Since primary health care is all encompassing. And when our colleague was making the presentation, a lot of questions were asked. And I hope our panelists will be able to give us an insight on why we want to run a master's degree program on One Health in Babcock University. It's one of the pioneer universities beginning to put programs on MSc One Health. National University Commission came to Babcock University for a resource verification, and they gave us the go-ahead to anchor the program of master's degree in One Health. And the proponents of those programs are here with me. They will give us the detail of what they have been doing up to the point of beginning the program. So I'm sure the program will start this session. An advert will be put very soon for our colleagues who will be interested in running master's degree on One Health. So I will call Professor Adibi to kickstart the program, and thereafter we can ask questions where there are areas of doubts, we will be able to clarify. Thank you very much, ladies and gentlemen.
So, and I want to thank the Chief Medical Director of Babcock University for that kind introduction. Can we have the slides on, please? Okay. So, I'm not going to bore you again with too much talk about One Health. I think Dr. Ladejo has done a lot of justice to that. I would be talking to you about the Babcock University's health curriculum planning, why One Health came about, the Masters in One Health, and how we went about it, for you to understand where we're coming from and where we are presently. And then my colleagues will take it from there. Now, we do know that we live in a changing world and that there are new complexities that we have to grapple with. So that reality makes it also certain that we were going to be having emerging new diseases because of the fact that we create man's activities create unstable niches, and nature lashes back because of that. So it's not about whether we are going to have another outbreak, it's about when is it going to happen. Now,
A little bit about the historical background. Dr. Ladeyo talked about the H5N1, that was the time that we started having some bit of communication across the ministries, and a lot of our colleagues started talking together and understanding each other. The 2009 Pandemic Preparedness Plan was a watershed in the history of One Health in Nigeria, because that was the very first time in Nigeria that the incident management system was described and how it would function. Many of us may have come across this Nigerian National Influenza Pandemic Preparedness Plan and Response. I was fortunate to be part of this process and part of the presidential committee also for the in 2006. So we've come a long way in One Health. It's been a long walk, but the One Health strategic plan for Nigeria, which Dr. Ladeyo talked about, was to end in 2023. It was extended to 2024. And I think this Monday, we were supposed also to meet on the technical committee for the One Health, National One Health Committee. But Nigeria has done very well in that the One Health, strategic plan aligns with the triple bottom line approach of the SDG, Wellness Goal 3. And that is to align with coupling environmental sustainability with economic development and social inclusion. And the One Health strategy in Nigeria does well to consider all this. Now, that strategic plan itself, opens the door for us to understand what are the gaps and the opportunities. The One Health strategic plan goes through, talks about an integrated, safe, and secure research agenda and sustained capacity for implementation of OH initiatives in Nigeria. Now, the research agenda was not well articulated for Nigeria. And that was a gap that the strategic plan realized and say that we need to do something about. Objective 2 under this research agenda gap talks about the need to incorporate occupational health into the curriculum of medical, veterinary, and environmental health, as well as other life disciplines by the fourth quarter of 2019. And we needed to build trust, and we needed to have capacity across the One Health spectrum. Now, this did not happen, but there were opportunities that at the national level that was latched onto, and there was renewed interest of critical stakeholders in One Health. In-service training packages were established across the frontline health workers. There was some prioritization, workshop for in-service training. We have for, also for vets, we had for human health. But they were also not speaking to each other. It was done separately, even up to now. So the Joint External Evaluation of 2023, Nigerian report also, opens up the vista for investment in global health security and One Health approach. So it was from this background that we then looked at it, that where could we situate the implementation of, having a curriculum that is all-encompassing and brings everybody together. So Babcock University has a USP that is very, very unique and second to none, in that their academic sessions run seamlessly. If you are thinking about the One Health workforce, if you're thinking of people who are already on the field, that you need to bring them together, and they want to know when they will start and when they will end. Babcock University also has an Adventist network that has practice sites across animal and health, interfaces. And it also has an Adventist network that cuts across most African countries. In fact, not all African countries. So there is the possibility for, cross-fertilization and internalization that is very, very unique for NUC. It also has a great ambience for learning. So that was the reason why we decided to go ahead with a master's in One Health in Babcock University, because it's a unique place to cite such a master's program. So we went about assessing the needs. We looked at the gaps and opportunities. We had surveys. We talked. We did consultants. We consulted people across One Health approach. We mapped the educational needs. We derived objectives and goals. We selected learning, experiences based on the objectives. There were several consultations, and then we had a co-creation curriculum workshop that brought in stakeholders from the different ministries of health, agri, environment, and across many other, service institutions in Nigeria. So, after doing that, we decided to envision the future. We decided to walk backwards from the future. So we envisioned that the resident better equipped and positioned to prevent, detect, and respond to public health threats in a coordinated manner will be the way to go. And because we did this, we then realized that we need to have a paradigm shift. We need to walk away from the usual way of planning curricula. And then we had to embrace a new way that is in line with the working from backwards from the future that we did. So we brought in a lot of, people from the field to critique, give us their, their honest critiques, no matter how hurtful it sounds. And that was what we got. And so the curriculum planning had to be a backward curriculum planning development, in which case we look at what we wanted learners to know, understand, and be able to do. We looked at what we determined to be acceptable evidence of what they know and understand and are able to do. And then we also look at how we can plan their learning experiences and instructions to achieve learning outcomes. So for all these, we needed to look at contextual factors, what will make them to function at the field level? What will make them to be able to interact with their colleagues across the different divides? So based on all these, we came up with some, unique requirements, basic modular, that we need to run it in a modular version. Most courses in Nigeria do not run on a modular version. So we decided that we need to run on a modular version so that people can understand, the experts can know when they will interface with the students. So we can have one expert run a module, and he knows when he's going to do that, and when he stops, another person takes over and knows when he's going to run it, and so on and so forth. Because we are bringing a lot of expertise together across different fields. And we also decided it should be experiential learning. We must take the gown, a clean gown, to town, and for us to be able to develop case studies, because that's another area that most Nigerian universities are deficient in, creating, case studies that are unique. So we had to bring people in from the field. Ogun State Ministry of Health is a perfect example. They have excellent case studies that would make the students' learning experience to be rich. So they had to be brought in, and we had to have a participatory learning approach. We look at team cluster-based learning, where we can cluster animal health and environmental sectors together, rather than they learning differently. And each person learns what is the expertise of the other person, and learns to understand what the other person needs and what the other person brings to the table. We also look at contextual requirements, which we needed to insulate it from academic politics so that it can run smoothly. So the issue of a department running it and what have you, and there is rivalry between departments, that would not happen. So we had to have two coordinators from vet and from community medicine. Coordination platforms, broad platform. We chose those who had skill sets and ability, not just that they are lecturers or teachers, people who have experience, people who have led outbreaks, people who have facilitated learning in, real spaces. We had to bring them on board and also, engage them. So we had in mind that we're either going to do MSc, MPH, MHSC, or MASc. And then we'll run PhD and certificate courses. We have very brutal and honest critiques. One of such is that we should be careful not to turn this into another profession. And that was a feedback that was very, very important. Initially, it was very hurtful because the way it was said was really, really damn bottom line, like being angry. But we took it in good faith and looked at the whole issue again, looked at the Nigerian context, and realized the fact that it is true we have to be careful. One Health is not a profession. It's a paradigm. And we need to preserve that. So we went for a master's program to be able to preserve that. So we also had to apply to COFI to have the COFI framework for competencies, which is something that is developed by WHO, FAO, and the World Organization of Animal Health, so that we can prioritize the competencies, the knowledge, the skills that are specific for Nigeria and specific to our own, needs. And the NCDC helped a lot in this because they applied on our behalf to the COFI for us to be able to use the COFI framework. This COFI framework has 14 domains. It looks at competencies for One Health, for field epidemiology, and we had robust training, robust consultations, and we came up with a curriculum that was really, really very rich. These are some of the collaborators that were the Ogun State Ministry of Health, Ogun State Ministry of Agric, Ogun State Ministry of Environment, the Nigerian Centers for Disease Control, Aphpn, Morehouse School of Medicine, Federal Ministry of Environment, Vet Institute in VOM, the World Health Organization, to mention but a few. So, it was Chinua Achebe that said that nobody should enter his own house through another man's gate. So what we have done is that we have defined the Nigerian gate for One Health and how the training should happen. We've taken through this through the NUC. We have the NUC approval now. We've had a lot of iterative, improvement in what we have developed. And we're still looking forward to have feedbacks and whatever we need to improve on. And we're careful that we do not want to develop another profession. So I would like to enjoin all of us that Babcock University, with critical stakeholders in One Health, has developed an MSc in One Health that would meet the need for a competent and resilient national public health workforce in Nigeria. I enjoy you all. to support the noble initiative as we move forward. Thank you for your attention.
Next speaker. Thank you very much. Please be writing your questions as we make progress.
I'll stand on the existing protocols. Distinguished guests, ladies and gentlemen. I'll move straight on to it's not responding. Sorry? Do I use my... Yes.
Please just be patient with us. They're trying to sort out some problems from ICT people. Dr. Olarimui is a vet doctor from the Department of Agriculture, Babcock University.
Title page. Would you be controlling the front there? Okay.
We are eating into our time.
Okay, please. Yeah, it's there. I apologize for the mix-up. Standing on existing protocols, I'll be presenting the structure and curriculum of the MSc One Health program that we've put in place or put together at Babcock University. Next slide. Next slide. Now, introduction to the MSc One Health program. I'll be presenting the overview of the program, its objectives and expected outcomes, the target audience, which would comprise professionals from various backgrounds who are interested in addressing the complex health challenges at the intersection of humans, animals, and the environment. And at this intersection, we find the occurrence of zoonotic diseases, the problem of antimicrobial resistance, food safety, climate, and its impacts on human health, human and animal health. The target audience for the MSc One Health program we've put together would include public health and policy professionals, agricultural and veterinary professionals, biological and environmental scientists, medical and healthcare professionals, environmental and conservation professionals, and social scientists, and also anthropologists. Next slide. Why One Health? The One Health program we've put together is one aimed at addressing global health challenges that require an interdisciplinary approach each time. We've observed that these interdisciplinary approaches constitute the best approaches. They are the most cost-effective and efficient approaches in resolving some age-long problems that have defied solution because of the ways and approaches that have been applied before now, with different professions operating and professionals operating in their own independent silos. So there is a need for integrated health solutions. The structure of our program, it comprises full-time and blended learning. Its duration 2 sessions, totaling 80 weeks, and there will be coursework, dissertation, online, on-site, and field components. And that's just one example of the various locations right there on campus where lectures will be held. We also have world-class facilities, laboratory and otherwise. We have a state-of-the-art molecular laboratory right within the premises of the Babcock University Teaching Hospital. The core courses would include Foundations of One Health, the International Health and Global Health Security, Epidemiology and Biostatistics, Food Safety and Food Security, Zoonotic Diseases, and Antimicrobial Resistance. We'll be talking about Integrated Surveillance Systems, and there are courses designed around risk communication and community engagement, biosafety and biosecurity, as well as environmental and occupational health. We have practical and field training components that would involve field work in communities and animal health settings, laboratory-based research trainings, and internships with public health organizations. Research opportunities exist for students and those who enroll in this program. There will be supervised research projects. The focus will be on emerging health threats, many of which have been addressed by previous speakers on this podium this day. Collaboration with government agencies and NGOs comprise part of the package we have in place. And the government agencies include Federal Ministries of Agriculture and Environment, the National Veterinary Research Institute at VOM, which is the foremost veterinary research institute in Nigeria. The Nigeria Centers for Disease Control is also on board, the NCDC, and state ministries of environment and agriculture. We also have, as part of our package, the opportunities for international collaboration, and we do have on board international faculty. We have lecturers from diverse backgrounds, including the Morehouse School of Medicine in Alberta, partnerships with Global One Health institutions, the African Field Epidemiology Network, also the International Epidemiological Association, and we have opportunities for exchange programs within and without of the Adventist health systems. And these, a glance at the very wide consortium we have in place to enrich or to provide our students with a very rich experience, the MOH students with a very rich experience. There will also be student support and resources, access to online and offline learning materials, state-of-the-art library and research facilities are in place, and career support and networking. For assessment and graduation requirements, students will have to undergo coursework and examinations. There will be thesis research and thesis defense. Fieldwork evaluation will also comprise part of the assessment requirements which students have to meet prior to graduation. Career opportunities for graduates include job opportunities at public health agencies, international NGOs and research institutions, academia, and policy development. Future developments and program expansion. We have in place a plan to build upon what we have right now, and plans for specialization, expansion of research funding, and building greater industry partnerships. How do you apply for this program? Application requirements. Those students or colleagues who would be interested in applying for the MOH program would be expected to have a Bachelor of Science honors degree with a second class, minimum of a second class upper division in relevant disciplines. At least 1 year post-qualification relevant work experience would also be required. Admission process will open every June, and it's very, very imminent right now. So from June 2025, we're going to start admitting students to this program. Scholarship opportunities exist also and have been factored into the program. And these will be two opportunities per annum for the next 3 admission cycles. This is a call to action. Please join the One Health movement and encourage other professionals to enroll. There are a lot of collaboration opportunities. You can reach out to my dear colleague, Dr. Abiodun Olumide at abiodun@babcock.edu.ng, or myself, Olarin Boye A at Babcock University, at babcock.edu.ng. Our aim is to advance One Health in Nigeria. And by the grace of God, we shall. Thank you.
Thank you very much for your presentation. Abiodun Olumide will speak about another topic briefly before we answer questions from online site participants.
Okay, so good evening, teachers,
distinguished colleagues. My job is the easiest of all. So I guess that's why I'm last. And I've been told to do 2 or 3 minutes. All right, so I want to attempt to stimulate a discussion around how the academia, beyond floating courses, how the academia can really engage within the One Health space to promote research and policy advice, and even practice improvements around the One Health space, specifically how academic journals, can do that, and to also underline how our journal at Babcock University Medical Journal, proposes to do that. And so the idea is to stimulate us to discuss, to advise, to think, especially when we consider the current, global events where it's imminent that research funding, at least from the north of America, is likely to reduce, and how the world has failed to respond to that, in the immediate run, and what we expect to happen. So our journal, One Health, and it's been variously defined, and I don't think we need to do that again. But the idea is that there's a gap between research and policy within the Nigerian context. And for us to engender optimal One Health, interventions and all of that, we need a lot of collaboration. Collaboration in research. And that you will hear often and often and over again. And academic journals can actually contribute to this. And we have quite a number of them, including us. How do we begin to intervene within the One Health space, on behalf of the academia? Our journal is a multidisciplinary journal. It's published by the Babcock Medical Society. The chairman of the BMS is CMD, who is seated. We provide peer-reviewed publications on health findings, and our strong basis is community and public health. The vision is to disseminate evidence-based pragmatic insights into health issues within the African context. And the specialties, all across specialties within health, be it BMS, basic medical sciences, clinical sciences, and all of that, and more recently, within the One Health space. Academic journals are, constitute a melting point where researchers, implementers, policy users, and all of that, where we meet. And so journals are very important because they can, advise policy. They can disseminate findings that potentially advance policy. And academic journals also have the potential to encourage collaboratory research, depending on the publication, the policies. And these are things we need to think about. How do we begin, to fine-tune our policies to encourage collaboration across sectors, especially when we begin to think of One Health, because hitherto, we have done a lot in silos, and many of the researches we publish often reflect that. How do we begin to encourage our publishers or our authors to do collaborative research? Journals provide the platform for emerging researchers also. It's a blind process, so everybody is welcome at whatever level. What brings us together is quality research. And so it also provides an opportunity for mentorship, for collaborations. And our journal specifically does a lot of training for young academics in terms of writing, publishing, and we sometimes fund researches. However, on the general note, publishing One Health research has its challenges because the researches are not even there. There's a lack of funding, which is about to get worse, for funding some of these complex collaborative researches. And we need to begin to think from here. How do we go forward? How do we think of providing funding, for the quality of research that can actually, influence our practice, improve our practice, and optimize our policies?
There's also, oh, you're faster than me. Sorry. Some of the challenges, also there is a lot of challenge to access to even quality platforms. I mean, many of the journals that we have not been able to, to go beyond, the initial successes to becoming established platforms. And these are discussions we need to ask. How do we place our journals on that pedestal where, finders, people who are looking for information, think about our journals. All right, and that's important. And again, there's a need for interdisciplinary collaborations, especially for those of us in the academia. There are even many of our colleagues who publish basically for promotion, and even the promotion criteria that we have in different universities sometimes do not do justice to or encourage collaboration across disciplines. And these are issues that we need to really think about and engage. There's need to increase funding opportunities for One Health research in Nigeria. And the Aphpn and leaders within the various sectors need to begin to consider this seriously and to look for alternative mechanisms, apart from the traditional mechanisms that we have become so used to funding research. We need to strengthen our review processes, even in the face of difficulty with getting reviewers. There's need to improve peer review processes in many of our journals. And this again is an area where we need to wake up further. We need to expand international collaborations, even within our editorial systems, And in trying to round off, I want to identify some of the things that we propose and we are looking towards as a journal. We welcome, people to propose issues that work around One Health. And these are things that we want to put on the high burner. We will encourage it and give necessary waivers, to ensure that some of these things see the light of it, so that we can create, an awareness within our system where the policy makers, the implementers, and the researchers can meet. Our researches can be properly disseminated, and we can have, an improvement in the whole research culture as it pertains to the One Health, paradigm. I think I will try to end there because there's a lot of pressure from behind, so that we can entertain some questions and especially thoughts, that can improve everything that we have said, our curriculum, our approach, and all of that. Thank you for listening.
Thank you very much, Abiodun. One Health is a new concept in health provision for this country. And I think Babcock University is just beginning to promote that course and understand UI and University of Jos is also likely to go along the line. It is because we are facing challenges, particularly with policy makers as regards to provision of health services to our citizens. So this is deliberately designed so that health services can be approached from multidisciplinary action, from veterinary medicine, from agriculture, from economics, from political science, and all other disciplines that affect provision of health in this country. So I will invite questions from the audience and online. As I said, it's a new concept. I'm sure you ask so many questions. Why this one? Are we producing another health professionals? What will be their career prospect if you have a master's degree in One Health? But as you have said, is to promote research and to also influence policymakers in making decisions as far as the health system of this country is concerned. You recall primary health care evolved over time from basic health services. It became primary health care, a kind of a universal health coverage that will promote the well-being of our citizens. But we are stepping it to another level now. We want to open it for discussion, and I'm sure we are stimulating a lot of questions from this discussion. Also, Professor Biodi has spoken about our Babcock University Medical Journal. It's on a category A journal, and we intend that all these researches will be published across board so that everybody will be able to know exactly what we are doing. So, ladies and gentlemen, you are welcome on board. Questions, both online and on site. I've seen one hand from my right. One. Any other question? Two, three.
And
You know,
four.
I've taken
That
a lot
should be
of
the
time.
last. That should be
Four.
the last one. Yes, sir.
Ameke, please coordinate the questions. The panelists will answer the question. Please direct your questions to specific individuals on the table.
Thank you very much for the innovative ideas and the presentation. My name is Adigbuiga Uyefabi. I'm a professor of community health. I'm also an epidemiologist. So I've listened intensely to this presentation, and I want to say that the concern I have is also what my brother, Professor Adibi, have earlier expressed about the fact that we should not turn this One Earth to a profession. As a premise, let me say I'm also fully involved in One Earth, having been involved in practical epidemiology, disease outbreak responses in different fora. So I'm not against One Earth. And I've been practicing One Earth now for about 4 to 5 years now, together with other professionals. But the concern is very germane. And when he mentioned the concern, I was expecting him to tell us the strategy to mitigate that concern. So that we as trainers of residents, we don't see ourselves as boxing ourselves into a corner, replacing some of these other silos of different trainees with our core training in residency and for consultancy training in public health. But when he was speaking, what came to my mind is that if this is the case, then that means that if you cannot beat them, then we join them. And what do I mean? We have to encourage our residents to take as many of these courses as possible so that they can also stand wherever the, people are saying, see my certificate in One Earth. This one will say, I also have the same certificate and I have beyond. That is my personal resolve as far as this issue is concerned. I've looked at the curriculum and I found that they are not different from what we have in our residency training program and other training program. I also hold a PhD in epidemiology. So I'm aware that some of the courses that have been presented are also subtopic, even in MSc epidemiology and MSc PhD. So what am I saying? I would have preferred a situation where One Earth is just a curriculum, either in MPH, residency training, MBBS program, or in PhD. Not coming as a silo, alone as a profession. But I understand, sir, because you are talking from the perspective of a private university, and I know you are also in business, so I'm not trying to be against this business as much as possible. But I see the requirements.
Please summarize your question.
Please, I'm coming, sir. I see the requirements, sir, for admission into the program, and it seems the MBBS is not there. I see Bachelor in Science, but I'm not seeing MBBS. So I want you to clarify. So at least if MBBS is there, we can also push our students to you to train them in One Earth for us. So these are some of my concerns. And I want to say, sir, the One Health approach, you mentioned again and again that it is not new. The country now even has a One Health strategic plan from 2019 to 2023. And they are planning to do another strategic plan. So it has been there. Right from the onset of COVID, you have been talking on One Health. But all the same, I thank you for your interest in One Health. I thank you for your interest in public health in Nigeria. And my prayer is that all these can be pulled together and we can work together. Thank you.
Thank you. I'll ask one of the panelists to answer you properly.
Yeah, I think I should quickly just address your concerns. I think you've misconstrued what we had presented. The concern of those, we had 3 streams. We were considering a standalone master's. We were considering a master's of health for those who are already practicing on the field. And it is that matters of health that reviewers had a problem with. That the masters of health will be misconstrued as creating another profession in the light of the context of what is happening in Nigeria. Masters in One Health is not new. It's a global normal. It's just a practical approach that focuses on coordination, communication, collaboration, and also, all the C's that you can ever think of. So what it does is that it brings people together to train in the same way so that they can understand the valencies of each other on the field. The field epidemiology training program also does that, uses that approach. But it's quite unsustainable because it relies heavily on donor funding. And that's why NCDC is changing that approach. You understand? So that we must get that one right. It is not a silo. And nobody is being kept aside. What we are saying is that our present master's program I talk about, whether it is epidemiology or whether it is community health or whatever, lacks that hands-on experience of working on the field in a collaborative manner, bringing together people from human health, animal health, and environmental health. And that is what the One Health Master's Program is solving. It was identified in strategic plan. One Health, I've been with One Health since 2006. So it's not new to me. So you are not saying anything new by saying that it is not new. And the process, in fact, I'm on the One Health Technical Committee at the national level. So it is not something that is new, but it's a gap that has been nationally that we have recognized. That we need to train people in a different way to work collaborative together. It's not a matter of private university. In fact, Babcock was not interested in it. But Babcock had to be shown why it is in their interest because they possess a good, credible host that we can look for to be able to plug the gap that was noticed that the strategic plan of Nigeria had earlier identified, and in-service trainings that NCDC is doing is trying to bridge. I hope you understand. I don't want us to have this misconception. That's why I had to stand up to correct that right away. Thank you, sir. And MBBS is also part of it. Okay? Thank you.
Please, next question. Amaike, please coordinate. I saw a hand raised there. Thank you, madam.
Good afternoon, and thank you so much for the new insights. Dr. Akonki Odedoyin from Alimosho General Hospital, Lagos. It seems the course is June to June, a one-year course. how much is, I don't know if this is the right forum to ask how much it's going to cost. And then I wanted to know if there's going to be an online component of the course.
Please speak loud because we're not hearing you very well.
Wow, sorry. Okay, I was just confirming that's a June to June program. And then I wanted to know if this is the correct forum to ask for how much it's going to cost and if there's going to be an online component to the course.
Are you going to answer that?
Thank you.
Okay, so thank you very much. We said earlier it's not a one-year course. It actually runs for 80 weeks, 2 academic sessions. There is online component. Many of the modules will be taken online, and there are also mandatory on-site and field experiences required. The university will graciously offer a few scholarships over the next 3 years. You may want to compete for those scholarships. And the precise costs, you know, by June will be advertised, but it will be something that is affordable. Thank you.
Thank you. Who's the next person?
Okay. Thank you very much. My name is Oyelajun Okoromade. Still introducing myself again from Nigeria Center for Disease Control. And I would like to commend Babcock for being the forerunner. We've been on this for a long time. I happen to be the pioneer national coordinator for One Health platform in the country, and I led the process of the One Health strategy plan, the first. And as rightly mentioned, AB is part of the National One Health Technical Committee. Just to add a bit of it, One Health concept is not new. We've been on it since avian influenza outbreak. We have an in-service training. But the need for us to have a platform actually came as a recommendation from the Joint External Evaluation of 2017. So that's just to add a bit to that. But my point, not really a question, is just to add when because of course I was part of the team that worked on this curriculum, so I'm quite familiar with it. But as part of the collaborators, I would just like to add that we have African One Health Network, which is a member of World One Health Association, just like IEA. It would be good to partner with that so that we'll look at the funding opportunities available as well as explore other opportunities around that area. And 2 years MSc program for full-time and not part-time. I think we can look at the time commitment because this is a master's program. Majority of people coming on board are professionals. We can look at the funding commitment within that 2-year space. And also, we can also look at the opportunity costs also. How committed are they going to be for a 2 years full-time? Or we should look into tweaking a 2 years for a part-time. This is just a recommendation for the team. And also to add, as part of the concern raised by one of the person that asked the question, I recalled in 2023, we had a workshop where we looked into incorporating the One Health curriculum into the residency training. And we partner with the college, the National Postgraduate Medical College. So the idea is to ensure that we have this One Health component across different curriculum trainings in the country, not just for other professionals. Why this can come as an MSc One Health for those that are interested or that want that. And in Nigeria, this is not the first time it's been done. It's been done in other countries, and Nigeria is just keen into what is being done globally. Thank you.
Thank you very much. All right, any other question? our time is up. We want to thank you for listening, and no online participants asking questions. So we're available for questions, for clarifications of any doubt about One Health. Adibi is going to say something before we round off. Thank you very much.
Thank you very much, Dr. Okuromade. You have actually clarified many of the things. The National Postgraduate Medical College Faculty of Public Health had a workshop. I was part of that. The curriculum is incorporating One Health into it. The online program, you know, we have online and we have on-site as well as the field experience. The program is actually not 2 years. It's roughly about 18 months, and it factors in the fact that you have the field engagement with it, the practical hands-on, and most of the courses are online. Thank you.
Thank you. In the absence of any other thing, we want to declare this session closed. Thank you very much for listening, and God help.
Thank you very much, the team from Babcock. Thank you, thank you, thank you. Thank you so much. Please, I want to invite every other person from Babcock to come for the photo session. While they are getting set for that, let me introduce the next plenary. We had a very late breakfast. So I know that our tummy is still full, so we'll take one more plenary. We'll take one more plenary before we go for lunch. Our tummy is still full. We take one more plenary. We had a very late lunch, and the small chops were very plenty. So please, let's take one more, then we'll go for lunch. So I want to invite for the plenary session 7. Plenary session 7. That will be handled by Aphpn Nigeria Limited. I want to invite Mr. Daniel Odia, who is the head of innovation and IT in that sector, to come and introduce the participants who will be involved in this session. Mr. Daniel, please.
All right. Good afternoon, everyone. My name is Odia Daniel. I'm the head of innovations and M&E at Aphpn Health Sense. We are making a presentation on our Race for Healthcare Solar project, and the presenters, our partners, Aphpn Health Sense and Donais, are making a presentation. Our research support officer will be making a presentation in the person of Usa Stephanie. And we have our partners from Donais also who are on stage. But while they prepare to come on stage, there's a short video we will need to be playing while they come on stage. Thank you very much.
We are Energy Storage System Factory located in Yichun City, Jiangxi Province, China. These 10 kilowatt-hour energy storage batteries will ship to South Africa. If you need it, please contact us.
Donais, no energy waste.
Everyone, good afternoon once again. So we'll go straight to the presentation. Please, can I have the slides up? Okay, so like my colleague said, I'm presenting on the Race for Healthcare project. It's a project of Aphpn Health Sense in partnership with Donais. We have our partners here with us, and they just arrived from Yichun, China. And I'm going to make this presentation on their behalf. Please, next slide.
Next slide, please. Okay, so the title of this presentation is Empowering Hospitals and Healthcare Workers with Subsidized Solar Energy Using Lithium Batteries. You can see here, what we have here, it's a prototype of our lithium battery. We see how beautiful it is. This is a prototype. Okay, thank you. This is a prototype of a lithium battery, and this is what it looks like. So I'm going to be presenting on how we are going to empower hospitals using these lithium batteries, and the presentation is done today. My name is Stephanie Usar. I'm the Research Support Officer for Avi Health Sense. Okay, so I'm going to be presenting on the brand experience and partnership and how we can power healthcare, the Down-Nice partnership, and the Race for Healthcare project. So I'm going to be talking about Avi Health Sense. Avi Health Sense is a public health social enterprise organization committed to improving healthcare through research, innovative and sustainable solution by bridging the healthcare gap through integrated technology and strategic partnership. That is what we are known for. We make strategic partnership and we create innovations. The Race for Healthcare project that we are presenting today is an innovation of Avi Health Sense. So we create innovations and then we use integrated technology to bridge the gap in the health sector. We are registered with the Corporate Affairs Commission. We got registered in 2014. Last year we celebrated 10 years as an organization. Our mission is to add value extraordinarily to humanity through public health research, public health social enterprise, and public health programs. Our vision also is to be among the best organizations that bring health science to the people, to make sense of public health approaches and address the health and that of our communities. We can see here a picture of an award that was given to us at Akure last year during the 40th Aphpn conference. That award was a special recognition, appreciation award was given to us at that conference. That is Dr. Tefa Kene, who is the CEO of our organization, receiving the award, and just me by the side there. So I'm going to talk about the Race for Healthcare project. What is the Race for Healthcare project? What is it all about? Like I said, the Race for Healthcare project is an innovation of Avi Health Sense, and all it does is to use the solar energy solutions that we have, and in partnership with our partners Down-Nice to enhance healthcare delivery. So the project is designed, like I said, by Avi Health Sense, and we provide standalone solutions using lithium-ion batteries. Lithium-ion batteries is one of the best battery technology we can find in the world today. And we say, since there are a lot of issues around power in the health sector, why don't we bridge that gap? And how do we bridge that gap? We say we are providing solar solutions to hospitals, healthcare workers, and business owners. This project is driven by the need to improve energy access in our facilities and healthcare system, ensuring reliable and sustainable power for critical medical operations. We find out that some health facilities have the problem of power. This problem exists in most of our healthcare facilities, and we are trying to solve this problem. There are unreliable electricity in off-grid areas and undeserved areas, and we are bringing this standalone energy to these undeserved areas and off-grid areas to provide them electricity and help them to carry out their operations. We are not just providing any kind of energy. We are providing clean, reliable, and affordable energy. I'm going to explain how affordable that will be. So the Race for Healthcare project integrates SDG Goal 7, SDG Goal 3 to bring about SDG Goal 10. So what am I talking about? SDG Goal 7 says clean energy, affordable and clean energy. Goal 3, we are all medical practitioners, we know that goal 3 is one of the goals we stand for. So goal 3 says good health and well-being. And then goal 10 says reduce inequality among communities. So we are bringing together SDG goal 7, which is clean energy, and then together with good health to bring about reduce inequalities in our community. And through this innovative approach for solar electrification, the race for healthcare is not just powering hospital, it's powering progress. How do I mean by that? We are ensuring that there is access to clean energy. The energy, it's very clean, meaning that it's environmentally sustainable, and it can be used in all the off-grid areas. We are also strengthening healthcare infrastructure by SDG Goal 3, and we are bridging the inequality gap. The project is making a lasting impact in communities, improving lives and setting a new standard for sustainable healthcare solutions. Our Race for Healthcare project has been ongoing since 2023, and the project we've had stakeholders engagement in 6 states. We've had over 52 health facilities express interest. We've had energy assessment conducted in over 27 states, in over 27 facilities in 5 states. We've had 80 energy audits concluded. As the presentation goes, I will make you understand why there is a need for an energy audit. We've had 25 solar installations in 25 different hospitals in Nigeria. And also we've had MOUs and letters of intent signed by these states mentioned. So we are focused around the North Central region, as you can see there. We are focused around the North Central region to help us to use the energy in the North Central, knowing that in other areas they have other issues, maybe it's too hot, you know, and some of those other problems. So we are focusing on the North Central areas. Not to say that we are not going to have engagement in other states in Nigeria, but this is our focus, and this is based on what we have done, or based on the work we have carried out so far. This is where we focused on. I'm going to talk about the Ave Health Sense and the Downice partnership now. About Downice. So Downice is a China company, like I said, that was established in 2009. They have over 14 years of experience, and their production line is in Yunchon City, Jiangxi province, which is also known as the lithium capital of Asia. And after 3 years of development, Downice became a well-known energy enterprise in Jiangxi. They combined the latest battery technology with the huge advantages brought by industrial belt and mature manufacturing system, aiming to provide customers with products of excellent quality and competitive price. So their products are the lithium ion. We can see a prototype here, just like I mentioned when I started. This is their battery, the prototype of their battery, and this is how the battery looks like. Very beautiful, as you can see. They operate all over the world, they operate worldwide, but they launched their brand in Nigeria in 2024 and went ahead to sign a partnership with Ave Health Sense in December last year. So you can see a picture of our CEO, Dr. Tefa Kene, there with the Downice team. This was after the signing of our partnership last year in September. So they visited our office, we made that partnership, and then it was signed and sealed there. This is the license, the distributor license that was offered Ave Health Sense to carry out activities and to provide standalone solar in Nigeria. So they are original equipment manufacturers. They are known as OEMs because they are original equipment manufacturers. They manufacture these batteries. So that is Dr. Tefa Kennedy with one of the top directors of Downice. So these are the batteries. This is how the battery look like. If you cannot see it here, you can also see it here. This is how it looks like. They have the 21 kilowatt hour battery, the 16 kilowatt hour battery, and the 10 kilowatt hour battery. These are suitable for hospital use, and that is why they have others. They have the 5 kilowatts as well, but that is not suitable for hospital. So, but these are more suitable for hospitals, and that is why we are showcasing these battery brands, because they are compatible with the hospital setting. Why is this partnership important? So Downice is an original equipment manufacturer, like I said, and through this partnership, we have direct relationship, we have direct communications with them. We have direct communications with Downice. There is no third-party relationship. If we need equipment today, it's just to call them directly. We are not calling somebody to call another person, to call another person. No, we have direct relationship with them, and they have an office as well in Abuja. They have an office in Lagos. The reason why we made this partnership is to avoid the third-party relations, to also provide high-quality, durable, and efficient energy system that is tailored for healthcare applications. This collaboration strengthens the initiative by leveraging on expertise. We have public, CEO is a well-renowned public health physician. He can bridge the gap in the healthcare, bring up the problems that exist, and also with the partnership, close that gap and provide a lasting solution that will last in healthcare. So what are the issues around providing power? We find out that in low, middle, and income countries, there still exist power problems. In fact, when we were having one of our installations somewhere around, I think, Kogi, the medical director said they have not experienced 20 hours of light in a whole month. So if a hospital cannot operate efficiently because of lack of power, that is a very serious problem. So Abbey Health Sciences, with the Race for Healthcare project, is bridging that gap. We are saying that there should be electricity. There should be electricity in hospitals, and we are willing to partner with you. We are willing to provide that electricity based on what you have available to you. In sub-Saharan Africa, we notice that only 40% of facilities have reliable electricity. And this is a growing problem because tariffs keep increasing. There are a lot of issues around it. You go to the hospital, hospitals cannot save costs. They are spending a lot of money because they are buying drugs and everything they need in the hospital in bits. But when you have a standalone system, you can buy in bulk and save cost. The benefits are huge and limitless. Also, during the Association of Medical Private Practitioners meetings, they said that hospitals were shutting down. Why? Because tariffs keep going up. Fuel price, diesel keeps going up. And then nobody's doing anything about it. So installing solar solutions in the hospital will also provide cost savings. You will save costs. And then you will be able to run your hospitals efficiently. And then the problems surrounding lack of power and all those other things can also be taken care of. What are the challenges and what are the opportunities that we are offering? So basically, we say we have poor quality products. You hear people say that solar system cannot power borehole, solar system cannot power heat generating equipment, and all that. We are telling you now that solar system can power heat generating equipment. Solar system can power boreholes. We are giving you quality services, quality products, and that is why we are providing the lithium iron phosphate battery that will help take care of all those issues and all those concerns you have in your facilities. Also, there is poor quality service. Someone comes to the hospital, installs for you, and go. There is no design that was done to know the kind of system that would have been suitable for your hospital and some of those other things that arise during solar installation. But we are saying we are going to bring the solution for you. We are going to provide it for you. We are going to give you 1 year service warranty, and also we are going to be available for you. There's also a monitoring app that you will install and we will install that we can monitor from our end and you also monitor. So we are going to be with you throughout the process. We are not just going to install and go. So we are going to provide those services. Expensive upfront payments. I know this is one concern that most people have. They say, oh, solar is expensive. I cannot afford solar. And the other issues that arise about cost. But we are saying we will provide a lease to own. So we are going to say, okay, you have a particular percentage, you have 50%. Why not pay 50% and then spread it over 12 months? Yesterday, we had a presentation, and then the Access Bank, we had a partnership with Access Bank, and it was presented here yesterday. Access Bank is offering 48 months. So you go to Access Bank, you tell them, oh, I need solar. They spread your payments for you. So the issue of upfront payment has been resolved, because now your payment is being spread, and then you can pay monthly as you want to. So what are the benefits of energy solutions? UNDP estimates 100% return on investment when solar installation is installed for you. So when solar installation is installed, between 2 to 5 years, you will recoup your money. Whatever was spent at the initial time, you're going to recoup it. And also, you will save. Now you will no longer waste drugs or say, oh, I can't buy this drug, I can't buy that drug, this drug is not available, or this service is not available, because you're now saving. Because what you are procuring in bulk. You're no longer procuring in bits. Now you have the solar system 24 hours, so you can procure in bulk and keep in the hospital and use it. You also have the least cost option, and you have savings. There is no longer repair of gensets, diesel, and any of those things, because now you have a better system, and there is also increased productivity. A patient can walk in at any time of the day and meet lights, and there will be no, oh, sorry, there's no light, let's reschedule this surgery for another time. No, there's going to be increased productivity and client satisfaction. During our installations, when we started the project, after installations, there were some testimonials from persons who had already installed that I feel it would be beneficial to share with you, because they are mind-blowing. When a hospital installs solar, the testimonials are numerous. They tell you their experience, and then you just marvel at what can be done if we find an alternative form of energy. So one of our clients said, our generators at the hospital has been retired. NEPA has been retired. Due to solar installation at our facility, we now enjoy 24 hours electricity supply, to the delight of staff and patients alike. We were able to conduct 38 surgeries in less than a month. This is what they could not achieve before. But after installation, they were able to install, and in less than, and no more concerns for emergencies, even at the dark of the night. No more generator noise, because generator noise itself could even be a problem. Your patient is having an issue, he's complaining of headache, and he's hearing goo, 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 goo from somewhere. You know, there's no more generator noise, no more lack of petrol, or running around to go and get petrol before the gen goes off. No more generator repairs. So all that has been taken off, because now he has solar. So he said, thank you, Ave Health Sense, for boosting our confidence energy-wise. That is a very strong statement, if you ask me. Another client also said, he can't remember the last time he bought diesel. He was asking his security for the past 2 months. The 1,000 liters we have is still there. But before then, every week I must buy 1,000 liters of diesel. So I would like to encourage as many hospitals that can key into the initiative. Yes, initially it could be capital intensive, but at the long run, it is highly beneficial. So these are testimonials. There are a lot of them. But these ones were very striking, and that is why I added it to my presentation. Now, Elizabeth May says something. She says, once you get a solar panel on a roof, energy is free. Once we convert our entire electricity grid to green and renewable energy, cost of living goes down. Once we as individuals get solar panels on our roof, energy is free. Once we as hospital owners get energy on the roof of our hospital, energy is free. You're saving costs, you're satisfying clients, you're able to do so many other things, because now you don't have to wait for the power distributing companies or diesel or anything like that. The tariffs does not concern you, because you have energy. Your savings goes down, you can sleep in your house, without problems and without somebody coming to tell you that, oh, you owe this bill or you owe that bill. So the use of renewable energy has come to stay. And if we adopt it in our hospitals, if we adopt it in our homes, the stress, your stress level, if you had hypertension because of power before, it will go down. That is what we are saying. So these are our details. If you want to schedule an energy audit, I don't know if I explained the energy audit. Usually energy audit is done before to know the hospital's need. So whenever you need, energy audit is done for you. A design is done for you to know what suits your hospital. So once that is done, then we can now go ahead and give you what is needed for the installations to go. So if you want to install an energy audit at no commitment, you can meet us. We are still around at the conference, just around the booth over there. You can reach out to us. Those are our numbers, and then we'll attend to you. We'll be happy to solve your energy need. Thank you very much.
Thank you very much, Stephanie, for the wonderful presentation. I would like to take your questions if you have any. Okay.
Thank you very much, Stephanie, for your presentation. Dr. Aphpn is my name, from Calabar. Throughout your presentation, you were just mentioning hospital, hospital, hospital. How about individuals? If they want to key into this Aphpn, how will they do it? Because I know the importance of solar. Now, for the hospital, you didn't tell us anything about the backup. You know that in Nigeria we have rainy seasons where the sun is not that high. So what we charge these batteries when the sun is not optimum? Thank you very much.
Okay, thank you.
Good afternoon, everyone. I'm Dr. Oguyemi from Lassuth. Thank you very much, Ave, for your presentation. I think it's a very good one. I like the ingenuity and the fact that you're targeting hospitals and making it quote unquote affordable. So my area of concern is this. We know that the batteries, the lithium batteries, they all have life cycle. So after like a period of a year or thereabout, what would happen to these batteries? Is there provision for maintenance, ability to be able to get new sets of batteries? Perchance you're still paying up the loan from Access Bank, which has been spread over 48 months, as you have said. What plans do you have for people when it comes to maintenance and being able to sustain, this huge investment that one is making? Thank you very much.
Okay, thank you. Right. All right, so I'll answer the first question. So Race for Healthcare project was initially designed for hospitals, but along the line, we can also install for the homes of healthcare workers. So our initial design for Race for Healthcare is for hospitals, but we are also ready and available to install for any healthcare worker who would want to install a solar system in their home. All right. And your second question is concerning the backup system. So you have the batteries, and the panels are there to charge them and give you a backup power. It's also very important to understand how solar system works in the hospital. You can schedule, by the time your backup system is full, after your race has been absorbed and inverted into and stored in your battery backup, the backup has been stored to be used later in the night. Once you have your backup stored, you are directly using from your solar panel the energy that is generated to run your facility in the morning. In the evening is when you start to run from your backup, oftentimes. Okay? Okay, good. So it's also very important to understand that your solar energy is not generated by sunlight. It is generated by sun rays, not sunlight. So even no matter how little you have sun rays, you are able to generate. And also we are using high photovoltaic panels in our own case. So we're using the very high standard panels that we use for the absorption of the rails. The panels we use absorb more rays faster than the regular smaller panels that you see on the roofs of hospitals. So that is able to charge your system even in raining season. You have it charged, okay? Second question, in terms of battery maintenance. So we are using lithium-ion batteries. They are different from lead-acid batteries. Lead-acid batteries are the ones that require maintenance. This is a battery, it has been coupled and packed. As it is packed like this, no one is opening it for 10 years. Your battery is there. And by the second, third year, you are done paying up your system and it is officially yours. No one is opening this. We're not coming to do any maintenance on your battery. We're not changing any acid. We're not doing anything. Your system has been coupled. It's lithium-ion battery. Nobody's touching anything. So it is usually lead-acid batteries that require maintenance, changing of acids, and we don't use that because it is very sensitive. It is not needed in the hospital. So we don't use that because it's even unreliable. We have a document that was shared yesterday after the presentation, I'm sure it was shared, on the difference between lead-acid batteries and lithium-ion batteries. We are using lithium-ion batteries and they are very, very reliable. They have the warranty for 10 years. They are going to serve you for 10 years. If there's any issue with any battery, we have a reverse logistics system that takes up the battery and replaces it for you with another one immediately, as long as it's within the warranty period. I guess I've answered that question. One more question.
Please, we need to break now. We need to, please. Dr. Kene is around and the team, they are all around. They have a booth at the back of this place. If you have more questions, they will be happy to attend to us. I want to apologize. We have to stop at this point. We need to let us appreciate the team for the wonderful presentation. They have a booth at the back. We have their flyers, so it's for us to go and make more inquiries so that we can acquire our own inverters and batteries and whatever they have for us. Thank you very much. Let's take a group photograph here. Dr. Kene, you want to come and join your team so that... Please, while they are doing that, we want to thank you for your patience this far. We want to go for lunch now. Please, lunch is going to be short. But as you are going for lunch, let us branch as the booth for UAC booths. They have package for each and every one of us, but you must go with your identifier. So let's go to that booth. UAC booth, they have something for us. When we come back from lunch, we take the presentation from UNFPA, then we break into the parallel session for our scientific conference. That is where we are going to end for today. So all presenters, please, if you have any issue with your presentation, see me before the end of lunch. Anybody that comes after lunch, I may not be able to attend to you, please, because we are running short of time now. Thank you very much. Let us go for lunch. We'll come back in 30 minutes time, please. Thank you. Well, please, if we have these persons, let's take their seats so that we can start our last session for the day. Please, the presenters for abstracts, you already know where you are presenting. If you are presenting in this hall, just come to the front so that once they take their seats, they can bring you up to present. Please, if anybody knows these people have called the chair and co-chair, they were about, if you can get them so that we can start quickly. Thank you. Professor Olumide Abiodun is the chair in this place. Professor Philly is the chair for room 2. Presenters, please come forward so that once they are seated, we can start our presentation. Please, online presenters for room 1, just log to room 1. The ones for room 2, room 2. Please, I want to invite Professor Mishore to come and help me chair this session. Please, please. Professor Mishore, please. We are taking parallel session 7. That's page, I'm coming. That is page 40. Yes, I will join you. You can start with this one, so I will guide you on other things. Please, if you are here, just indicate abstract code 065. 065. 065. 066. 066. 0, okay, we have taken 069. 071. 071. 072. 072. Okay. 072. How about 065? I'll take again. 065. 066. 069. 071. 072. 074 is supposed to be online. Please confirm. 074 if you are online, confirm. 075. 74. 075. 075. 076. Okay. 077. 017. So we are going to take you to, sir, what of your number? 080, yes. How about 079? 079. 078. 078. Sorry, sister, what is your number again? 017.
Okay. Is 071 here? Good afternoon, everyone. We are welcome to this scientific session. Some of our presenters are not here, but we'll take those who are available. To the best of my knowledge, I don't think 065 and 66 are here. 069 has been taken in the morning. What of 071? Is it 072? Do you have 072? Okay, so let's take 072 as the first one, which is on violation and exercise of sexual and reproductive health rights among ever married women in Ibadan metropolis, a mixed method approach. Please come forward. So we are taking 072. Yeah, please let's have that on the screen. The authors are Abraham, Sarah, Temitayo, Obo, Abiola, Oluwatoyin Makinde, Oluwatosin Adebimpe, Adebayo Ayodeji. After 072, is 074 available? Okay. 075? Okay, let's take 072. Please go ahead. Dr. Mike, I think each presenter has 8 minutes. 8 minutes.
Well, depends. As you progress, you may wish to shorten your time. It's at your discretion. But when it is time, we have to close. It's already after 5. Our target is to close by 6.
Okay, so please let's use 8 minutes. At 6 minutes, you will get a little bang. Thank you.
Good afternoon, the chair, my teachers and colleagues. Standing on the existing protocol, I am Kayode Ilugbo, and I'll be presenting on behalf of the team. I'll be presenting violation and exercise of sexual and reproductive health rights among ever married women in Ibadan metropolis. And the team has been introduced earlier: Abraham S.E., Temitayo Obo, Ilugbo, that is me, Makinde, and Adebayo A.M. I'll be using this outline. Sexual and reproductive health rights are an essential component of the universal human rights to the highest attainable standard of physical and mental health, and they include access to sexual and reproductive healthcare services and information, as well as autonomy in sexual and reproductive decision making. And they are central to achieving gender equality and sustainable development. The exercise of these rights is critical to women's ability to protect themselves from unwanted reproductive and sexual outcomes. However, not exercising these rights leads to frequent violation of their rights. Globally, 30% of women have experienced physical and or sexual violence by an intimate partner, which is known as IPV, the intimate partner violence. And this picture is even higher in sub-Saharan Africa and in Nigeria. And common violations of these rights in Nigeria include forced marriage, dowry-related violence, widowhood practices, virginity rituals, female genital mutilation, intimate partner violence, women trafficking, unsafe sexuality, and sexual abuse of different types. And most of the barriers to women's exercise of their rights stem from ignorance and attitude of the society, individuals, including healthcare providers. Much attention has been given to the exercise, has not been given to the exercise of the sexual and reproductive health rights by married women. And married women especially are vulnerable because of the position of marriage, their family characteristics, gender roles, and cultural influences. A previous study in this field focused on the knowledge and perception of married women to their rights, sexual and reproductive health rights, and little to no study has been done about reporting a violation and the exercise of these rights. The failure to exercise rights, the sexual rights by the married woman, contribute to the experience of the violation of these rights. The study had two objectives. The first one was to assess the violation of sexual and reproductive health rights, and the second one was to assess the exercise of sexual and reproductive health rights among ever married women in Ibadan metropolis. The study design was a community-based cross-sectional study using a mixed method approach. The study location was Ibadan, southwest and northeast local government areas. The population was ever married women of the reproductive age group 15 to 49 years, and the sample size after the calculation and adjustment, the minimum sample size was exceeded for the study, which was, we had a sample of 423 women, and the sampling technique was multi-stage, and data collection, there were two instruments. The first one was for the quantitative aspect, the semi-structured interviewer administered questionnaire, and for the qualitative, a focus group discussion guide. The data was analyzed with descriptive statistics, and the two outcome variables were the violation of the sexual and reproductive health rights, which was the answer of yes, the response to yes to the question of, has any of your rights been abused? So there was a list of all the rights, has any of all these things listed abused? So yes to that answer was termed as the violation of their rights, and the exercise of their rights too was, have you ever taken any form of action against violation and or against the abuser of your sexual and reproductive health rights? And so these are the results. Most of the respondents were aged 25 to 39. They were married. Their highest level of education was secondary school. They were unskilled workers and of the middle socio-economic class. And for the experience of the violation of their rights, a quarter of them had experienced violation of their rights, that 25%, and the rights that were abused was the right to the freedom from violence and sexual immunity, right to freedom from abuse. They were the highest reported. So there were many rights, but because of the presentation, I just picked the ones with the highest proportion. And the abusers were majorly the husbands, friends, and relatives. Generally, 90% claim to have ever used their rights, either those abused or those not. 90% of the total population. And of these, the right to marriage and the right to family planning were the commonly used. And over half of the respondents reported that their culture and religion support them to exercise their right, especially the right to bodily control. And of those that had been abused, exactly half did nothing against either the violation of the right or the abuser. So for the qualitative aspect, I'll just rush through. Most of the participants agreed to the part of abuse of rights is common, the violation of their rights is common, and one of them said married women are terribly beaten and sexually abused to the extent that they may abort their pregnancies. So they agreed on the general experience of married women in the violation of their rights, and on the exercise of their rights. Many of them said it should be individualized and not that it cannot be taken as a group, that each individual should, according to them, each man to his cross, not one size fits all. One of them said she used injection and pills to prevent pregnancy, and the husband was not aware because she did not want her rights to be abused. So in discussing our findings, the findings show a high prevalence of violation of the sexual and reproductive rights, which is embedded in the deep socio-cultural beliefs, and there is a limited awareness, which were things that the FGD brought out. I'm sorry I did not put, okay, thank you, sir. And is, however, paramount that for women to exercise their rights is important in achieving their fundamental human rights and gender equality. In conclusion, 1 of every 4 respondents had ever experienced a form of abuse of their sexual and reproductive health rights, and the women should endeavor to involve their partners and spouses when making the decisions that affect their rights. And if they are not supported, where ignorance and negligence of the partners exist, the women carefully decide on issue and seek support from constituted organizations and agencies that promote the implementation of these rights. Thank you.
Okay,
These are my references. Thank you.
Okay, thank you very much. Please, if you have questions or comments, kindly let's note them. Sorry, before 074 comes up, I was told that there's somebody that should have presented yesterday, 017. Can the person please come up? I couldn't see that in the abstract list. I hope your slides already loaded. No, there's 016 and then 17 was jumped. On page 35, there's 016, then 017. If your slide is not loaded, maybe we'll take 074 first, if it is not, to save time. It's not loaded yet. Sorry, I didn't get you. It's not. Okay, so let's take 074 while they get that loaded. 074. And that's on work-life balance, coping strategies, and psychological well-being of medical doctors in a tertiary health facility, Southwest Nigeria. A number of authors there. But the presenter is, what's the name of the presenter? Adeyemi, oh, okay, Dr. Amuda. Dr. Adeyemi Akim Amuda will be making that presentation. Thank you. You have 8 minutes, please.
Good afternoon, sirs. Good afternoon, Mass. Standing on the existing protocol, our study title was Work-Life Balance, Coping Strategies, and Psychological Well-being of Medical Doctors in a Tertiary Health Facility in Southwest Nigeria. Here's the list of the authors. I'm Dr. Adeyemi Akim Amuda. Using this outline, we'll be discussing our study. And as background to the study, there has been a global increase in the workload of healthcare workers following the COVID-19 pandemic. And it's also known that there is also a recent upsurge in the immigration of healthcare workers from Nigeria to high-income countries. And also, currently, because of the current economic situation in the country, many doctors are actually finding it difficult to cope, and so they have to do a lot of multiple works at the same time to be able to make ends meet. So all these actually make maintaining a positive work-life balance very difficult for most doctors. So the prevalence of poor work balance among doctors is higher than that of the general working population. And this is due to a lot of reasons stated here. And the consequences of the disrupted work-life balance are multifaceted. So they have effects on the individuals and also on the system. And one of the effects on the personal life is burnout, decreased job satisfaction, psychological distress, and some others. Whereas on the, it also compromises the standard of care for the patients. So what's the justification for this study of ours? The available post and COVID-19 data on work-life balance and coping strategies among doctors in Nigeria are limited, while the existing ones are actually focused primarily on the early career doctors like house officers, junior residents, who live in other medical doctors unstudied, and also some studies actually focus on their female counterparts. However, also some studies also studied some isolated professionals among the doctors, such as maybe among the general patients, medical doctors, amongst the general surgeons and the likes. However, these studies of ours is actually examine the work-life balance, coping strategy mechanisms, and the psychological well-being of all medical doctors at OHHC Ile-Ife. So the study setting is OHHC Ile-Ife and used analytical cross-sectional study design. The participants were selected through a multi-stage sampling technique, and a mixed method study was used. 250 doctors for quantitative study, and this they were taken according to proportionate to size, using the cadres of the doctors and also different departments they belong to. Also, for qualitative studies, 8 doctors were selected, and they were selected in such a way to reflect the group dynamics among these doctors. So the quantitative data was analyzed using SPSS, while with P set at less than 0.05, while thematic analysis was used for qualitative data. Ethical approval was sought and granted by the Ethics Research Committee of OHHC Ile-Ife. The data were anonymized and handled only by authorized personnel. So this table is showing the socio-demographic characteristics of the respondents. So for the age distribution, majority of the respondents actually belong to the 30 to 39 years category, and 71.2% of them were males, 68% of them were married, no, 41.6% of them had no child, and the average monthly income for them, the range it started. It was from 300,000 to 500,000 among the 53% of the respondents. Then 71% of them actually married healthcare workers, and 60% of them had no other jobs. So for the distribution of work-life balance, coping strategy, and psychological well-being, the study found that 58.8% of the respondents had poor work-life balance, and then for the coping strategies, which was a sort of a multiple choice options for them, 82.8% of them actually took active coping as a coping strategy, whereas 10.4% of them actually used one substance or the other just as a coping strategy. The 90.6% of them had poor psychological well-being, while 80.4% of them had good psychological well-being. Then for the quotations of some of the respondents regarding the coping strategy, for instance, one of the respondents actually mentioned that work-life balance cannot happen accidentally. So it is something you have to plan for and be intentional about. If you want to achieve some sort of balance, you need to go for it intentionally.
2 more minutes.
Also, so for those who, for somebody who talked about denial, so the statement was also quoted verbatim as shown on the slide. So looking at the association between work-life balance and explanatory variables, for the age categories, it was noted that the older you are, the more likely that the respondent will have a good work-life balance, and the relationship was statistically significant, even at p less than 0.01. So also for marital status, those who were married were more likely to have a good work-life balance, and this relationship was also significant. Also, there was also a significant relationship between the spousal profession and the kind of work-life balance they maintain. For those who had healthcare workers as their partners, they had a better work-life balance. Even though the relationship was also significant. Also for psychological well-being, those who had good psychological well-being also had good work-life balance. So we want to discuss our findings around these themes. 58.8% of the respondents had poor work-life balance, and this was also consistent with the findings from the literature. And this remark here is that there is actually a need for immediate intervention by relevant stakeholders. Also, the prevalence of substance use as a coping strategy among the respondents was 10.8%, and this was quite higher than what was documented in the previous studies. Where high prevalence of this maladaptive coping strategy actually reflects probably the present shortage of manpower at OHSC, and there is a need for a drastic step to be taken in that direction. So our study also found that 80.4% of the respondents had good psychological well-being, and this was also consistent with the findings in the literature. This was much higher than what was documented previously. However, our remark here was that this may be somewhat due to the differences in study populations. Okay. So thank you very much, sir. Then the negative work balance was associated with being young, being single, had lesser years of experience, and so on and so forth. And their remark is that the personal and work-related factors influence the work-life balance of medical doctors. So in conclusion, we conclude that our study found a high prevalence of negative work-life balance among doctors. Then it was also demonstrated in our study that there are various socio-demographic and work-related characteristics that significantly affected work-life balance. And so the study does recommend that there should be introduction of employee aid programs, there should be training on work-life balance and positive coping strategies among doctors, and also adjusting doctors' workload to allow for better work-life balance. So thank you very much, sir.
Thank you, Dr. Amuda. Thank you. A round of applause for him. Please let's note our comments and questions. Please, are we ready for 017 now? Huh? 017. Are we ready for it now? Okay, maybe we'll take the next one. 075 here. 076. Okay, sorry. 076 can come forward. Then do you have 077? I just want to know, 077, do we have 077? 078, 079, 0. Okay. So let's take, this is 076, have we? Okay, let's take that now. 076 is factors influencing disease surveillance and notification practices among health workers in private facilities in Federal Capital Territory, Abuja. And Dr. Adebayo will be presenting on behalf of the other authors. Thank you. There's no 077. We have 079 and 080. Are those ones ready? Do we have the slides of those ones? Either 79 or 80. Can either of them come? Okay, 79, please come. While we'll get 017 and 76 ready. So 79 is on valence pattern and effect of abuse of methamphetamine, umpiri, seeds of water among students in Anambra State, Nigeria, by Kingsley Chinedu Okafor, Uzua Maka, Ude Akwe, and John Bim. Thank you. So let's have that slide, please. So let's get the others ready, please. 017, 076, and 080.
Okay, thank you very much. I will stand on existing protocol. I will be talking about prevalence pattern of Urummiri use among students in Oka, Anambra State. The authors, Kingsley Okafor.
Okay, you are Kingsley Okafor?
Yes.
Okay, thank you.
So drug abuse is common in our community and has been described as inappropriate use of substances for the purpose of pleasure, to feel or perform better in certain situations, or to change one's perception of reality. It's increasing amongst the youths, and there are so many types like alcohol, cigarettes, opioids, cocaine, marijuana, and methamphetamine. Crystalline methamphetamine is a common drug currently. It's like grass fragments, shiny or bluish in color. It's chemically similar to amphetamines. It comes in different types, forms, tablets, powders, and crystals. It's actually an illegal psychoactive stimulant drug similar to amphetamine, discovered in the 19th century and used as a nasal decongestant. It currently is addictive and it can be smoked, snorted, injected, taken orally, or used with other substances. It causes temporary sense of heightened euphoria, alertness, and energy, and seemingly release of dopamine amongst the users. So it encourages them to use because it gives them a rewarding and reinforcing behavior. Methamphetamine is cheap and easy to manufacture. It's available in our environment in Asaba, Enugu, and Onitsha. They have met labs available there, as discovered by NDLE and the other agencies. It's common also in America, and there are key situations in these states that increase the incidence of amphetamine use. You have things like armed robbery, rape, terrorism, kidnap, and it spurs other forms of criminality around the environment. It's also fueled by idleness amongst the youths. It's common in Nasarawa, 40%, in 65% in Kogi State, it's 2% in Plateau State, and is increasing across the country. The objective of this study is to determine the prevalence and pattern of Urummiri use among students in Anambra State, to ascertain the prevalence and also to determine the pattern of use. It was done in Oka, which is an economic hub in the east and also capital of Anambra State. It's a descriptive cross-sectional study design was used, and samples were selected using respondents-driven sampling technique. Total of 110 participants participated in this study. That was analyzed using SPSS. Analytical review consultation was gotten from Bingham University Teaching Hospital. Most of the respondents, about 60% were male, and it was it involved people within the age group of 21 to 30 years. Many were 34% of 60% had secondary and tertiary education. Mainly were Christians, were Igbo, and of Nigerian origin. They were introduced to methamphetamine mainly by their friends and neighbors, and some 10% were introduced by their family members. Current use of mkpuru mmiri was about 71%, and half of the respondents used mkpuru mmiri alone, while others combined it with alcohol, cigarette, and weed. And there is high dependence, as 87% are currently using it daily, and 85% more than 5 times per day. There's a community acceptance in about 28% of the respondents, and they believe that 80% is increasing in the community. Now, for the respondents, about 96% of them believe that massive campaign can help to reduce its consumption, and they need continuous orientation. They also believe, about 82% of them believe that arresting them will be a deterrent to others, but prosecution, only 50% agreed to be prosecuted if they are found using it, and 69% believe that they should be rehabilitated. In conclusion, the prevalence of methamphetamine use among users was 70.9%. Over a third were introduced to mkpuru mmiri use by their friends and neighbors. Most of them take mkpuru mmiri daily, and majority of the community members do not accept this use, while about 30% will accept it. Most users believe that use of meth is increasing in their environment. While 96% of the users agree that there should be massive campaign against it, 82 opined that series of orientation is also important to stop them from using it. 51 agreed to be rehabilitated during the process. So we recommend that the Anambra State government and other government agencies should be involved in tracking the supply chain for this, for methamphetamine, and also dismantle it. The State Ministry of Health, the Ministry of Youth and Sports should also be able to identify these users and draft them into a rehabilitative program around the state. The Ministry of Information and other media houses should carry out awareness campaigns on the dangers of consumption of methamphetamine by the youths. Strict penalties should be meted out to both the sellers and the users to serve as deterrents to anyone who may wish to sell or use the drug. Government should also partner with other heads of tertiary institutions to ensure that the drug is not available within their environment. Most youths are gradually becoming idle and frustrated. So it's important for government and NGOs and communities to establish youth programs that can give them sellable skills like computer programming, data coding, digital marketing, and even sports to give them time to utilize their energy positively. Thank you.
Okay, thank you for keeping within the time. Which is ready next? Okay, so we take 076, factors influencing disease surveillance and notification on health workers in private facilities in FCT Abuja, to be presented by Dr. Adebayo.
Thank you, the Chair, the Secretary, my seniors, my teachers, and my colleagues. So I'll be presenting the topic. Our topic is factors influencing disease surveillance and notification practices among health workers in the FCT Abuja. Okay, and I'll be using this outline.
Okay, move on, please.
Yes, sir.
Okay.
By way of background, disease surveillance and notification is a process of reporting occurrence of disease or other related health-related conditions to appropriate and designated authorities. And it is part of the health management information system, involving not just facilities, but surveillance units at local government area, the state, and then the federal levels. Data that is collected are analyzed before transmission from the state and then to the federal level. For statement of problem, the collection, collation, analysis, and interpretation of data in public health facilities are often unsatisfactory in Nigeria. This is attributed to several factors such as inadequate registers and insufficient forms. Additionally, there are also logistic problems that are experienced by personnel within surveillance units. This often results into poor analysis of data and poor feedback, both at the local government levels and then at the state levels. Many studies to assess factors influencing unsatisfactory response to disease surveillance and notification among healthcare workers were done in public health facilities, but a few were done in private facilities. So there's a need to explore the familiarity with disease notification and reporting system among workers in private health facilities. The objectives generally were to assess the factors influencing disease surveillance and notification practice among healthcare workers in private facilities in the FCT. And then for specific objectives were to determine the healthcare workers' level of knowledge of the current trend of disease notification and reporting system among healthcare workers in private facilities in the FCT, and then to also assess the practice of disease pattern reporting system among healthcare workers in the private health facilities, and lastly to identify the factors influencing their practice of disease notification and reporting system among the healthcare workers. The study area, as mentioned earlier on, the Federal Capital Territory, with 6 area councils.
Let's move a bit faster.
Okay, thank you, sir. The design was cross-sectional, it was a descriptive cross-sectional survey, and then the population were to be healthcare workers in private healthcare facilities in the FCT. Sample size was determined using the Leslie Fisher's formula, and then 379 samples were used. A multi-stage sampling technique was employed, and then the instrument was a semi-structured pre-tested questionnaire which was validated. For data management, we used SPSS version 23, and then for the questions were analyzed using descriptive statistics in form of percentages, frequency graphs, and tables, while the null hypotheses were tested using inferential statistics of chi-square at 0.05 level significance. Scoring of outcome variables was done using mean score on knowledge, attitude, and practices. Ethical approval was sought from the Ministry of Health, FCT. For the results, for the demographic characteristics, a larger percentage, 57%, fall into the 35 to 49 year age group. And then about 2/3 also were females. For level of education, a large percentage of them were in had tertiary level of education, and for the working as regards working units, about 23.5% were in the medical record unit. Okay, thank you, sir. For awareness, about 2/3 also were aware of notification and reporting system. This shows a summary. 57% had good knowledge. 61% had an unfavorable attitude. And then for practice, 85% had poor practice concerning disease reporting. Then this table also shows an association between knowledge, attitude, and practice. For discussion, a large proportion of healthcare workers in this study were aware of the IDSR strategy, but generally they had a poor knowledge on the tools and its importance. This is an agreement with the study conducted by Inebue et al. In 2015. It is of interest to note that more than half of the respondents, about 61%, had favorable attitude, while majority had poor practice. This could be attributed to inadequate availability of standard case definitions for IDSR, as well as poor training of healthcare workers on IDSR strategy. This is contrary to the outcome of another study by Tobin West in southern Nigeria, where majority reported good practices. Concerning the attitude of healthcare workers towards reporting on IDSR tools, majority of the respondents in this study have used IDSR tools in reporting immediate notifiable diseases. This is similar to the study conducted by Ekanem et al., where it shows that reporting IDSR is necessary and that reporting priority disease is a public health responsibility of healthcare workers. Practices are influenced by knowledge and attitude among respondents. In conclusion, this study concluded that a majority of healthcare workers were aware of the IDSR strategy. They had poor practice on installation of the tools due to inadequate knowledge on the use of the various forms and data. This poor reporting requirement seems to be a major factor affecting disease surveillance and notification of priority diseases. The resultant negative effect was that these healthcare workers in private hospitals will be unable to detect and notify the occurrence of diseases that have high case fatality rates and of public healthcare importance. Therefore, more attention needs to be devoted to regular training and training of healthcare workers. These are my references. Thank you.
Thank you. Sorry, I was just told that there's somebody online that would need to take. Possibly should have been taken yesterday. That's on page 38. We will see number 35. That's serial number, abstract number 043. Pattern of STI cases at the Sexual and Reproductive Health Clinic in a tertiary health facility in Rivers State. There are a number of authors there. Please, who is the presenter? What's her name or his name? Can the presenter come online? Serial number 35, abstract number 043.
Mary Dimba, if you can hear us, Mary Dimba, abstract number 043. Mary Dimba, can you hear us?
I'm pleased we have a plenary session after this. I learned the present paper, so we need to run this up soon. If she's not coming online, maybe we'll take. Are we ready for 080 now? 80 or 017, either of them. Either 017 or 080. Okay, 017, please come. The next is 019. So we're waiting for that to be projected. Okay, it's on dietary habit and nutritional status of pupils in public and private schools in Port Harcourt, Rivers State. Please go ahead.
Good afternoon, Mr.
8 minutes.
Good afternoon, Chairman. Good afternoon, my teachers, my mentors, and colleagues. I'm going to be presenting on dietary patterns and nutritional status of pupils in public and private schools in Port Harcourt, Rivers State, comparing primary schools in both schools. Now, the study was done with a colleague, and I'm the one presenting for today. Dr. Carol Joseph.
Okay, Dr. Joseph.
I'm taking the outline as shown. Now, the dietary habits and the nutritional status of school children are essential for creating effective health interventions. This is because assessed dietary intake, physical activity, and nutritional status among pupils in Port Harcourt's public and private schools are going to be assessed. Given the evolving nature of dietary intake patterns, food consumption frequencies, and nutritional knowledge among pupils in Port Harcourt, there is a compelling need for in-depth research that examines the potential impact of school type on the dietary habits and patterns of the children across the various demographic areas in the state. This study holds a critical association for several reasons. Because childhood malnutrition remains a formidable and enduring public health challenge in Nigeria, exerting a toll on children's physical growth, cognitive functions, and future well-being. Secondly, it is vital to recognize that the challenges and disparities in childhood malnutrition within Nigeria persist, even as we make a lot of efforts. These disparities span geographical location, socioeconomic status, access to good water and sanitation, education, and also the health services available in the state. In this context, the research offers a promising avenue to show evidence-based policies and interventions. We decided to evaluate and compare the dietary intake patterns of pupils in public and private schools in Rivers State, Port Harcourt. And our objectives were to evaluate and compare the dietary intake to determine and compare the patterns of physical activities of these pupils, to determine and compare the pattern of nutritional status, and to identify the factors that could influence the nutritional status of pupils in the state. Our method was a comparative cross-sectional study design using recruiting 348 pupils from both school types, and we had multi-stage sampling up to 4 stages. Our data were collected through structured questionnaires, while anthropometric and physical activity measurements were taken accordingly with standardized established methods. Analyses were performed using the IBM SPSS 23 version with bivariant logistic regression, analyzing the social demographics and other nutritional outcomes. Now, for the results, pupils in private schools demonstrated superior dietary habits. They had options of having a regular breakfast, having fruits amidst their food, while they are able to consume all that. Conversely, the public school people showed higher rates of stunting and underweight, while overweight was more common in the private schools as well. Significant correlations were identified between stunting and factors such as low socioeconomic status, lack of maternal education, and rural living. Public school pupils face greater risk of being underweight, particularly those from low socioeconomic backgrounds and without maternal education. Now, low socioeconomic status consistently predicted underweight in both types, with private school people showing higher overweight prevalence. Social demographic characteristics of people across public and private schools highlighted pronounced disparities that influence educational experiences and outcomes. A clear distinction emerged in the socioeconomic backgrounds of students of the private school, predominantly coming from higher socioeconomic families, showing that 31.0% falling into the high socioeconomic bracket compared to just 11.5% in the public schools. On the other hand, the majority of the public school pupils are from low socioeconomic status, with 58% of such pupils from low background. Dietary intake. The comparison of dietary status of pupils in public and private schools shows essential differences. Using the scale from 1 represent never and 7 always, private schools are seen to consume breakfast more as often as 75% scored 7 and so on. Other bivariant activities that were established were physical activity patterns of the pupils, anthropometric measurement of the pupils, association between gender and anthropometric characteristics, and association between physical activity using the BMI scale, presence of stunting by socio-demographic characteristics, presence of overweight by also the socio-demographic characteristics, and presence of underweight in school children by socio-demographic characteristics. In conclusion, the study highlighted significant disparities in dietary habits and nutritional health between public and private school pupils in Port Harcourt, with private school pupils exhibiting better nutritional status. Addressing economic barriers and promoting healthy food access and parental health education, especially in disadvantaged areas, is one of our recommendations. Thank you very much. These are my references.
Okay, thank you very much. Please let's note our questions and comments. The last presenter, do you have 080 now? 080. Okay. 080 is assessment of prevalence and usual factors of occupational stress among secondary school teachers in Enugu metropolis. The presenter is Dr.
Cassie Wilson Chukwukas.
Dr.
Cassie Wilson Chukwukas.
Okay. Dr. Cassie, thank you. So let's have the slide.
I will stand on the existing established protocols. Okay, go on. Okay, these are our outlines. Occupational stress is the harmful physical and emotional responses that occur when job requirements do not match the capabilities, resources, or the needs of the worker. Occupational stress among teachers is a significant public health concern, particularly in secondary schools where the demands of job can be exceptionally high. Occupational stress can lead to chronic illnesses like hypertension, diabetes, cardiovascular diseases, and some mental health problems, including anxiety, depression, and burnout. Also, it can reduce the quality of life and ability to perform effectively with increased absenteeism and lower job satisfaction. Consequently, it affects the students' learning abilities with low quality education that are delivered by the teachers. Noted that in previous studies, I find that over 50% of secondary school teachers in Nigeria experience moderate to severe levels of occupational stress. This stress stems from various sources, including excessive workload, student indiscipline, and lack of support from school management. Factors such as age, gender, years of teaching experience significantly influence the stress levels of teachers. Less experienced teachers are more vulnerable. We have noted that there is paucity of research focusing specifically on secondary school teachers in Enugu State. This study will produce empirical evidence on the prevalence and effects of occupational stress, contribute to the body of knowledge in this area, and inform policy and practice. Identification of the key drivers of occupational stress may guide the development of comprehensive support system for teachers, and understanding the unique stressors faced by teachers in this region is crucial for developing targeted intervention that can effectively mitigate stress and improve teachers' working conditions. Our objectives are to determine the prevalence of occupational stress among secondary school teachers in Enugu State, to identify the key factors contributing to occupational stress among secondary school teachers in Enugu Metropolis, and to identify the effects of occupational stress on the health and well-being of secondary teachers in Enugu Metropolis. The study was carried out conducted in Enugu Metropolis, the capital territory of Enugu State, using descriptive cross-sectional studies. A total sample of 278 was studies after correcting using the finite population correction formula. A multi-stage sampling technique was used to select the 278 secondary school teachers in Enugu Metropolis, because Enugu Metropolis has 3 LGAs, 3 per LGAs. We are given a total of 9 public schools. In each of the schools, 31 teachers were selected from the nominal roll using the table of random numbers. Data were collected using the teacher stress. Data we are collected using the teacher stress inventory. Data we are analyzed with IBM SPSS version 20. Ethical approval we are gotten from the Health Research Ethics Committee of UNT of University of Nigeria Teaching State Enugu. Informed consent we are obtained from the teachers, and necessary approvals we are secured from the Enugu State School Board. From our result, the prevalence of occupational stress among teachers was found to be 72.3%. We find that physical health problems such as fatigue, headaches were reported, and anxiety and depressions were also reported. The key stressor included excessive workloads, where 61.1% of the teachers noted excessive workload, student indiscipline, 47.1%, and inadequate teaching resources. Years of work experience and job insecurity were significantly associated with stress level. The common coping strategies included taking breaks and time off from work and seeking support from family and friends. These are a bar chart showing that most of the teachers who reported stresses are more often than always, and that of job satisfaction among the teachers. Then discussion, we found that there is high prevalence of stress among teachers in this study, with 72% experiencing stress at various frequencies have grave consequences on their job performance and on the students' learning outcomes. These findings agreed with findings in 2021 by Zadok, Gorman et al. And systematic review by Garcia, Carmona et al. In 2019, where they found that up to 70 to 89% of teachers and secondary schools have experienced stress, occupational stress. In conclusion, we find that the prevalence of occupational stress among secondary school teachers in Enugu State is high. Multiple significant stressors affect teachers in Enugu State, with workload as the predominant factor. The impact of occupational stress on teachers and health and well-being is substantial and complex. So these are my references.
Okay, thank you. Do we still have anybody online? Okay. 043.
Good evening, panelists.
Good evening, we can hear you. Thank you. Please go ahead and present. Extract number 043.
Okay. Good evening, panelists and every other participant. My name is Barine Mary Dimpa. I am going to be doing a presentation on behalf of my co-authors, pattern of STI, sexual and reproductive health clinic in a tertiary health facility in Rivers State. I'll be using the following outline. Background. Sexually transmitted infections remain a significant public health issue globally, with varying prevalence across different regions. STI impacts negatively on sexual and reproductive health of individuals within the reproductive age group.
Please put on slideshow, if it's possible.
There are about 30 different conditions, among which there are about 30 different STIs, among which the most common are gonorrhea, chlamydial infection, genital warts, and HIV. Statement of problem. According to the World Health Organization, STIs are one of the most common diseases for which individuals seek medical help. Globally, female adolescents and young women have the highest risks of curable STIs. A study done in India on patterns of STIs in a tertiary health facility showed that the majority of people diagnosed with STIs had syphilis, followed by condylomata acuminata. Podell also did a study and documented that condyloma accuminata is one of the most common STI in his study. Justification for this study. In Nigeria, the burden of STI is made worse by factors such as poor access to healthcare, inadequate sexual health education, and socioeconomic challenges. According to WHO, Nigeria experiences a high prevalence of STI with variations in different regions. This disparity is in Rivers State. In Rivers State, there is a paucity of data on the pattern and prevalence of STIs in this region, and therefore it is important to assess the pattern of cases seen at the clinic for the past 5 years, as this will help inform clinical decisions. Understanding of these patterns is essential for developing targeted interventions and policies to reduce the burden of STIs in Rivers State. Objectives of the study. General objective was to assess the pattern of STIs and HIV seropositivity among patients presenting at the STI clinic in UPTH from 2019 to 2023. Specific objective was to determine the pattern of STI among patients presenting at the STI clinic in UPTH from 2019 to 2023. Methodology. The study was carried out at the STI clinic of UPTH. A cross-sectional study design was used, which retrospectively reviewed records of cases seen at the health facility from January 1st, 2019 to December 31st, 2023. Case files of patients who presented to the clinic in the past 5 years was used as a study population. A sample size of 461 was calculated using the Cochrane formula for cross-sectional study with a prevalence of 18.2%, which was the prevalence of STIs seen. Data was collected using data extraction sheet, which had social demographic, sexual activity, and pattern of STI infection sections. Data was analyzed using SPSS version 27. Descriptive statistics was used to summarize data. Pearson's chi-square test was used to determine association between outcome and independent variables. And level of statistical significance was set at p less than 0.05. Ethical approval was obtained from the Research and Ethics Committee of UPTH. Permission was obtained from the unit consultants. This study didn't involve direct dealing with human subjects, and so there was no need for consent from participants. There was no risk or threat to life. Results. 502 cases were seen over the period under review. The mean age of respondent was 28 years. About 45.8% were individuals within the age group of 20 to 29 years. Majority of them were singles, and more than half of them were males. 79.1% of them were from urban areas. Majority of the cases seen were new cases. 41.2% had one partner. 41.6% had multiple sexual partners. The proportion of those with multiple sexual partners was 25.7%. 58.4% used condoms sometimes, and 48.2% had a previous history of STIs, while 16.3% of the cases were HIV positive. From the table on the screen, you will discover that the most prevalent STI cases seen was the genital warts. And factors that were significantly associated with the pattern of STI cases were HIV status and previous history of STIs. Specifically, those who were HIV positive were shown to have higher proportions of multiple STI syndromes, genital warts, scabies, candidiasis, and genital ulcers, compared to those who were HIV negative. Those without previous history of STI also had a higher proportion of genital warts compared to those with a previous history. Those with a previous history of age at sexual condom use. Age at sexual debuts, condom use, and location of residence were not shown to be associated factors. Discussion. The data from 502 cases observed over the 5-year period reveal a predominance of cases in younger adults within the age group of 20 to 29. This is consistent with findings from other studies conducted in Ibadan. However, this study was in contrast with our findings, had some contrast with our findings because in our finding, we had more of males than females, and it is in agreement with another study conducted in southwest Nigeria. Findings also align with global trends indicating a higher prevalence of STIs among individuals in their reproductive age groups. This age group may be more sexually active, engage in high-risk behaviors, or have limited access to comprehensive sexual health education, highlighting a dear need for targeted preventive interventions. Genital warts were found to be most common among individuals within the age group of 10 to 19, suggesting that younger populations, particularly adolescents, were disproportionately affected by HPV infections. This is consistent with findings from other studies, such as studies done by Podell et al. And Davy et al., which also reported high rates of genital warts among STI clinic attendees. This highlights the need for early sexual health education and vaccination efforts, particularly the introduction of HPV vaccine to
Dr. Denta, please round off.
before sexual debut, as sexual exposure is a risk factor for HPV. In conclusion, this provides important insights into STI cases from 2023. Younger individuals, particularly adolescents and young adults, are disproportionately affected by genital warts, while older populations experience more disease and candidiasis. There are gender differences in STI females being more likely to experience genital warts, multiple STI syndromes, and candidiasis, while males are more likely to be affected by herpes genitalis, scabies, and urethral discharge. The rising trend in genital cases over has caused the need for intensified public health interventions and sustained STI prevention efforts across various population groups. Thank you for
Dr.
listening.
Dimpang. Thank you. Please stay online. Please, our time is actually fast spent. Do we have questions or comments? It's been a long day, I'm sure. Okay, I can see one hand at the back. Please quickly come forward. We'll take that. As it comes forward, I'll quickly just mention some observations. For abstract 079, your sample size 110 students for a study on prevalence of something as common, and you did it among students, is actually insufficient. I don't know how you went about it, but your study would have benefited more from a much larger sample size. Abstract 080, I'm not sure it's appropriate to use SPSS to draw your charts because you cannot label your axes appropriately. Okay, let's take that comment because of time. Or question.
Thank you very much for our presenters. So I have a question for the person that presented on methamphetamine. So I'm quite worried based on the prevalence that you found in your study. So I want to know particularly, based on the finding on the prevalence of the use of methamphetamine in your study, have you taken any practical step or are you planning to take any practical step? You mentioned that you're going to involve some stakeholders, you're going to involve policymakers. So are there practical steps that you have taken or you're planning to take to address the observed prevalence? That's my question. As I personally believe that beyond getting the data, presenting the findings, there should be some proactive steps to correcting some ill findings. My second question is to the second presenter, so that a study done in, I think in Ife, you did mention that 6 IDI participants were recruited. So I'm just thinking that considering the nature of the topic that was done, I was thinking that having more than 6 participants will have been good. Understanding that you mentioned that the 6 participants were recruited across various cadres. So considering the number of cadres we have within the medical practice and specialties, I was thinking that having something between 15 to 20, well, based on some literatures, it is expected that you have a minimum of 20. Some say 15 to 20. However, some would say that you have to reach saturation. And once you reach saturation, you stop recruiting. So I want to know the rationale behind selecting these 6. Thank you very much.
Okay, I think he said 8, but he would respond to that. So let's have Dr. Cassie respond to the first. Okay, that's not Dr. Cassie. That's Dr. Kingsley, yes. So please respond to that. I know you had many recommendations, even recommendations that were not really based on your studies, on your findings. But you can go ahead. Thank you.
Thank you. Concerning your comment on prevalence. Yeah, the prevalence that we calculated was prevalence among current users. Criteria for selection that you must have used methamphetamine at least once. That was the criteria for selection. And the essence of the study was to find out, for those who have ever used methamphetamine, who are those that are still using methamphetamine. So that was helped us to foreclose the need for very large sample size. And in our calculation for sample size, we got about 90 and yes, about 110. I'm decided to stay with that. The worry is for use of Mkpurumiri in the state as we speak, current things are being done. So people are either taking or not taking and are stopping to take. So this was to find out who are those that are still taking it at this point and who are those that will benefit from rehab. And that's why we employed using the same users to tell us what exactly they think will help them stop, their own perspective. And that was where we went ahead to find out what they think will be useful in stopping. And based on the findings of what they felt will be able to help them stop using the drug, we also made similar recommendations. Then we also thank you for the question on steps to take. As public health people, our role is to try to generate evidence and try to advocate for something to be done about it. So post presentation, we'll probably write an executive summary, 1-pager, 2-pager, to the executive commissioner for the state, to the State Ministry of Health, and to the Ministry of Youth and Sports, and also to the NDLE operating within the state. And the essence of the executive summary would not necessarily be punitive. It's for correction, for rehabilitation, and something should be done. The essence of saying, recommending, I got the point on recommending what you find. Now, I also expect that studies will also emanate from this, maybe qualitative studies and FGDs that will try to establish if the links on supply chains exist and why they do. The complete work actually has a document, a result that shows that there is, in fact, a chain of supply. And the essence is to help the government to see how they can track those labs and try to stop them. Thank you.
Okay, thank you. Those are very beautiful explanations. Thank you. I think the next, is that Dr. Amuda?
Yes, sir.
Okay, so please respond to your question. And just a comment from me. I'm not sure the instrument for measuring the work-life balance and the psychological well-being, I'm not sure they were mentioned. They should have been mentioned. Please go ahead.
Thank you very much for the comments and observations. I also thank the earlier speaker who asked about why we decided to use 8 and not a much larger sample size. The point was that we had in mind to actually interview as many people as possible. That was even the essence of going for IDI, so that we'll be able to really have in-depth interviews with these participants. Okay. However, before we even got to 5 or 6 or something, we're already reaching points of saturation, such that we're just getting the same responses over and over again. So there was no any point for the researchers to continue interviewing. So thank you very much.
Okay, thank you. I think that's all the questions we have. For Dr. Dimpa online, your general objective involved both STI and then you specifically mentioned the HIV. And then when you came to your specific objective, you left it only as STI. Maybe you should just stick with the STI in both the general and the specific objective. Do you have any other observation or comment? Let's take from Kinka. If there's any comment. The rapporteur will have 2-3 minutes and then we will round off. We hope they are rounding off at the other end because I learned there's still a plenary session here.
Thank you, sir. Okay, so to all presenters, thank you very much. I think you've done a good job. And one thing I noticed that was that referencing was not uniform. So I was seeing Harvard and I was seeing Vancouver. So I don't know, isn't there supposed to be a prescribed format from the association? I believe there must have been. So we should all just try to follow the format so that there is uniformity. Apart from that, thank you very much.
Okay, so Dr. Oindamola, just in about 2-3 minutes because of time. And I expect that they are running off at the other end and we've told them to come here. Thank you.
Thank you, Chairman, sir, and thank you to the co-chairman. For this parallel scientific session, we had a total of 7 oral abstract presentations, 6 physical and 1 virtual presentation. So because of paucity of time, I'll just mention the speakers. The first speaker was Dr. Kayode, who talked about, whose topic was violation and exercise of sexual and reproductive health rights among ever-married women in Ibadan Metropolis, a mixed method approach with his key findings. And the second was Dr. Adeyemi Akim-Amuda, whose topic was work-life balance, coping strategies, and psychological well-being of medical doctors in a tertiary health facility, Southwest Nigeria, with his objectives and recommendations. The third was Dr. Kingsley Okafor, whose topic was prevalence and pattern and effects of abuse of methamphetamine among students in Anambra State, with his results, and he has explained the first. The fourth is Dr. Adebayo, whose topic was factors influencing disease surveillance and notification practices among health workers in private facilities in Federal Capital Territory, Abuja. The fifth was Dr. Joseph, whose topic was dietary habits and nutritional status of pupils in public and private schools in Port Harcourt, Rivers State. The sixth, Dr. Cassie, assessment of prevalence and associated factors of occupational stress amongst secondary school teachers in Enugu Metropolis. And finally, Dr. Dimka, whose topic was the pattern of STI cases at the sexual and reproductive health clinic in tertiary health facility in Rivers State, Nigeria. Thank you to all the presenters. Thank you, sir.
Okay, so we thank all presenters. Can you step forward to take a picture? As they say in Yoruba land, Oniyan se, Olobe se.
Thank you very much for the presentations and thank you all for your patience. Please just oblige us to take our last plenary session for the day. Please, I'm inviting UNFPA to please come forward. Thank you very much. Give me the slide on male involvement, male involvement, male involvement, male involvement.
Please, can everyone come inside? People outside, please come in. We're about to start a very interesting and brief session. Please come in. Please come in if you are outside by the lobby, by the exhibition center. Thank you.
I've sent it to you. Are you ready? Okay.
Good evening, everyone. Thank you for
taking time to wait. I know we've had a very long day. We have this presentation. UNFPA is the Sexual Reproductive Health Agency of the UN, and our major goal is to ensure that every pregnancy is wanted, every childbirth is safe, and that young people achieve their potential. And we seek to achieve 3 transformative results, one of which is ending gender-based violence and harmful practices, of which we will be presenting one of our initiatives on this. So we'll be looking at engaging. I'm here with my colleague, Dr. Akin Akibaju. He's at the back there. He's our maternal health family planning analyst, and I'm the gender reproductive health analyst. We'll be looking at engaging men in sexual and reproductive health and addressing social norms. And this is something we have done, and it has yielded a lot of results. Engaging men in sexual and reproductive health while addressing social norm is a transformative approach to achieving gender equality and improving health outcomes. The UNFPA Male Initiative emphasizes the importance of involving men as partners, clients, and agents of change in this area. Our key strategies are inclusive health service, where we create male-friendly health services that encourage men to access care and support their partners to do same. Community engagement, where we collaborate with community leaders, healthcare providers, and organizations to foster environments that support gender equality and reproductive health. We also use the strategy of challenging harmful norms, where we focus on reshaping traditional gender roles and promoting equitable attitude, and this includes addressing stereotypes that discourage men from participating in family planning or seeking reproductive health services. And the last is education and advocacy, where we raise awareness among men about their role in supporting their partner's health and rights, as well as their own reproductive health needs. So the examples we have across the Inclusive Health Service Program is, the slide is not moving. Oh, okay, we'll move it from here. Sorry about that. All right, the example we have here on the Inclusive Health Service Program, we have men in ANC and birth preparedness. We implement this at the PHC. Men whose spouses enroll at the PHC are taken through a simulation of pregnancy and birth preparedness at 36 weeks. And this is to encourage health facility delivery and postpartum family planning. Also, we engage men as family planning champions at state and local levels, and this is to increase uptake of contraceptives. This we do as high as even to the level of the governor. We also have specialized focus group sessions with males and partners of young moms.
Having reported barriers to hand hygiene identified by this study.
All right. Also, we also have models in social change, where we have the Husband School. This is a community social and behavioral change intervention that is implemented at Niger State and in our northeast and northwestern states, that is designed to improve family planning and reproductive health and address gender-based barriers that contribute to poor health outcomes. We also have male models, and we have the E4She initiative with governors, legislatives, and traditional leaders helping to drive social norm change. Also, the impact that we've seen over the years is increased funding for family planning commodities, also increased funding to adolescent sexual reproductive health and in GBV prevention. We have increased uptake for antenatal care, family planning, and health facility delivery amongst our male beneficiaries. Championing social change. In the North, we've had delay of marriage of girls till 22 years, and we have the Sultan, who has publicly proclaimed that within his domain, anyone who marries off any girl would be banished. And for those who had violated, they have been banished, and girls have had this delay till 22 years before they get married. Also, the passage of the VAP law. We've had because of the male involvement, like I said, as high as to the level of the governor, where we've had the governor ensure that the VAP law is passed. Also, declaration of FGM abandonment. We know that FGM is still an enigma within some states in Nigeria. And with our social norm change engagements with the males, we've had declaration of FGM abandonment. And also we have community surveillance for compliance to FGM abandonment. I'm just going to show you, this is a picture of our husband's school, where the husbands will come in the evening after they've gone for all their trade, and you have a lead who will take them through in pictogram of what ideally the husbands should be doing. Also, we have the FGM abandonment led by the governor of Osun State, Aregbesola, during his regime. And this involves them signing a document that will be kept with the Ministry of Justice and also at the community level to ensure that truly they commit to abandonment of FGM. We also have signposts being put in those communities to show that those communities have indeed declared abandonment, and their traditional leaders also would sign their compact that they're going to comply with the abandonment. The role of Aphpn, we decided to bring this because we know that Aphpn is a body that could drive male engagement. Advocacy, there's need for advocacy at all levels. Development of states to support states to have state-specific multisectoral guide to male engagement, and also to research, to have research on impact of male engagement for sexual reproductive health and in addressing social norms. Thank you. Where is the moderator? Okay, I don't know if there are any questions, because I expect that to come from you. Okay.
Let's have our hands up so that we know the number we can take. I have just 1 and 2.
Okay, thank you very much for that presentation. I just want to ask a question regarding the age 22. So how did you arrive at that age? By age 22, I know very quite well somebody's already master degree holder. So why age 22? Having known that the legal age in Nigeria is 18 years. Thank you very much.
Thank you for the presentation. This is quite critical intervention for reproductive health uptake. My questions are, one, with respect to husband school, how did you find it easy to congregate the men? Because I know it's an Herculean task. I've been involved in an intervention that had to do with pre-survey and got. So I need the secret. Two, the impact you outlined, there's what exactly are the interventions that brought about those impacts? Because they can't be directly linked with the interventions you outlined or how you got those men. Thank you for a brief and beautiful presentation.
While we are taking the response, please, there's a missing ATM card, First Bank. If it is yours, please let us know. First Bank ATM card, please. Looking for the owner.
Thank you very much. How did we get the age of 22? Most of the males that are enrolled onto the program, their children, the age of their children as at entry into those programs, we get their age, and over time, this program I'm talking about, we just decided to condense it. It's something we had run over 3 years. And in 3 years, over 3 years, we realized that many of them, their girls, by the time they're age 22 is when they believe that the body is formed and they're ready to be married off. at that point in time, and that would have given time for those girls to have finished to an extent most of the levels of their education. So it's based on the cohorts that we had, that the average of delay of the girls being married of is age 22. For the husband schools, before we started, we did focus group discussion to get what their perceptions were. And because usually we have them as cohorts, and post that cohort, we also did focus group discussion to see the change that we have, and there are many variables that we have for the change for the husbands. Also, how did we get them? Like I said, the Sultan, we have the advocacy to the Sultan helped us because he believes in girl empowerment. He believes in women empowerment. And that was like having a charge by the Sultan or the emirs that we do engage, that this is statutory. So when you are coming back for the farm, there are scheduled times, and you must be available at those scheduled times where the husband schools are to hold, except if you have a pertinent reason. And we know very well that most community members have reverence for their religious and traditional leaders, and this is has been the secret for us as well in the program. Thank you.
We want to thank UNFPA very much for that presentation. Please, let's appreciate her again. Once again, thank you all for your patience. We do not want to take it for granted. We thank you. We have come to the end of the session for today. The activity for tomorrow will start by 8:30 a.m. So we'll let you know when the buses will start the hotel pickup. Thank you very much. Good night. Have a nice, good rest.